from the University of Applied Science in Utrecht in the Netherlands. And I want to welcome you to the special interest group, the SICK, Evidence-Based Integrated Care. And we have some fine presentations this morning, oral poster presentations. But we start with a small introduction in evidence-based integrated care. You see some names of the group who are in it in the Netherlands. What is integrated care? If we talk about integrated care, it's very difficult to give a definition about integrated care. But if we talk about integrated care, it's an integration of health and welfare services personalized for the patient. So you have to follow the context of each individual patient, and you plug in some content about care or welfare. And if you look at what is integrated care for civilians, then we have some questions. What is the starting point when a client is entering integrated care? What is recorded in a care plan with integrated care? And where is the care delivered? First of all, if we start with integrated care, it starts, of course, with a comprehensive assessment of what is needed, what is this patient or this civilian needs at this moment to participate as much as possible in society. And what is recorded in a care plan with integrated care, all these services which are needed, but in coordination. They have to be coordinated among different providers and settings. And where's the care delivered? Well, at home or as near as possible. So if we talk about personalized care, it's as near as home or at home when possible. So we have some perspectives shaping integrated care. If you look at in the middle, there is integrated care, but it is provided. Policymakers are involved, regulators, evaluators of care, the community, of course, service users, the civilian itself, managers who organize it, and care professionals. And then you see all these arrows, all these lines. And the whole point with integrated care is they are interconnected. And so there are lines between it. And that makes it so very difficult because you have to do it not only in a target group, but you have to personalize it. So that makes it very difficult. And if we look in the literature about integrated care, there's a lot of discussion and there is a lot of debate in defining it and in what we understand about integrated care. But it's, of course, a seamless care provision. And following triple aim, quality of life of the citizens, quality and continuity of care, and cost-effective care. But the problem is if you want to doing research, you want to do research in integrated care, it's narrowed by the lack of a comprehensive definition. So if you look at integrated care itself, it is aimed at well-organized, cost-effective. It must be a process of care delivery, and it must be cost-effective. And it's, of course, provided by committed professionals. And these professionals must count on well-established evidence, of course, for the care they provide, in integrated care trajectories. It's very, very good to understand it are trajectories, it are pathways, care pathways to their patients. So if we are doing research in integrated care, we are doing research in a context. And we are doing research on content of care applied in context. And if we look at the WHO definition, they say, well, let's bring together inputs, delivery, management and organization of services related to diagnosis, treatment, care, rehabilitation, health promotion to improve services in relation to access, quality, user satisfaction and efficiency. This is a definition which is very much focused on the organization of care. But if you look at evidence-based integrated care, it's also about evidence of the content and evidence of the application of that content. And then we come to another definitions. And we added the red points with the last years, with many people involved in integrated care. And then we say defining the care problem by identifying working mechanisms. How does things work in practice? Collecting existing effective intervention or develop these. And then we go back to the definition of WHO, which is in black, bringing together input, delivery, management and organization of services. And then we added test acceptance by patient, care providers, the care system, and the rigor of an evaluation study. So it's very much important to focus on that content again and the application of the content. We go back to the WHO definition related to diagnosis, treatment, care, rehabilitation, health promotion, and that's what we added with the group to test the effect of an evaluation study or practice research and or theory research oriented. And then at the end to improve services in relation to access, quality, user satisfaction and efficiency according to the WHO. And we added enabling the working mechanisms of the intervention in the organized context in clinical practice. And then you see there is context and there is content, and that must you combine that to achieve quality of life and the societal participation of citizens by personalized and cost-effective preventive primary, secondary and tertiary care. So this is our special interest group on the website of the IFIC. And if you want to join the group or just add something, please be welcome. This is the special interest group, evidence-based integrated care. So we are talking about, and we are doing research in providing evidence on the content, evidence on the application of the content of care in the context of the personalized context of the patient. I want to introduce to you the next speaker. I have to go back. That's Anne. Let's have a look if I can do that. Yeah, that's working.
Okay.
It's coming? Yeah, it's coming. Wonderful, wonderful. Yeah, thank you so much. Okay, and the floor is yours.
Thanks so much. Thank you. Good morning, colleagues, and it's a pleasure to offer some insights and evidence from our work in Scotland to add to the weight of evidence that the Special Interest Group is taking forward. The context for our work in Scotland, I hope, is familiar to many. This is not the first time that it has been shared at this conference. Universal coverage with no co-payments and fairly unified primary and secondary care context, but at the point in time that we took forward this work, we were not horizontally integrated across health and social care. Similar challenges to many systems across the world with an ageing population and a diminishing budget. And the burning platform that was developed was very much around a policy of reshaping care for older people towards home-based care, care that was personal and closer to home, and a realisation that if we continued doing what we were doing, institutionalisation was going to require an increase in emergency beds to the extent of opening a new district general hospital every 3 years, opening a new care home once every month, and that was not feasible, and it was certainly not desirable, and it was not what the older people of Scotland wanted. So we took forward a programme of reshaping care for older people, a transformation programme where we began to flip the paradigm, flip the pyramid with a focus on promoting well-being and building community capacity, supporting people to stay well and integrating health and social care and support. This was oiled by a 300 million change fund, an innovation fund that was for 4 years. So I'm now presenting not the results at the end of the 4 years, but at the end of 2 years after the conclusion of the change fund. Are we holding the gains? One of the innovations was to shift the locus of care from hospital and institutional care setting towards more preventative, anticipatory care in community, and to shift the focus of care from reactive to much more preventative care, supported by a range of enabling actions around organisational development, workforce development, technology, finance, the usual strategic enablers of change. It was taken forward as an improvement programme where we were supporting change at the point of care and at delivery through an improvement network, which was a cross-sectoral network, a network that brought together health, social care, housing, NGOs and independent provider partners from across the country. We focused on each of those pillars of the pathway, on prevention and building community capacity, on supporting and strengthening the resilience of our informal and unpaid caregivers, and had a particular focus on the prevention of falls, recognising that that was an important evidence-based intervention for older people. We aligned work on anticipatory care planning, thinking ahead, personalised care plans that set treatment goals, and we linked that with work on pharmaceutical care and new models of realistic medicine to help reduce unwarranted and inappropriate polypharmacy. And we grounded this in the context of primary care, where we were promoting that interdisciplinary practice across the primary care team and extending the primary care team to include third sector partners, social care partners, and to provide continuity and coordination of care. And a shout out here for the World Health Organization practice brief on continuity and coordination of care with many global examples. We recognised that you could have a perfect system in primary and community services, but it all unravels in the evening and at weekends if there is no realistic menu of alternatives to hospital care when somebody's condition escalates. So we invested particularly in models of intermediate or transitional care that offered a rapid response to crisis, or an early supported discharge, or more recently, what we describe as hospital at home services, as well as step up, step down community beds. And finally, we invested systematically in programmes of improvement within hospital and care home settings as well, really working right across that care pathway with a particular focus on dementia, delirium and frailty. You can see here that the chart shows what we would have expected in terms of anticipated hospital bed use, emergency hospital beds occupied by older people had we not changed. And we're able to see that beyond the conclusion of the Change Fund, we're still holding the gains in terms of every day in 2016-17, 1,500 older people not occupying an emergency hospital bed, 1,500 older people able to be supported at home. Importantly, not shifting from hospital to care home. This is the same graph showing the older people that were not occupying care home beds compared to what would have been expected had the age-related rate continued. Every day in 2017, 7,200 older people not in institutional care, but being supported in their own home. When we put those statistics together, we see that older people in Scotland, by the 2 years after the conclusion of the Change Fund, were spending around 3.2 million more days at home, quality time in their own home with their own family support. That equates to around 480 million per annum institutional care costs avoided, not saved, but institutional care costs avoided and released to be able to invest in community services and support. We had a phrase at the beginning of this programme. We said, we have to big up the blue. We have to have more people who are not in receipt of formal statutory services, more people who are supported to live well with community and informal supports. And here you can see that, yes, we have achieved that over the period of the programme. Some of that progress has been achieved through the strategic use of technology to enable more assisted living and support at home. And here you can see a rise in the proportion of people in receipt of telecare who are not in receipt of social home care. The ability to continue to hold the gains beyond the end of the funding programme has really been enabled by the policy lever that was then pulled, the legislation to integrate health and social care across Scotland, and to do that not just for older people, but for adults. To use strategic commissioning and planning not just at a partnership of health and social care, but also at a local population level, to be able to invest in the services that are evidence-based and deliver the change. And delegating an integrated health and social care budget, which was available to the commissioners to commission the outcomes that matter to that local population. Over 60% of the adult and older people health and social care budget now delegated to the integrated authority to commission the services to deliver the change. Beginning to integrate our data to be able to track the changes in health and social care utilisation, and integrating around a common patient identifier, a community health index for every citizen, which is now linked with social care data. And also now, more recently, levering change and continued improvement through a new GP contract, which is much more focused around person-centred, integrated care and coordination across that interdisciplinary team, with everyone working at the top of their licence and the GP being the expert generalist in complex and chronic care. So I guess if we're looking back to where we've got to across the programme in Scotland, we've pretty much pulled the levers and enablers that are highlighted in the European Commission report from 2017, the blocks support report that identifies the strategic enablers of change in integrated care. Creating cross-government support, using funding as a catalyst for change, introducing both social and technological disruptive innovation, investing in prevention and community capacity building, particularly valuing the support of informal carers as full partners, a real relentless focus on place, home, community and outcomes that matter to people, and taking this forward through a learning and improvement culture. Tapping into the professional leadership, particularly in the primary care community, and promoting interdisciplinary practice and distributed professional leadership. Using legislative levers to promote integrated strategic planning and integrated budgeting, and then introducing some new contractual levers in more recent years. If you want to hear more about the programme and some of the outcomes, then here's some of the references that you can access. Or tap into our Integrated Care Matters webinar series, which is available on the IFIC website, and you'll get some examples of some real changes on the ground. Yes, I think we are beginning to hold the gains from reshaping care. I'm not entirely convinced that it's as yet full transformational change that is dramatic, irreversible, and is taking us to a position of financial sustainability. I think we still have some way to go yet for that. My own belief is that we need to face up to frailty to really get to that transformational change, because not all older people are equal, and we now recognise that our frail older people are the population that we really need to tackle and get to grips with. And this is a bit of a shout out for the Face Up to Frailty workshop at lunchtime, and also for the Advantage Joint Action presentation tomorrow, where we're working across Europe to identify a roadmap to transformational change for frail older people. To really make the change and hold the gains, we absolutely have to get further upstream. We have to tackle frailty, but we have to create active and healthy ageing communities. And I think this graphic from Public Health England, published this month, really captures the essence of understanding the importance of social connectedness, meaning and purpose, resilience, and tackling loneliness and isolation, which are such a public health challenge to our society. And I guess my vision for the future in Scotland is to move beyond reshaping care, to continue to hold the gains, but to reach towards a decade of action on healthy ageing, and to be part of the WHO global movement, and to perhaps one day see Scotland being one of the blue zones in Europe and in the world. Thank you very much for the opportunity to share our work.
No questions? No? Okay. And thank you so much. Gaia, it's your turn about lessons learned from sustainability. The floor is yours.
Hi everyone, thank you so much for being here and helping us start off this conference. So, let me begin with a quick introduction to Ontario. So the province covers over 1 million square kilometers, and it has a population of about 14.5 million people. Now, about 80% live in urban areas. Now, it does have a rather bureaucratic health system. Health policy is set by the Provincial Ministry of Health, and it's implemented by regional authorities called LINs, or Local Health Integration Networks. Then you would have CCACs, or Community Care Access Centres, and they would be in charge of actually contracting with other home care organizations to actually deliver the care. Now, CCACs were recently restructured, and they now are under the more direct umbrella of the LIN. Now, the province uses a combination of sources to really fund healthcare. So you have HBAM, or the health-based allocation model, and this makes payments based on patient contexts as well as hospital costs. And then there are global budgets, which provides fixed payments for a specific a time limit. And then there are volume-based payments for quality-based procedures, or QBPs. And these are payments made on a price times volume basis for following standardized best practices. So the province is really trying to move towards linking payments to better quality and value. And the integrated funding model, or the IFM, is one attempt to really accomplish this. So the IFM really requires people across professions, across organizations, across the acute and post-acute sectors to come together to collaborate while working with a predetermined amount of money. And the objective is to provide care for patients, and in this case, for 60 days post-discharge. So partners are just expected to transfer funds to a commonly held bundle or to each other that correlate with the expected use of a specific service or group of services. And so partners would be responsible for extra costs, but they would also get to keep any savings that are accrued as a result of this process. So the hope really is that efficient care transitions, monitoring at home, and encouraging self-management will eventually reduce the length of hospital stays, provide better support for the patient at home, whilst also reducing readmissions, hopefully, and hopefully costs overall. So in 2015, the ministry invited expressions of interest from acute hospitals as well as home care organizations who were interested in coming together as a group to deliver these models. So they received 50 submissions and they ended up selecting 6 of them, and these became the original 6 pilot programs. Now 3 focused on chronic obstructive pulmonary disease and congestive heart failure, so COPD and CHF. So the map here shows you where they're located in the province. So I'm going to be focusing on these 3 programs specifically and how they reimagined integrated care, even as they, delivered it. So we conducted 36 interviews, so 12 with each program. I'm not quite sure how to go back. Okay. So the first 18 were done when programs were first implemented in 2016, and the next 18 as programs matured last year in 2018. So we included program leaders, managers, and clinicians, from physicians to integrated care coordinators. So this was across the hospital and community spectrum, and you see the numbers broken down here. So the transcripts were anonymized, they were coded, and they were analyzed using a cultural constructivist lens. So we were really interested in what mattered to programs and how programs were developed in response to unique conditions, as well as how they then went about tweaking these conditions and transforming things as they went along. So Program A. Program A involved 2 hospitals, a family health team, and a community care access center, so the CCAC. The program found it difficult, really, to agree on a price for the bundle in advance, and this was because the CCAC was unable to project a figure for the community care component of the bundle. And this was because they had really been providing care for a subset of patients all this time, whereas now they would be expected to provide care for everyone. And furthermore, even if 2 patients receive the same level of care in the hospital, of course, their needs in the community would vary depending on social complexity and that sort of thing. Now, the 2 main hospital and community partners had a pretty well-established relationship, and they had a mutual appreciation of quality improvement cycles. There was an understanding that this would take time. So they both agreed to wait and reconcile on a quarterly basis, based on actual data after maybe 20 or 30 patients had actually been through the program. Now, 2 years later, the partnership was thriving, and partners had really reconceptualized the funding component of the bundle. So partners had signed a gain and risk-sharing agreement, and basically partners agreed to put money into a shared pot that was proportionate to their savings. So the plan was that this would then be reinvested to forward other bundled conditions. So as a hospital leader explained here, it was really a gain-sharing and risk-sharing model that we wanted to do as opposed to a bundle. Now, what other hospitals did, and I personally thought that this was the wrong way because it creates an us versus them notion, other organizations were taking money away from the CCAC and pulling it into the hospital and then providing that service or vice versa. And I wanted a partnership model. So during its first year, the program generated a paper gain, and because despite a reduction in hospital length of stay, beds couldn't be closed because it would just be occupied by someone else. Now, for some in the LIN, this didn't really matter because patient outcomes were so phenomenal, but others disagreed. So a LIN employee, for instance, complained that there was far too much emphasis in her own organization on the transfer of money, and there was very little acknowledgement that they were now able to basically serve far more people for less money, or at least for the same amount of money. Hospital participants agreed with this sentiment, right? They basically said the LIN didn't get this model. So the LIN kept pushing us. What are your financial outcomes? When are you going to bundle? When are you going to do this? When are you going to do that? And the community partner and the hospitals at the time said, our model is different, like leave us alone and we'll get there. So she went on to say, this is really not a savings strategy. And I think if we think it is, we're fooling ourselves as a province. In the long run, however, it is going to save us oodles of money because it's cost avoidance. Now, the IFM was also funded through the transfer of quality-based payments, or QBP funds, into the bundle. So in order to qualify, IFM patients had to meet stringent QBP eligibility criteria for COPD. But of course, other comorbidities might come into play. So by the end of their care journey, patients might not be COPD qualifying QBP patients. So this meant that hospitals had to scramble to figure out where to transfer funds from. So as one participant suggested, a more global funding approach that did not pigeonhole patients into specific funding pots would probably better address clinical complexity. And someone else suggested perhaps instead of having a COPD navigator, they could have a general navigator that followed them for all their needs. So moving on to Program B, this was the most ambitious in scale. It reached LIN-wide and it included 15 partners. Now, its bundle holder that managed the funds was also the hospital that had pioneered this approach at its own site, and then it was spread across the province. Now, this program had very strong leadership. It had a pricing model that accounted for different risk scenarios, but unlike other programs, the coordinators at this one had to really figure out, often on the go, how to put in processes that accounted for this large scale. So in the words of this coordinator, every hospital has a different set of rules, a different set of union rules, a different set of ideas about how they could function. There's a lot of opinion in everything you do, and every decision you make now needs to go through 9 hospitals. If you want to change a weekend rotation for the coordinators, you have to have 9 hospitals agree, and guess what? They don't. So participants found early on that one of the main challenges of implementing such a large-scale program was really negotiating differences in practice, size, location, experience, resources, you name it. So some had more stringent privacy cultures than others, right? Some were teaching hospitals, others served much more rural patient populations, and this would then require coordinators to traverse large geographical distances to provide care. So now 2 years later, there was an even greater appreciation for the differences across hospitals, as well as the additional complexities of scale. Now, the lead hospital had gone from an organization of 12 co-staff, where everyone knew everyone else pretty well, to about 70 or 80 providers who were struggling to identify who was the appropriate person to talk to during virtual rounds, for instance. And there was a new realization that there were components of the model that really could not be standardized because of these significant differences across organizations. And there were a couple of smaller hospitals that really they were forced to stop running the program just because of smaller volumes. And there were also complaints about uneven buy-in at this point. So participants were now in the process of discussing how the model could be extended from 60 days to 1 year, or perhaps even beyond. Now, this was partly in response to low enrollment rates because some patients had been reluctant to participate in the program because it would have meant giving up their existing PSWs, their personal support worker, that had been provided to them by the CCAC for the length of the program, and then perhaps have to deal with wait lists to get another one, and there was no guarantee that they would be given the same person. So they were refusing the program as a result. There was also a renewed awareness that people with chronic disease really needed ongoing monitoring. So the lead hospital was now considering a restructuring of the bundle so that each hospital would have greater autonomy and some sort of fiscal responsibility for the care they provided. So as you see this participant saying, I think how we structure the bundle going forward will be very important. We're big. We have 9 hospitals who are part of this. I think in the long run, we need to ensure that each hospital keep those bundles within the influence of the organization. Because if our cost per patient was much higher and we weren't performing as well as another hospital, the challenge with the way the bundle is structured now is that it averages out across everyone. So there's, in theory, a little lesson center for hospitals to be really pushing the envelope and to be innovating because they just don't get as direct an impact from that, right? So it was really just this move for more local autonomy and control over this bundle. So moving on to Program C. So Program C included an acute care hospital that acted as bundle holder, a chronic care and a rehab center, as well as 5 community partners. Now, during the early stages of program design, the hospital had been rather surprised to discover that only a small percentage of patients in the community were getting care from the CCAC. And this was partly because of the many layers involved and partly because of the lack of a feedback loop back to the hospital. So the hospital was very concerned that patients were getting lost in the community once they were discharged. So it decided to deal with this by applying for community service status, and this would then allow them to basically contract directly with these service providers and pretty much bypassing the CCAC. So this was, this made hospital participants rather happy because they had a new sense of control and autonomy now. They quite liked having a feedback loop to the community that let them know exactly what extra services were being delivered, whether specific patients perhaps needed different sorts of services, where extra costs were coming from. When the patient returned to the emergency department, the hospital had a very good sense of what care had already been provided, and they had a good sense of the history of these patients. And both partners, the hospital and the community partner, developed a trusting relationship over time. So the hospital was able to also have a respiratory therapist who acted as a coordinator, and they were able to build a better relationship with the respirologist. And this was something that the CCAC simply had not been able to do. But now, 2 years later, the hospital's community service status expired. So now it was unable to financially sustain the coordinator role as well. So this meant that the program had to revert back to a CCAC-dependent model of delivering care. Now, by this time, the CCACs had been rebranded Home and Community Care. So one participant spoke about the move back to working with home and community care is both a blessing and a curse. It was a blessing because programs had been facing low enrollment rates here too, right? Because patients were reluctant to give up their existing PSWs, and this would no longer be a problem. But it was a curse because the quality of patient care that was being received in the community was once again suspect, at least in the hospital's eyes. So as this participant says, what we realized is that if I'm Mrs. Jones and I've had Susie Q as my PSW for 6 months and I like her and I'm comfortable now that she sees me naked in the bathroom, I do not want to switch and I say no thank you. And therefore we can't take on anybody. But with home and community care, you're not going to get an educated, trained pool of people because our project is all about education. You can't ask, what module are you teaching? Oh, you're teaching module 4 this week. So you wouldn't have that kind of control. So hospital patients were worried that the acute and post-acute care sectors would be behaving like separate entities once again. They found it very challenging to discharge patients without knowing what would happen to them, without being in control of their care post-discharge. They really wished that integrated care had been sustainable for them, and they wondered if perhaps a different structured way of doing things in the community sector could have helped. And you see the sentiment here. So just like the QBP standardized pathways ensure best practices in hospitals, I think the community also needs to have some standardized pathways, especially for these elderly chronic disease management folks. So from dietary to pharmacy to transportation to social issues and all those things. So this widening of the care network would ideally be accompanied by a lengthening of the bundle, perhaps starting at doctors' offices in the community, for instance, and certainly expanding it beyond its current 60 days to, probably ongoing standardized monitoring of these patients to ensure that their medication, their diet, their pharmacy needs, their appointments are all in order. So as one participant said, we really need to start thinking about our patients as patients and not as diseases. So regardless of the unique challenges faced by individual programs, participants across these programs were suggesting that to be truly sustainable, programs had to be reimagined. And this theme was articulated in a number of different ways. You see this in these quotes. So this is someone from Program B. We see so many times different providers going into the homes of people who are living in poverty with nobody and terrible conditions, but they're there to provide wound care or to teach about heart failure and those things. But they're not looking at what they're living in, and they don't have heat or food. It's not that person's job, and that this isn't just about the IFM. It's like the whole concept needs to be different. Someone from Program C. There's different ways of doing it than we're doing it now. I think by using existing community services like the YMCA as an example would be important to do. If we look not just through the lens of the Ministry of Health, but the Ministry of Recreation, the Ministry of Housing, you know what I mean? Like breaking down all the silos across the system. And someone from Program A, I'd give their acute portion up to 60 days, but I would keep them with a navigator forever. It's the right thing to do. What if we did a navigator and a nurse and a team on all COPD patients that walked into this hospital and they were followed? Think of the difference that's going to make in the long term for the healthcare system. So, to summarize, program participants made a number of recommendations. So instead of linking funding to single conditions, consider a more global approach, and this would hopefully better address clinical complexity. Adopt a long-term view of financial benefits. As one participant said, this will definitely save us oodles of money in the long term. Then connect patients to other programs and community spaces. Then extend the tenure of the bundle well beyond post-discharge. And finally, promote accountability by encouraging local level ownership of the bundle, as well as somehow standardizing pathways in the community. So now these are all ideas that call for a complete re-envisioning of integrated care in a way that's holistically, spatially, and temporally more expansive for the patient, but at the same time, more accountable and predictable for those delivering this care. So on the one hand, sustainability was contingent on having control, having autonomy, having predictability and accountability. And you see this with Program A, right, who opted for a retrospective gains and loss sharing agreement as a way of really exerting control over financial uncertainty. And then you have Program B, that wanted each hospital to have greater autonomy and fiscal responsibility across a shared bundle. And then you have Program C, who wanted to work directly with a new community partner, again, as a way of exerting some form of control over what was happening in the community. And on the other hand, sustainability was also contingent on a re-envisioning of patient care that went well beyond the scope of the IFM as it was originally defined. And imagine, really. So participants wanted patients to be approached holistically as patients with multi-morbidities, with both medical and social needs. They wanted them to be linked to other resources and other programs as needed. So this would really mean extending the spaces of care beyond the hospital to envelop spaces that have not traditionally been seen as within the purview of healthcare, right? So spaces of residence and leisure, for instance. And finally, it would mean an extension of the tenure of care well beyond the 60 days to ongoing monitoring that, kept on going with the patient potentially. Okay, thank you.
Gaia, thank you so much. Are there questions for Gaia? Nobody? Gaia, thank you. Is Sarah? Oh, yeah, yes. There is Sarah. Wonderful. Close, yeah. About challenges implementing and delivering integrated care. Yeah. Okay, good luck.
Okay, good morning, everybody. Thank you very much for coming along. My name is Sarah Barry. I'm from Trinity College Dublin, and I will be presenting this morning with PJ Hartnett, who is from the Integrated Care Programme for Older Persons in Ireland. And just to say that we both have wonderful teams behind us, PJ with the Health Service Executive and me in the Centre for Health Policy and Management in Trinity College Dublin. So we're going to do a sort of a two-hander here. I'm going to speak a little bit about the policy context for a moment in Ireland and how we're aiming to have a systemic or systems-based approach to integrated care. And that's under the auspices of a drive towards universal healthcare in Ireland. PJ is going to talk about the lessons that are being learned in practice with the integrated care programme for older persons. I'm going to briefly present some findings from a case study work that we have done in collaboration and co-designed with the ICPOC programme, and then we're going to just pull out some conclusions. So just briefly, the policy context in Ireland, just to give you a little bit of background. So some of you may have heard, but in Ireland we have an all-party initiative currently underway to transform Irish health and social care services, and it's with the intention of turning Ireland much more towards a universal healthcare system, which it currently is not. And there's a couple of approaches that are outlined in that, if you like, government report, or Oireachtas. Oireachtas is our Houses of Government report, and that is to set out a population health approach to how we are delivering on a universal healthcare agenda. That will involve expanding entitlements, creating a proper kind of funding framework that will offer better security, and obviously then confident implementation of this very broad programme of change. But at the heart of it is a service delivery model of integrated care. Now, the approach of sláinte care, which means health care, your health, is to take a very whole of systems approach. So in sláinte care, it means integrated care means system strengthening. So some of the kind of things that other speakers have spoken around, creating the right kind of conditions that will deliver integrated care. The service coordination piece is the piece that I suppose we've done the most work on, and PJ will be talking a little bit about in a moment, and then very much leaning that shift left to that network building and that community integration that some people have already spoke about this morning. And then finally in 2019 we have some concrete implementation actions around the delivery of integrated care taking place. These include an integration fund. I was just mentioning to PJ when I heard Anne speaking about 300 million. We look very poor. We have a long way to go. But anyway, we have a start and we're doing something to test and scale new models of care. There's a focus on integrated workforce planning, getting the right information architecture and standards in place, and then the creation of a little bit like the LINs, the Regional Integrated Care Organisations, or RECOs. So we have quite a challenge around the geographical and the organisational alignment. So I'm going to hand over to PJ, who's going to give you a bit more the meat on the bones from the ICPOC perspective.
Thanks, Sarah. Yeah, it's always with great envy that we look across the water at Scotland and look at the work that they're doing. So we've learned a lot and benefited, I think, from the work that Anne and her colleagues have done. I'm going to talk briefly about the implementation aspect of the work that we've been doing, and it's been great to partner with Trinity and Sarah and her team in terms of understanding, getting insights into the process of implementation and what that looks like from the point of view of the people who are tasked with implementation. We have a website, icpop.org, which contains a lot of material, videos, presentations, and in December 2018 we launched Lessons Learned, which was an insight into 2 years of implementation with sites who are seeking to develop integrated care for older persons. We currently have 13 sites across Ireland who are working on this. We've grown from 6 in 2016 to 13 last year, with 8 or 10 new sites in the pipeline. And it's a way of working that appeals to people. And it involves many of the ingredients that are familiar to people who are working on integrated care internationally. So it involves the deployment of case management, it involves new ways of working for people in terms of community roles, working at the top of their licence, it involves the development of new pathways and age-tuning the service. And so some of the impacts that have been delivered over the last 18 months to 2 years are available within that early stage insights report. Our team, it's a very small team. Its primary purpose really is to work with local clinical managerial leaders in terms of using a 10-step framework to develop care pathways and implement new ways of working, etc. I'm not going to go through all of the detail of that, but a lot of the messy reality of implementation involves working with people at the coalface and addressing many of the issues that you heard about from the Canadian example, whereby the lived reality of changing the way people work is often an incredibly difficult struggle for everybody to address. So typically our involvement lasts about 18 months when we are seeking to work with local leaders on this process. This is a slide that depicts one of our sites, which in terms of McDonald's, the fast food outlet, has a term, leading edge operator. So this is one of our leading edge operators, one of our 13 sites. The kind of change that they've delivered speaks to both a cultural change, experience of care, value in terms of efficiencies and so on and so forth. 2 years ago, this particular site struggled to recruit registrars. Last week, they interviewed 34 registrars for 3 posts. For every euro we've invested in this site, there's been a return of investment of around €7. The bed days saved have been significant. The alignment of previously disconnected services in the region, which were orphan services, often standalone, bringing them into an overall ecosystem of care has been incredible. When you look at the issues around access for older people seeking to access healthcare in Ireland, one of the really big problems we have is that older people default to emergency departments in order to get the care they need, and that's not what we want, and that's certainly not what older people want. The number of people who default to an emergency department who are over 75 in this area is about 5%, and that compares with about 20% typically in other areas. So what we're seeking to do is to take some of the insights from this site and from other sites and scale that up. So in 2014, the number of areas around Ireland which had age-attuned pathways, which were working on the issue of addressing bespoke pathways for older people, was actually diminishing. The number of people working in specialist roles were diminishing, and the actual energy and effort and enterprise associated with developing pathways was actually on the decline. And at the end of last year, when we looked at the number of places that were working on one or more aspects of age-attuned pathways, it started to demonstrate that this kind of work has really caught people's imagination nationally. So when we looked at the insights around the work that I've just described, we were very interested in some of the kind of things that Scotland had to say. The idea that you put the citizen first, which was kind of emerging out of the Christie Commission in Scotland, rebooting public services to think about their fundamental purpose and reason for being. The needing to describe what it is exactly that we're seeking to scale up and what measures are appropriate that are associated with the kind of functional gains that older people want, as opposed to the organisational gains that are often a kind of political focus. So in our report, we've made some suggestions about what route to scale, the kind of methodology associated with scaling in terms of complex adaptive system as a kind of context for the change, and how all of that might be incentivised. And we've got a benign policy context now that we didn't have before. And these are some of the insights that are reflective of the kind of implementation science literature that we're reading, which is that methodology really does matter. The way you approach a change is fundamentally important. The command and control approach is not really one that's appropriate for a complex system where you have high autonomy actors who can decide whether or not to engage. Like politics, all integration is local. Everybody needs to feel that their version of integrated care really is something that is unique to their particular area. The timeline between expectations and improvement is also something that has to be carefully managed, because there are often emergent and iterative and unanticipated benefits and initiatives that emerge. A foundational aspect of what we do is around local governance. Whilst we have an integrated health and social care system in Ireland, very often people are held accountable for institutional performance as opposed to the needs of the population. So establishing local governance and getting them to focus on populations as opposed to institutional priorities is a real key to some of the work that's been done. And the other final point on this is that people really do know what it is that they want to achieve. They get it, they understand, they have a vision, but they often don't have the means to realise that ambition and vision. So a relatively small amount of money tends to be sufficient for them to be able to reorganise what they do, provided you give them the autonomy to be able to do so. Sarah.
Thanks, PJ. So as part of our work with the Integrated Care Programme for Older Persons, we conducted a case study of 3 of the pioneer sites, and I just want to give a shout out here for Maeve Nia-Loon, who is our researcher who worked, if you like, on the participant observation and rendering the text of this research. So we have a couple of, I suppose, key findings that came out of that work, which was conducted over quite a number of months in 2018. And that is that the multidisciplinary team is absolutely fundamental as a mechanism of integrated care delivery, both in terms of the team members who are driving the changes, their ownership of the, if you like, the vision, but also in terms of challenging the status quo of the way things are done and shifting those professional boundaries, which they can be quite a challenge in trying to do things differently. The multidisciplinary team progress can definitely be constrained by systemic or organisational factors, as PJ has mentioned, and he's highlighted the importance of that person-centred approach, if you like, first. Nonetheless, I think there is an argument for thinking about the tipping point. It's well known in change management literature that if early adopters don't begin to find, if you like, the conditions and a system that's, if you like, able to move with them in due course, then they become fatigued and disillusioned, and no real change happens. So I think one of our big questions around scaling is how do we start to overcome the fragmented funding structures, the lacks of multi-annual funding. There's quite an issue with the turnover of senior decision makers, and therefore, if you like, that not only the kind of political cover, but also the organisational policy perspective, the strategic direction. How do you get continuity there? And then obviously a range of complex professional contractual negotiations. And then with the Integrated Care Programme for Older Persons, we've basically coming to the conclusion that this really does have the potential to be a new approach to health system reform, at least in the Irish context, which generally health system reform has been very understood as, rearranging the structures and changing things, whereas the integrated care approach is very much bottom-up driven. So embracing the complexity, as PJ mentioned, really highlighting context and working across the community. So I think the general message here is that we're finding from our case studies that the contextual factors are critical, not only at local, which PJ has pointed out, but also at programme and system levels. Now this slide, just briefly put it up here for a second. This was part of our case study work. We did a survey with all the participants in the ICPOC programme. And I just want to highlight, this is data, rich data that I'm currently writing on and delving into in more detail. But what I do just want to highlight here is that we have 2 issues there. We've got a number of responses. And you can see that the big issues here that people were talking about a lot were cultural and organisational in terms of a balance against some other issues. And these were both weighted, if you like, as a sort of strongly or a moderatively negative impact on progress to implementation. And I think we need to sort of drill into this and understand a little bit more in detail, but it does highlight how important context is in driving change. change. So some of our findings from the case study in general, as I've just said, context matters as a bottom-up driver of implementation. And the multidisciplinary team both characterises and drives implementation, and that to some extent can be a double-edged sword with both sometimes positives, sometimes negatives there. The challenge of generating community leadership in a fragmented public-private mixed system as in Ireland. So one of our big challenges is we've got a very complicated mix of public and private provision with a lot of perverse incentives. This is something we're going to have to overcome to really implement integrated care. The importance of a population mainstreaming approach for implementation at scale, which I think one or two other speakers have highlighted very clearly. And then obviously, you know, how do we get that right balance of ownership and innovation? So in other words, capturing all the good of the local whilst also scaling to the global. And then there are a lot of positive that come from a lot of positives from focusing on understanding and working with the complexity, with the local context, and with the community. So, in conclusion, we have a couple of points from both of our perspectives. Will I just fire ahead with them? Yeah, and PJ, I'll give you a minute if you want to say anything more. But basically, to sum up, implementation methodology is absolutely critical, and somehow that methodology has to be able to do what we call the down and dirty. The multidisciplinary team can be an antidote, and excuse me, a powerful antidote to the system fragmentation that we have experienced in Ireland, but that is a very long journey, I think, and those teams are going to need serious resourcing and support. The policy context is fundamental, and I just highlight there that we really need to be clear on the theory of system change that we are assuming or that we have working behind. And we all know that the operational cycle and the policy cycle turn at different paces. Users as an asset in co-production, and this is really, really important that we bring the clients, the patients, the carers, all these people on board in terms of making the change that we need. Finance, as we know, needs to be dynamic. It's absolutely critical. I'll let PJ make his point on ICT here because he's down and dirty with that one, most definitely. And from my perspective, I think from a policy analysis perspective, ICPOP potentially offers a model of bottom-up, top-down dynamic of system reform by focusing on patients' needs first. So, if you like, integrated care in the universal healthcare perspective, which is where Ireland is at from a policy view, is what it looks like on the ground, and it has great offers to lesson on how to deliver in practice. And I'll just let PJ say a word on ICT. You're fine. Okay, great. We'll finish at that, and thank you very much for listening.
Thank you so much, PJ and Sarah. Are there questions? No? Thank you very much. Thank you so much. Wonderful. Oh, there's a question.
Gracias. Sí, muchas gracias y felicidades por la presentación que han hecho. Yo tengo dos dudas, dos preguntas que me gustaría que me contestaran. La primera es si y cómo valoran la dimensión de las residencias y su ubicación, por un lado. Y segunda pregunta sería, ¿hasta cuándo están ustedes, en qué porcentaje tienen implantado el sistema de libre de ataduras? Gracias.
Is there somebody here who can translate this? Oh, you have understand?
Yo hablo español, pero no entendí todas las preguntas. Por favor, ¿me puede dar muy concisamente para que pueda entender un poco mejor?
Sí, me refiero a ver cómo valoran y en qué dimensión tienen el concepto de la dimensión de las residencias. Pueden ser muy grandes, Pueden ser muy pequeñas, muy medianas. ¿Qué tipo de residencia es la que considera usted la más adecuada, no solo por su dimensión, sino por su ubicación? Y la segunda pregunta era, hay un sistema de libre ataduras, que las ataduras a los residentes pues pueden ser químicas o pueden ser...
Bueno,
está claro, ¿no?
A ver si entiendo. Ataduras no estoy segura qué es, pero tal vez alguien me puede traducir. La primera, por Irlanda, lo que estamos trabajando, si he entendido bien, son poblaciones de 50.000 personas. Ahora, el ICPOP, el programa en que PJ está involucrado, son proyectos pilotos de quizás poblaciones. What size are the populations of the projects that you work with?
Each of them typically 100,000.
Más o menos el proyecto en que está trabajando él son 100.000 personas por proyecto, pero tienen una manera de trabajar que está enfocado en la gente con necesidades complejos. The complex care needs, isn't it, that you focus on? So the complex care needs. La segunda pregunta, perdona que no entendí la palabra exacta. Si alguien me puede dar una traducción, puedo responder. Si no, hablamos afuera del auditorio y tal vez nos podemos entender un poco mejor. Gracias.
Can you summarize a little bit for the non-Spanish audience?
Okay. Sorry. So just been asked to just translate that a little bit. I think the question, and I may have misunderstood, so I'm sorry. Also, the sound is not great here on the stage. But I think the question was, what size populations are we working with in our units of organisation? So they're community health networks of 50,000, and then PJ through the integrated care programme, the pilot projects are with populations of about 100,000 persons, but they do take a focused approach around the people with most complex needs. And I think that for that reason, the referral process is very important, very critical. But that's really PJ's bailiwick. And then the second question, I'm afraid I was missing one key word to be able to understand well, so apologies for that. But the Senor and I hopefully can have a chat outside and we can clarify a little bit more. Thanks very much.
Thank you so much, Sarah and PJ. Caroline, the floor is yours. And Caroline is going to talk about the long-term condition questionnaire.
Well, thank you very much for this opportunity to talk with you today about our work, which we've been doing in England, in Oxford, to develop a new patient-reported outcome measure. And I hope that this will be a tool that could be used to fit into the sort of integrated systems that we're talking about throughout the conference here. So I'm going to take the time today to talk a little bit about why we developed this patient-reported outcome measure, what we think it's measuring in terms of the outcomes that really matter to both patients and their carers who are living with multimorbidity and complex care needs. And the work I'm going to be presenting today, I'm going to give a little bit of the background in terms of how we developed this new measure, but I'm focusing on a more recent feasibility study that we've done locally within our Oxford clinical research networks to try out this new measure in the context of a memory clinic service. So these will be patients who are coming for a first diagnosis either of mild cognitive impairment or dementia. And so this work is really the work of a collaborative team between researchers and local clinicians. So to set the context within the English health services, we are approaching around 700,000 people who are now living with dementia, and we know that they are supported by more than 500,000 informal carers. And enhancing quality of life for this patient group and their carers has been identified as a priority both within the English National Health Service and the UK government. And we want to focus particularly on dementia patients because not only do they have a complex set of needs, they're often the seldom heard group. Very often their outcomes are reported by clinicians or perhaps by carers or someone reporting on their outcomes on their behalf. But the kind of measures that we work with, we're really trying to enable people to report on their own quality of life as far as possible. And of course, we can't take their quality of life in isolation of the quality of life of their informal carers. As we heard this morning, it was great to hear how much investment has been placed in the Scottish context for investing in informal carers, because we know that without them, most of the care that's happening for these patients would not be sustainable. And just to signal the wider context, although we are working with patients specifically who have been diagnosed with some kind of memory problem, we know that from the wider context of multimorbidity, very often they are living with more than one long-term condition, perhaps with a very complex set of conditions and needs to address. So the key question that we took into this work were how effective are health and care services in the English context for supporting dementia patients and their carers to live well during the period following diagnosis. If we look at the general body of evidence around how the English National Health Service is working at the moment, the answer for that would probably be not very well. We have a growing body of evidence now that says that because the system was designed very much around treating acute conditions, and the funding streams very much reflect that, that people who are living with multiple long-term conditions very often are facing a highly fragmented system where care is not coordinated and they potentially receive poor emotional support, even if they're getting fantastic care in terms of supporting better clinical outcomes. So we know there's a lot of informational lack of continuity, and that the services are reactive rather than predictive, which we know we should be aiming for, and very few, very low levels actually of proper care planning. So the proposed solution to this, as put forward by the King's Fund and now advocated by NHS England, is this house of care model, which is moving in the direction that I think we'll be talking about a lot at this conference, very much thinking about both a partnership model between those who are using the services and the professionals within them, but also thinking about joining up the organizational and commissioning practices to support person-centered coordinated care at the heart of this new model. And from the view of National Voices, one of the biggest patient advocacy charities in the UK, that is the definition of integrated care. It should be person-centered, coordinated, and it should be bringing together the outcomes that matter most to the people who are using the services. And that's the real focus of what we do within the Health Services Research Unit at Oxford. We develop patient-reported outcome measures, which are basically short health questionnaires that allow people to report on quality of life in terms of the outcomes that matter to them. So the work that we undertook starting about 4 years ago now was thinking about, are there a good way for capturing outcomes that matter to patients who are living with long-term conditions, potentially multiple long-term conditions? So an earlier phase from this work was really looking at the existing outcome measures, of which there are many, and some might be familiar with well-established measures such as the EQ5D, but trying to get a sense of whether they were really capturing all of the outcomes that matter to patients living with long-term conditions. And this illustration here is my sort of visual representation of an earlier phase of work that we did, working with stakeholders and patients, conducting interviews to ask what are the most important things we should be asking about if we're trying to evaluate services on whether or not they're improving outcomes that matter to patients. And many of the existing measures take quite a lot of focus on functional well-being or outcomes that are related to particular symptoms of particular conditions. But the sorts of things that people were talking to us about were much broader outcomes. It was basically around the idea of, can I still live the kind of life I want to live in spite of the impact of any or all health conditions that I might be living with? And so some of these broad outcomes were around ideas of having control over your daily life, maintaining a level of independence, being confident to manage living with your conditions, being able to still do things that you enjoy, and feeling safe inside and outside the home. And also some of the issues that have been highlighted in more recent research around things like managing potentially quite a complex range of services and different medications. So having to assess the outcome on the burden of services and treatment was also something that's quite important. And certainly something we've already had mention of, things that are hugely important, are social outcomes, whether people feel isolated or lonely, if they feel they have enough information about their illness and know where to go for help in managing them. So these were the sort of things we were trying to capture in this new outcome measure. So those ideas were translated into 20 items, 20 questions that now form the long-term conditions questionnaire. And the intention of putting together so many broad outcomes was that we wanted this to be an outcome measure that would be relevant for someone either living with a single long-term condition or potentially multiple long-term conditions, and that those needed to include both physical and mental health conditions. And a key consideration for us was thinking about outcomes that would be relevant both within the National Health Service context, which is mainly where we've worked in the past, but also thinking about integrating care. So thinking about, would these be the sort of outcomes that would matter, say, in a social care context? So it was really important to us to capture a wide range of outcomes that would be relevant for assessing people's quality of life as they move through different parts of a more, hopefully, integrated care system. So the first study that we did to test how well this new questionnaire worked was our initial validation study that was published a little over a year ago. And for that study, we asked quite a diverse sample of people living with a range of different long-term conditions to take the questionnaire, and we looked to see how well it performed as a measure. So does it tell us whether someone is living relatively better or relatively worse with their long-term conditions? So we want to make sure that not everyone's answering the questions all the same, so that it gives us some useful information. But we also want to make sure that we're asking the questions of a very diverse sample so that we know that it is relevant right across the range of people living with long-term conditions. So this is just a snapshot of some of the results from that validation study, which was published in BMJ Open. So we recruited the fullest range of adults aging from 18 to 102 years old, but on average they were older adults. And although we only recruited them on the basis of having one long-term condition, and we tried to make sure that we included a range of conditions that were high impact from their high prevalence, such as diabetes and chronic back pain and depression, we also included recruiting conditions that were high impact but rarer, such as more severe mental health conditions like schizophrenia and neurodegenerative diseases like multiple sclerosis. So we recruited people on the basis of having one condition, but in fact we found that the vast majority of our sample had at least 3 conditions. So this was sort of by default tested in a sample with a high multimorbidity. And in terms of how it performed as a measure, we look at psychometric properties such as internal consistency. So do people answer things in a way that makes sense? How they answer one question, would it make sense in terms of how they answer another question? And also reliability across 2 different test points. So do they answer things roughly in the same way over time if you haven't experienced a change? And so it performed well psychometrically as an outcome measure. And an important thing we wanted to check was, could it distinguish between groups of people that we would expect to be living relatively better and perhaps living less well? So we recruited both through primary care practices and also through the local authority who offered social care services. And in the English context, the threshold for accessing social care from the local authorities is quite high. So this was a group that we expected to have much higher needs. And as we expected, we saw that the range of scores, which range from 0 to 100, 100 being the best score, so living well, we saw much more of the sample recruited through primary care near the top end, but much more of the social care sample at the lower end of the scoring scale. So that suggested to us that within a very diverse sample of people who were living with a lot of different conditions, this is an outcome measure that can distinguish if people are living relatively better or relatively worse with their long-term conditions. So the more recent work, now that we felt fairly confident that we had a measure that works well as a measure, was to think about how it might actually be used within clinical practice. So over the last couple of years, we've tested out the long-term conditions questionnaire in local memory clinics within Oxford and Berkshire, 2 counties, 14 different clinics. And because this was a partnership project with our clinical partners, basically they approached us and they said, we like the look of your questionnaire. It's asking the sort of questions that we think we'd like to be keeping track of in our patients. So can we try to use it in our clinic? But of course, most of our patients don't come without a carer with them. So could we adapt the content to reflect those very broad outcomes that we think also would be very important for asking in our carers. So the first part of the work was very much about going back to interview patients with memory problems and their carers, looking again at the content to see, is this content relevant? Is it capturing outcomes that matter to you in living with memory problems? And then once we were confident that the measure was appropriate for this patient population, and we had a new carer measure, which is very, very similar to the original, but has one additional question on time to yourself. Once we were confident that we had some tools to work with, we distributed surveys through 14 different memory clinics in Oxfordshire and Berkshire, who had just been given a diagnosis of either mild cognitive impairment or dementia. And just to give you a sense of who responded to these questionnaires, this is a small feasibility study, so just over 100 people each. Generally, it was an older population with a mean age of 79 for the patient populations. But as we expected, we saw quite a bit of comorbidities within the sample, so most of them were reporting another condition as well as memory problems. And similarly, with the carers, the mean age was slightly younger because this was a mixture of spouse carers and also adult children, but they themselves, many of them, were also living with and managing a long-term condition. In terms of how the LTCQ and LTCQ carer performed within those groups. In both groups, we had very high completion rates, so most people were able to complete the 20-item questionnaire in full, and these would have been just handed to them at clinic for them to take home and choose to complete on their own and send back. So one of the questions was how willing would people be to do that, and we asked whether they were able to complete it on their own or required some kind of help. And we had very high completion rates with 2 or fewer missing items, so we could calculate a score for 99% of the sample for both measures. We also had very few missing data, so that tells us that people are able to answer those questions, and we didn't see any questions that seemed to trouble people or that people found inappropriate. And again, we looked at those psychometric measures to see how well it performed within these populations, again, finding high internal consistency. So here we have the scoring distribution among the memory clinic patients in the blue, and then the score distribution among the carers in the green. And we did compare those to an existing measure, the EQ5D, which is very widely used, and found that we saw a much broader range of scores on our measure than with the EQ5D that tended to skew very highly towards the best health state. So it might be a little bit more difficult to distinguish if people were struggling in particular areas. So these are very new data. We've just finished the study, but this is promising for us that with this patient population and their carers, again, we're seeing a measure that can distinguish between people who are living relatively better with their long-term conditions and relatively worse. So we compared the scores for both the new carer measure and the original LTCQ in the memory clinic population with our original study, and I was slightly surprised by this, that the numbers were very, very similar for the scoring as our primary care cohort, which, if you remember, had more people sort of scoring at the higher end, saying that they were living well with their conditions. And frankly, I was expecting that, having just been given a diagnosis of memory problems, we might see more people scoring less well, but in fact, we saw a very similar scoring profile to that primary care sample. And so it makes us wonder if this measure does have the potential to show if people are deteriorating or living less well, if this measure might be able to capture that, if they might shift more towards the pattern that we saw among the social care cohort in the original validation study. And then in terms of how it might actually be used, we had some feedback from the memory clinic nurses who were administering the questionnaire, and they highlighted that particularly for the carers, that having something in a structured questionnaire form could help to elicit and disclose areas of concern that might have already been raised elsewhere, but that people might have been more reluctant to talk about. So they felt this had real potential as part of normal part of their services that might enable them to identify areas of concern earlier and then link up to other elements of support in the system. So in the local context here, that might be a formal carer support assessment through an organization such as Carers Oxfordshire. So in conclusion, from this first feasibility study of the LTCQ in the practice of a memory clinic setting, we've concluded that patients with mild or moderate memory problems can complete this measure they can self-complete this measure as a measure of living well in the context of potentially quite complex or multiple long-term conditions, and that the companion carer measure also showed promise as a concurrent measure for capturing these very broad outcomes of living well. We did note there were low response rates across the different clinics that were participating, and we noted that because this was part of a research feasibility study, people were being asked to take the packet home and complete it just after they'd received a diagnosis. And on reflecting with this, we think in terms of really integrating with clinical practice, it might be more appropriate to ask people to take the questionnaire before they come in for their appointment as part of their registration process, and then at defined follow-up times. That may be a more meaningful and feasible way to collect the evidence on how they're doing over time. And something that we need to look at for the future is how well or not this measure can actually capture if people are improving or doing worse over time. So we do need to set up some longer-term studies that would capture the responsiveness of the measures. And finally, the work that we're looking to do next, now that we've done this first feasibility study, we are looking at could these measures be used in the wider system of integrated care. So in our local context, social care and health care services are very separate. They are funded separately. So we've had conversations with the local authority that funds social care services to see if they might be interested in trialing this measure, for example, in some of their carer support initiatives, and also looking to see where within the health services, both at primary care and acute care, where this measure could possibly be implemented. But the idea is that we hope that in capturing outcomes that matter to patients and carers that are quite broad, that they would be relevant to the different components across an integrated health and care service. So we have these measures available. We hope that people will use them so that we can begin to generate more of an evidence base around integrated care. Thank you.
Caroline, thank you so much. Is there still one question? Room for one question? Is there a question? Yeah, you have a question. Yeah, wonderful.
Shall I shout?
Yeah, shout, please.
My name's Robert Johnston, and I was actually a board member of National Voices for a while, so thank you for putting that patient-orientated quote into there. My slight concern was you said at the beginning how you wanted it to be a very well-rounded sample, and yet you were nearly all white British. I suggest you go to Blackburn or somewhere like that and work with some of the members of the ethnic communities and see if we get the similar sort of response.
Yes, that's a very valid concern, and certainly something in the original validation study. We tried to sample the primary care practices that were recruiting for us. They were sampled from different areas of England, and we were specifically trying to target areas where we thought there would be a higher impact of long-term conditions, and some of that maps with a higher percent of the population that are either socially deprived or in ethnic minority groups. So we think probably, as is typical with many of these studies, we do have a bit of a response bias in terms of who was willing to be recruited and take part. So I hope that certainly thinking about more local level implementation, we certainly do need to identify community centers, services that will reach the areas of the population that we haven't reached yet. Thank you.
Okay. Thank you so much, because it's already time. Thank you, Caroline. I won't withhold you from the refreshments. We saw some fine examples from evidence-based integrated care from Scotland, from Canada, from Ireland, and from England. They really gave us an insight in what kind of problems we are facing when we are studying evidence-based integrated care and what kind of solutions there are. Okay, let's go to the refreshment. Thank you very much, speakers. Thank you very much, audience, for your attention, and have a wonderful conference.
Egunon denoi. Good morning, everyone. Muy buenos días a todos. Bienvenidos a la sesión titulada Descubre España y el País Vasco, transformación de todo el sistema. Sesión que se va a desarrollar en español. Esta sesión contará con 6 presentaciones, una presentación de póster y 5 presentaciones orales. Se trata de una sesión bastante compacta y aunque intentaremos que haya la posibilidad de hacer preguntas al final de cada presentación, no podremos asegurarlo. Sin más dilación, pasamos a Mariluz Marqués, que nos va a presentar el caso de la OSI Uribe, superando los paradigmas actuales.
Egunon, buenos días, good morning. Voy a aprovechar al máximo mis 5 minutos. La creación de las OSIs en OSAKIDETZA es la apuesta del Departamento de Salud del Gobierno vasco y OSAKIDETZA por lograr una atención integrada entre los servicios de atención primaria y los servicios hospitalarios que dan sus prestaciones de cuidados a un determinado grupo de población. El Plan de Atención Integrada en Euskadi, que hace una fuerte apuesta por hacer intento de hacer una atención proactiva con un enfoque poblacional sobre determinados grupos de pacientes. Y esto hace que a lo largo de estos años las 33 organizaciones de OSAKIDETZA poco a poco se han transformado en 21 organizaciones. El marco teórico de este plan de atención integrada se basa en una serie de pilares entre los que destaca un proyecto colaborativo interdisciplinar entre los profesionales de distintas organizaciones que precisan de un cambio cultural para poder trabajar juntos, de unos sistemas de información clínica única, de un sistema de gestión y financiación único entre las distintas organizaciones, a fin de cuentas de un modelo de gobernanza común. La singularidad del caso Uribe reside en que, en este caso, la fusión se produce entre una organización de atención primaria conformada por 500 profesionales que dan su prestación de servicios a 220.000 habitantes de 24 municipios y un hospital que precisa ser puesto en funcionamiento. De ello se derivan 3 grandes desafíos. Por un lado, es necesario realizar la planificación y la puesta en funcionamiento progresiva de los distintos servicios hospitalarios. Por otro lado, es necesario una negociación y llegar a acuerdos con el anterior proveedor de servicios hospitalarios para hacer una retirada ordenada de sus servicios y profesionales. Hay que tener en cuenta que en OSAKIDETZA la prestación de servicios es parte de una sectorización. En tercer desafío, pero no menos importante, se estriba en la construcción de una confianza mutua y una cultura compartida entre los profesionales de atención primaria y los que se van incorporando al hospital. 2015 comienza la planificación y junto a la decisión de cuál debía de ser el modelo asistencial se produce una decisión no menos importante, que es la que decide que la calendarización de la apertura de los servicios debe de ser progresiva, lo cual nos va a permitir dar respuesta al segundo de nuestros desafíos. La primera apertura ocurre a mediados del 2016 y a partir de ese momento se produce una continua ampliación de la cartera de servicios junto con la incorporación de los profesionales, hasta llegar a los más de 600 que somos en la actualidad. Pero para finales del 2017 ya hay un suficiente número de profesionales que permite, junto con los profesionales de atención primaria, hacer una reflexión compartida para dar lugar al Plan Estratégico 2018-2020 que nos ha permitido identificar cuáles son las líneas y los objetivos que queremos desarrollar a lo largo de estos años. En la fase de implantación nos hemos apoyado en diferentes modelos, diferentes dinámicas, diferentes herramientas, dependiendo de cada momento y de cada situación. Ha sido un trabajo muy, muy intenso de organizar, rediseñar, procedimentar, pero les engañaría si no les dijera que hemos dedicado una gran parte de nuestro tiempo a manejar las emociones de nuestros profesionales. Profesionales que partían con una incertidumbre, que presentaban muchas dudas, tanto los que querían venir como los que ya estaban, sometidos a rumores, muchos rumores, pero profesionales también que venían con muchísima ilusión, con ganas de cambio, con ganas de innovar, con altísimas expectativas. Un trabajo de manejar el equilibrio entre aquellos servicios que evolucionaban rápidamente y otros a los que les costaba más arrancar. Ha habido que manejar la desconfianza en algunas ocasiones de los profesionales de atención primaria, que les parecía que en la dirección nos dedicábamos para unos demasiado poco y para otros demasiados al hospital. Ha habido que manejar los sindicatos con sus propios objetivos y también las incertidumbres o las desconfianzas de algunas otras organizaciones de OSAKIDETZA que veían la migración de sus profesionales. Para todo ello, la herramienta ha sido única, puerta abierta, escuchar, dialogar y seguir trabajando, con dos lemas que repetíamos como un mantra. Por un lado, no inventes la rueda. Por el otro lado, olvídate del siempre se ha hecho así. Atrévete a innovar pero pensando en el paciente. Teníamos claro dónde queríamos llegar. Queríamos hacer una organización que fuera pública, integrada, eficiente, resolutiva. Una organización con calidad y con seguridad y centrada en el paciente. Una organización que junto con los otros agentes del entorno nos ayude a mejorar la salud y permita una sostenibilidad. Sabíamos dónde queremos llegar, sabemos cuál es el camino, no hemos llegado, estamos en el camino, pero pensamos que estamos por buen camino. Muchas gracias.
Muchísimas gracias, Mariluz. Damos el paso ahora a Gochone Miranda Larrucea, que nos va a hacer una presentación que lleva el título Los soñadores participan. Parte hartu. Gochone, cuando quieras. Está, aquí arriba.
Bueno, hola, egun on danori. Buenos días a todas y a todos. Y bueno, lo primero que quería hacer era un poco llevarnos a una reflexión, a tocarnos un poco a las personas, ¿no? Los compañeros anteriores, en la anterior sesión, han estado hablando de la atención centrada en la persona y de fijarnos en las personas. No solo a quienes atendemos en los servicios de salud, sino también la gente que estamos trabajando dentro para que ello sea posible. Perdón. Y os quería empezar con una pregunta. ¿Quién no ha soñado alguna vez? Seguro que esto va inherente a la condición humana y no hay nadie que diga que no ha soñado, ¿no? Tenemos algunos sueños con respecto a la parte personal o profesional y soñamos también con un sistema de salud excelente o con que en nuestro trabajo se vayan consiguiendo esos objetivos que nos hemos propuesto, ¿no? Aquí está uno de los iconos internacionales de esta imaginación y de estos sueños, que no solamente se puede soñar, cuando ya puedes soñar lo puedes hacer, puedes crear. Y una segunda barrera que se da es no solamente pensar, sino cuál es el siguiente paso, el de compartir esa idea que tenemos, el de llevarla a cabo. ¿Te gustaría compartir esa idea? Recogiendo lo que ha dicho Mariluz de Atrévete, volvemos a retomar ese Atrévete y hacemos un guiño, ahora que estamos preparando también el plan de igualdad en OSAKIDETZA, hacemos un guiño a una mujer que también consiguió algo muy importante, que es el sufragio femenino aquí, para que podamos votar las mujeres, Clara Campoamor. Y por último, ¿conocéis parte hartu? Hoy quiero explicaros qué es que es una plataforma donde podemos compartir esas ideas con todos los demás profesionales que están trabajando en OSAKIDETZA. Puedes hacer que esos sueños, esos pensamientos se hagan realidad. El contexto lo voy a pasar muy rápido. Mariluz ha contextualizado ya anteriormente. Estamos en OSAKIDETZA, somos la mayor empresa de Euskadi, trabajamos más de 28.000 personas y a través de 21 organizaciones y muchísimas ubicaciones, como veis, dispersas geográficamente. Este es nuestro mapa actual, que responde a las necesidades de integración tanto administrativa como asistencial. Y nos hemos organizado de la mejor manera para poder dar ese servicio. Y había un nuevo paradigma para fijarnos en los profesionales que trabajan en este servicio. Queríamos trabajar en unos espacios de relación para que estos se mezclaran, que hubiera una hibridación y en tres áreas, sobre todo, comunicación, la colaboración y la
cooperation and participation or engagement, all this, of course, using technology. In terms of participation or engagement, we have promoted different spaces to promote those relationships. That is what you can see in the center. And this started in May 2016. Parte R2 is aimed at our professionals working in OSAKIDETZA. So we didn't start from scratch. There was already something OBG where the idea was to collect ideas coming from professionals. This was not widespread, so we decided it to be used all over OSAKIDETZA. We decided to organize work cafes, more than 60 people coming from the different areas, from the communication and the cooperation and participation departments, met together to try and see how we wanted to work from now on. We also needed to have regulations, the rules of the game, a management model that would be useful. Then it had to be accessible by all of us with guarantees, and we wanted to use technology, as I said before. So here you can see this management model. How do we work in terms of collecting ideas? There are 3 stages. Ideas come to us, then they are analyzed, and last, results arise. But we always have a constant feedback. There is a group who are the mentors, the role models or the benchmarks working with us, and it is up to them to concentrate on those different ideas so as to have the feedback about the evolution of those ideas. What ideas are we collecting here? Well, any idea will be welcome coming from anybody in the organization. There are no categories there. Ideas can be very different. Some of them will be highly local ideas. They can be implemented there where they are born. Other ideas may be required from others, from other organizations. Maybe they are going to be affecting a whole group of professionals, and there are other ideas, most of them, which are going to be affecting OSAKIDETZA as a whole. They are going to be having an impact on the whole system. As you can see, there are different groups which are going to be playing. First, we have the role models or the benchmarks in Parte R2. Then we have the CEOs, the managers, and then the steering committee. And all the different departments of OSAKIDETZA are represented there, and they are going to be operation in turns. This is Parte R2. This is our platform. Here you can see all the ideas that are being born and incorporated. You see how people vote, and because we start by dreaming and thinking, but then things have to be published. People read about it, they can comment on it, and the members vote, and that is how ideas are completed. I want to participate. How can I do it? There, where you see new proposals, and this spreads up, and you can reflect and make comments about the strategy, and you can express your ideas, And you can also add documents, associated documents, images, pictures, photos. You can also reflect or think about the values, and you can also talk about challenges. What is the challenge there? And once the idea is there, and once we can read about the different comments, and the votes start, a journey starts, and that is what you can see there. You see different colors, different stakeholders, different functions and ideas, and there are 3 stages. First stage, that goes from kilometer 0, from the beginning, once the idea is born and published. Then this group of role models or benchmarks or mentors, this group of mentors have to start researching, comparing, completing. They will have to reply to the person giving the idea, and then they need to establish priorities, because we have many ideas, based upon different criteria. Then we will have to establish priorities to see whether it is innovative, transferable or not, so as to establish a ranking of those best ideas. Not all the ideas are going to be implemented or evolving. Some of them are already being implemented in different projects. There are others maybe that will be abandoned, but they will be mere suggestions, but most of them will have an impact on the whole system. Second stage now, analysis. We will organize a workshop with all the different mentors in part AR2, and we will be working out of this ranking of ideas. We will extract and come up with the 5 best ideas. There is a lot of work to do, a very intense work, and we try and identify the best ideas and the most representative ones. We follow a highly systematic methodology, and there are 2 rounds of work so that the system is well balanced. Third stage, once the ideas go to the steering committee, it is there when we will decide which ideas are going to be implemented or not. And the 3 groups are going to be involved, both the managers, the mentors, the steering committee. They have to join hands at the end. And this year we have organized a public conference to show how all that was taking place. Today we have 546 ideas, more than 2,400 comments or opinions given by other members, and 4,050 users have also participated, have also taken part. This is part of our participatory culture, and in YouTube you can watch a video about it. Let me share with you the best in the year 2018. I wanted you to know them, to see their faces and their different ideas, projects such as chronic pain or migraines, how to tackle migraines. From pedagogy, this was born out of primary care professionals. There was a midwife and a nurse who decided to use pictures, photographs. Others speak about incorporating, for example, also children, so as to learn about different techniques. A professional in Sebastian proposes to send messages to the relatives of people being in hospital, and also deploying information in Basque language, which is our co-official language. Different ideas, and that is what we did. Here is where we met, in this big room. We invited all those who wanted to participate. People were generous enough to pitch their proposals. Last year, there were other ideas. These are the ideas from 2017. In 2017, we didn't open up the doors, and that is why in 2018 we wanted to be open to people. These are those who are involved, who want to create a much better health system, And here you can see that you can use the mobile application. And last but not least, conclusions and lessons learned. All this cannot be done if we do not have a shared leadership. I have already spoken about role models and benchmarks. We also need to know about our organizations very well. We need to know about it in depth. Two essential attitudes are engagement and being open. And the lessons learned, this year we organized a meeting and we wanted to carry out a SWOT analysis, and the conclusion was that we need to have an annual budget to use so that these ideas can become true. We need to measure things. Measuring is important. Also, we need the support coming from managers and recognition. We need to acknowledge what is being well done by these groups and which are the challenges. Today, we are including in this platform different challenges, and now, through each challenge, we want to go and ask professionals, what do you suggest to do to overcome this challenge? We want to develop local innovation, where ideas are coming from, and two further ambitious challenges, but why not? Why not extending this to interest groups? And what would happen if this was spread to citizens as a whole? Here you can see the video by Parte R2 in YouTube. I think it has been translated into English, and I hope it will be accessible for all of you. Thank you very much.
Muchas gracias, Gochone, y enhorabuena.
Thank you so much, Gochone, and congratulations for this excellent proposal. And maybe we have time for one question. Are there any questions for Gochone? Where are the microphones? Perfect, thank you. Any questions?
No? Vale, Gochone.
Gochone, let me ask you something. We know that this is an initiative that was launched by OSAKIDETZA, by the Basque Health Department. But are you evolving in other sectors, such as the social sector, or are you only aiming healthcare professionals?
Por favor. Sí, gracias. Muchas gracias.
Sí. Bueno,
Well, as I said before, any idea will be welcome. Ideas can be associated to the healthcare sector, which are in our core business, so as to say, but there are also many other concerns which are different. For example, how to improve working environment, or how to do things or work in a different way, different approaches. There are also improvements and not only innovations. From the social perspective, there were some initiatives too, because we are open to all the different professionals in OSAKIDETZA, and each of them have their own concerns, of course, and they can propose any idea. Please stay here, because I don't know if maybe there are any questions. Well, that is not the case. We are only starting. Let's continue then with our next presentation. Nerea Eguren Adrian is going to be telling us about coordination in the Principality of Asturias, going or moving towards integrated care. Nerea, the floor is yours.
Muy bien, buenos días.
Good morning, everyone. I can't see you very clearly because the light is shining full on my face, but hello anyway, I'm sure you're there. I am the head of the social service planning department in particular, And I'm going to be talking about a work that was carried out between the Health Department and the Social Services Department over the last 4 years. As you know, many of you, Asturias is a region in the north of Spain. There's 1 million inhabitants live in the region, and I think we're a society which is quite similar to many other societies in the Western world. We have a very large life expectancy. There's a lot of chronic illness, and we have suffered and we will be suffering over the next few years an increased burden on social services, especially with regard to the health and social services, as a result of the change in the family model as well, and the nuclear family. This means that the needs change as well, the needs of all of the services. Now, alongside these social changes that we've analysed alongside our services, we think that there is an opportunity here because of the way the systems are changing. The health system is moving more towards home care. We need to stop being centred so much on hospitals and to focus more on homes and home care. And homes are the places where social services have been working traditionally. So this change in the systems, change in society, means that we're seeing things in the following way, as we can see on the screen. Now, both systems have already been working in the path in parallel. You can see there's the two railway lines that don't cross. But we need to move towards a situation that we can see here on the right, where the lines are constantly intercrossing. And we believe we're now at a moment of coordination and we're moving towards integration. Now, the relationship between these two systems has gone through 3 phases. So specific links about specific projects, that was the first phase. And then the next phase has to do with coordination, which is where I think we are now, as I said before. And we are currently developing integration projects. As you can see at the bottom of the slide, this is because we believe that we share a comprehensive view of people. This is something that we share. We're systemic systems. We are constantly crossing over with other systems. We have complementary resources, which means that we can actually provide some kind of continuity in care. And we always we base our work on our different health and social determining factors, which often are similar. So, as I said, we are at the moment of coordination moving towards integration. And this is all based on a couple of points. We have interdepartmental cooperation and shared government. In the past, we've done a lot of technical work. And what we're trying to do now is to set up stable structures. It's like a Russian doll, if you like. We had an interdepartmental board made up of political representatives, general directors, etc. And there, one, I think, important point is that the chairs rotate every year. And it rotates between the different political people responsible. We have a technical commission as well, which meets every 2 months with technical staff from the 2 ministries. And then another key to our success has been to create different structures, territorial, regional. You can see that we have divided the autonomous community into 8 different social and health areas, and it helps us to share resources. There are different teams set up in each region or in each district with more than 100 health professionals and social services professionals aiming to give a much more holistic services. And we also work with municipal services because, as you know, the municipalities have an important role to play here. We have carried out more than 100 meetings over the last 2.5 years. We've held meetings aimed at transferring knowledge, talking about the different structures, sharing cases, and we've really worked very hard in this particular side of things. We've developed a plan. We've had a pilot project for a case of abuse. There's a poster here if you want to go and read more about it. We are there at your disposal. We presented the plan, and we also shared best practices. As I said, this has been one of the basic things that we have done to create stable structures. Another important element is the approval of a health and social plan based on the structures that I have just described. We've just passed it now, I think just a couple of weeks ago. And the aims are to provide high quality care. You can see this in the circles, the little circles outside, to have effective care, to improve efficiency, to share and coordinate resources, to raise awareness as well, and to share information between different professionals. And there's another element which is very, very important, which is the information system. Now, the information system is based on two laws. The health law, which was passed last Friday, which talks about health and social coordination, and our Social Services Act, which establishes the shared information system. So we now have a legal framework. You know how important data protection is. This has made our life a little bit more complicated in both systems, but we have managed to approve a legal framework which talks about our integration. And we believe that this is the driving force behind all the other things that I'm going to be telling you about. Now, let me tell you about the actual plan, the health and social plan. It has a number of different areas, but it's based on 5 strategic areas. The first is our actions with regard to target populations. We have identified 9 target populations. These are the populations that we really need to pay special attention to. The second area are information systems, because this is very important, as I described before. The third one is interinstitutional support between the 2 departments. The fourth is awareness raising and transfer of information. And then the 5th one is these different structures of the plan. Let me go through them one by one. Well, we have identified people who are fragile, those who are living in situations of dependency, serious or mental disorders, which I think is something that both systems have always been working with, those living in or in situations of exclusion, children who are very vulnerable from a social and mental health point of view, violence and abuse, end of life, people at the end, in the stage of their end of life, vulnerability with regards to oral health, which is very important, and neurodegenerative diseases, neuromuscular diseases, and some of them include which are considered as rare diseases. Now, there are 53 different actions. Most of them refer to this particular area, and we have older, fragile older people. We are on the verge of opening up a convalescence program. And so we have set up a special care home for people who do not need to be in a hospital, but they do need a time for convalescence, for recovery. So it's a recovery home, a convalescence home. They'll be there for maybe between 2 and 3 months, depending on what the different problems that they have. I'm not going to go into detail into each and every one of them. If you want more information, it's available on our website, but I would like to perhaps highlight some of the most important ones, because we have been working on this now very intensely for 2 years. So people with serious mental disorders, we've worked on coordinating our different care mechanisms and to coordinate the beds or the places we have in the different facilities offered by each department. People at risk of social exclusion, we're talking about homeless people, vulnerable children, we're talking about children with mental health problems, those who suffer abuse. Here we're talking about children and women as well, those who are at the end of their life. This is something that both departments have been working with very assiduously. People at risk of oral health and those with muscular degenerative and cognitive degenerative diseases. Now, the information system, I'm going to go speak even more quickly than I've been speaking until now, because I don't have much time. But here we have our information system. We're going to have both of the clinical records brought together, and we will be able to share parts of that. With regard to interinstitutional support, we're going to have the central acquisitions of drugs and different pharmaceutical items. Everything that has to do with blood tests, etc. All of this will be done in a coordinated manner. Professional awareness raising, disseminating the plan, lifelong learning, a shared ethical space for the health and social area. And as I said before, we've talked about some of the activities carried out in this field. What are the structures which support the plan? Well, these are the ones that we were talking about at the beginning. We have the interdepartmental board, and we have the committee of experts as well. And in order to actually implement the plan, we've set up a series of working groups about the different reports. There are many, many different reports, the shared reports, which made attention and care very, very difficult. And the design of devices for those aged over 50 years. This is a type of profile that not much attention has been paid to in the past. Greater coordination between the health and social services. And we also coordinate with OSAKIDETZA, which is the Basque Health Service. We have a training group, we have a penitentiary group for prisons, because we have a prison where we have a very, very important both health problems and social exclusion problems. We have a group on pharmacy, we have a group on residences or care homes, and a collaboration with the third sector. Now, I'm going to finish now because I think these instruments are very, very important. We need to have a strong political leadership. We need to have stable coordination mechanisms. We have to do specific actions as well. There has to be a strategic point of view, but it has to be operational as well. We have to innovate because we have what we have, but what do we want to have in the future? Having well-trained professionals and working as part of a network. Thank you very much, and I'll be very happy to answer any questions that you may have.
Muchísimas gracias.
Thank you very much, Nerea. Thank you very much for that very fast presentation. We have a couple of moments for questions or comments, if anybody has anything that they'd like to say. Any questions from the floor? I can't see any hands raised. Yes, there is a hand raised. Thank you very much. Nerea, perhaps you'd like to come up here to the... Oh, no, you've been giving a hand mic. That's okay. This is a question for Nerea. In your plan, you were talking about your collaborators, and you mentioned the third sector. I'd like to ask you about volunteers. Have you counted on the support of volunteers? And what percentage of your collaborators are they? Can you hear me? There's a bit of an echo here. Thank you very much for your interest. We have used stable participation structures. I'm sure there's something similar here. We have different territorial and regional health councils through which volunteers can volunteer. But I think in the social services, we have a traditional habit to actually, we're much more used to working with the third sector in the social services than in the health service. So in the health and social service that we now have, we do have volunteers, and they, perhaps at a lower level, they have more responsibility, that's true. We have voluntary organisations who have made important contributions to the design of the plan. And then the different territorial structures that I have outlined for you, they are also very important there as well. In fact, one of the best practices that we have shared and we have highlighted was a shared working day between volunteers and the third sector with regards to how to coordinate the new health and social service. Thank you very much. Any other questions? She was just starting to talk without the microphone, but she's just been asked to wait until the microphone arrives. Nerea, I would like to know, what type of communications channel do you use between the health area and the social area? And then in these meetings that you're holding with the health and social team, what issues do you discuss in those meetings? I'm sorry, could you introduce yourself and tell us where you're from so we know who you are? My name is Nerea, and I come from the Oshulibe organization. Well, the communication channel, as I said, we have monthly meetings. So we started out with a lot of enthusiasm. Many of the professionals already knew each other. So it was just formalized something which had been happening in an informal manner for many years. The communication channel mainly is the website. We have a community of learning to which all the practitioners have access to, and then a specific email address for each of the different teams. And what issues do they discuss in the meetings? Well, in the first meetings, it was just generally getting to know each other, sharing what each person did, because we come from very different traditions, very different areas. So we mapped out our resources, the resources that existed in each area. It wasn't an inventory. It was sort of a map of resources. What was there? How do we work with it, etc. And then something else that we did, and that is very important, the management of complex cases. We worked on developing a methodology for tackling complex cases. Now, each area, each district has different dynamics. They're very similar, but they're quite different in many ways. Sometimes because of the different tradition that they've had, or the profiles of the people who were involved. The job title is always the same, but people are different, of course. And there were some areas or districts that specialized in this complex case methodology, so that we weren't all working on it at the same time, to avoid overlap. And this is a very important piece of work. And now we have shared this methodology so that we can all work in a similar way. Now, with complex cases, we had to look at the profile, the mental health profile, older people in situations of fragility, people who lived by themselves, what to do after discharge, hospital discharge, for example. This was something that we had to tackle together between the two departments. The main idea is that we, first of all, got to know each other, got to know each other's resources and how we function, how we work, and then managing complex cases. Thank you very much. I don't think there are any more questions. So now we're going to carry on to our next speaker, Maribel Moreno. And the title is Local Health Network, Community Educational Program to Empower Migrant Women Taking Care of Dependent Persons.
Hello, egunon.
Good morning. Good morning, everyone. Egunon, as we say in the Basque language. Well, first of all, I would like to thank the organisers on behalf of my group for having invited me here to talk about this experience that we are carrying out at our local council and in the area of Duranguesado here in the Basque Country. We are aiming to set up local health networks. It's called There Is No Life Without Care. And it's aimed at migrant women who are looking after dependent people. Because what we saw was that our small society, our small care society, didn't really put the life of people and their care at the center of things. And then we saw that there was an opportunity to improve the health of people and their situation. And we thought it was an important opportunity that we couldn't let pass by. Now, care is often carried out in a domestic sphere, in the home, by people who don't receive any pay for this. Socially, this task generally falls to women, but this is changing. There are some changes in society which is destabilizing the former family model. Some authors talk about the crisis of care as well. Now, as the health service, we actually become responsible for covering this particular health need. And we were asking ourselves, well, who looks after this and how are we looked after? And in 2017, the Association of Female Domestic Workers of Vizcaya the province of Gipuzkoa, found that 97.97% of women working in the domestic sphere were actually lived with the people that they looked after. And 71.6% of them did that in illegal situations, and with regard to their timetable and their rest days. For example, even Lanbide, which is the Basque Employment Centre, presents some statistics that say that more than half of these women are of foreign origin and they have migrated from countries outside the European Union. Looking at this, we saw very clearly that care and care work is something that cannot be provided in conditions of insecurity for both the carer and the patients themselves. And so something needed to be done. In our primary care system, we decided to set up a network that would enable us to tackle this problem through training, to provide an integrated, interdisciplinary perspective, which would include all the different outlooks, everything related to care. Our starting point was that we were going to mainly be working with migrant women, mainly from Latin America, living in situations of extreme loneliness, social isolation. And in September of 2017, we began, in collaboration with the Basque National Health Service programs as well, in collaboration with them, we started to structure our intervention. Now, the strategic programs set in motion by OSAKIDETZA, the Basque Health Service, clearly say that all programs need to be well coordinated between the different stakeholders, and we were very aware of this. Now, we had doubts about our methodology at the beginning, so we had to find the right methodology, but back in September 2016, we did find that OSAKIDETZA suggested a good methodology for us, and in fact it was going to be that methodology that was going to guide our intervention. It consists of an analysis, the design, then the implementation of a program which would be adapted to our local environment. What were the aims? First of all, it was to increase the technical knowledge and abilities of the migrant women who were carers, but we also wanted them to acquire this knowledge in the field also of looking after themselves, as well as looking after the person, the dependent people with whom they work, so both themselves and their charge. This led us to some secondary aims, which was to establish a community network with a favourable institutional support in order to be able to set up a true community network, and to increase security and safety at work for the carers, to improve the quality of the care received by fragile or dependent older people, to help with self-care of the carers themselves, to foster their integration, and to help with their empowerment. With all of these aims and goals, we thought, okay, well, that's well and good, but how are we going to do them? How are we going to achieve them? So there are a number of different phases that we can distinguish here in this process. First of all, we had a steering committee, which is an interdisciplinary group. We had representatives from primary care, the Basque Health Service, the social service of the Durango area or region, where the social workers work. The Department of Equality at the local council also sent a representative, and we worked together to establish different areas or strategic areas to identify what stakeholders were going to be involved and to try to move the project forward. We drafted different documents and proposals, etc. We prioritized the working group, and we were interested in involving the target population as well. We wanted to see what they were concerned about. We carried out individual and group interviews to do this. The secondary aim was also to stimulate the participation of these people as well. We wanted them to collaborate with us as well. We identified what sort of social assets we had, different associations and organizations working in the area. and the different physical resources, the economic resources and the cultural resources as well. We explored the potential of these different community participants. We identified leaders who were well considered in the community, who could actually serve as ambassadors for the process. And we carried out data analyses to try to determine what sort of indicators that we had for mortality and comorbidity. We carried out the community review with a working group. And all of that led to the design of the program, taking into account all the different perspectives so that we set ourselves with a mission and a vision, etc. And this was then all specified in the training program for female immigrants working in the care field, looking after dependent elderly people. Now, I'd like to focus on this particular part in particular because I wanted to explain to you something which I believe is a defining element of the way we work, and that is that we strive to set up a community of practice involving different social stakeholders, social assets. We want everyone to participate in these workshops in order to understand what our target population really wants, what their perspectives is, what their opinions are, and to focus the design on this so that we can adopt a global network-based perspective right from the very beginning, putting people at the center of the entire program. By people, we mean the people who are dependent and the carers themselves. We developed a training program in which 20 women worked with 10 theoretical sessions and other inputs as well. We talked about healthy habits, general care, general health care, and also care for people, elderly people. And then we also had, these were 6 classes, and then there were 4 classes which were interspersed between these other 6 classes, in which we provided what we call participatory popular education. Now, this was led by a feminist sociologist who was also an immigrant herself, and she focused on the social integration side of things, which was something that we needed to include in the training, as well as all the different theoretical aspects. So we held different group dynamics to present the methodology, to establish the commitments. This was done in the first session. And there it was not just the teachers, it was also the steering committee was there as well, and the women themselves. We alternated empowerment sessions, self-care sessions with all of this as well, how to find allies, how to create a support network so that the women themselves could establish their own support network. There were final sessions afterwards in which the teachers and the promoting group came back together to assess the results in order to get a qualitative idea of the degree of impact that our intervention was having. Now, with regard to results, we had good attendance levels, and with regard to the knowledge acquired, we did pre and post tests, and the average score was high. What we learned mainly, we learned from the qualitative evaluation of the program carried out by the promoting group and the target group as well. And all of this was thanks to the workshops that we held. With regard to adherence levels for the local health network was a satisfactory level. A lot of organizational meetings were held and attendance was very high. With regard to the dissemination of the initiative, we can say that the results were fairly positive as well. Because in fact, the women, the carers, ended up giving talks themselves, talks about cooperation, and they were telling about the necessary and invisible work that they do, and how this invisible work should be visible and should be seen by everyone. With regard to satisfaction levels, we can see an empowerment as well. We can see that empowerment increased, and their level of relationships with other people. We saw that, in fact, behaviors changed. There was a greater degree of participation in the different events that were organized. Collaboration with the local cultural centre as well. Outings to the theatre were organised. Dinners were organised with the participants in the network. So the whole experience was very satisfactory. There was a good level of dissemination, because you should remember that we're talking about a first initial experience, which is like a pilot experience, in which our goals were achieved, were met. Very, very good level there. The general knowledge in the health and social fields of all participants, not just the carers themselves, but everybody involved, has increased. And we've seen that the self-care of these women as well, and the promotion of their own health has improved as well. They've participated in programs to promote healthy living, vaccination programs as well. Now, no matter what the relationship with regard to the coordination of the network, it's very useful to make sure that these relationships happen at the same time, that we should work on forging personal relationships as well. What are our conclusions then? Well, the idea is to scale up this initiative so that it can have a greater impact on this particular field. When we were thinking about what we had achieved, we came to the conclusion that it was a viable intervention with positive outcomes with regard to people's satisfaction and experience. Working as a community network always has to have a good methodology to guide it. And also it was important to avoid overlaps, duplicities, in order to reduce administrative costs. And we were able to do that at many different levels. Because, in fact, we have fewer hospital admissions, fewer home visits, because the care that these people are receiving is improved right from the very start. There is a greater degree of integration of these women. They become more integrated in the society in which they live. And we also decreased the exclusion level of the target population, which was migrant women. There are still some barriers, and we are analysing them at the moment. It's important to work as a network, and in order to, we have to make sure we get the right system to get a good deployment and scaling up of the initiative. Just to finish, I would like to tell you that we're still very enthusiastic. We're working very hard still to increase our impact in order to provide greater value to patients and to society in general. After the training session that we've carried out, we are now organising a cycle of 3 workshops with the same participants, so follow-up workshops. And we've also started providing the initial training with a new group of women. And because we see that they are activities that really are beneficial to all involved. Because we're also trying to interrelate the different activities with the first group of women, with the second group of women, so that some of the members of the first group can become facilitators for the second group. All so that we can reach our final goal. Thank you very much indeed.
Muchas gracias, Maribel, por esta excelente.
Thank you very much, Maribel, for telling us about this excellent initiative. Does anyone have any questions? No? No one has any questions? I think somebody does. Thank you very much. Perhaps you can tell us your name and from what organisation you come from. Hello, good morning. Thank you very much for the presentations. My name is Elena Fernandez from Goyenea. Now, how do the How do the participants rate the initiative? Well, the initiative itself, how did you choose the participants was the question. Well, the network was set up because certain needs had already been detected. When we were starting out with the first program, we looked at the needs and we worked with associations. For example, there was the local women's association. And in fact, it was the network who gradually found the participants. But the selection process wasn't really a process because there's a very high demand. So it wasn't difficult to find participants. In our everyday work, we had contact with many families who were asking for this sort of service. And I'm talking about families, and in fact, who saw that these carers as part of their families. And they were asking for this special service, special type of attention. And it's true that we advertised the initiative through posters on the local council website. We also worked through different social workers. But the groups almost were created by themselves. And in fact, we couldn't include everyone in the first group, which is why we now have the second group, and more groups are being formed all the time because there's a very, very high demand. It's very easy to recruit participants.
Muy bien, parece que no hay más.
Thank you very much. There don't seem to be any more questions. Now we're going to pass on now to our next presentation, which is going to be given by Mariluz Peña González, and it's called Integrated Care for the Elderly in OSAKIDETZA. OSAKIDETZA is the Basque Health Service.
Bueno, egunon denoi.
Good morning, everyone, or egunon, as we say in the Basque language. Thank you very much for coming. Now, I'm going to be talking about the program PAM, the program Care Plan for the Elderly, the PAM plan. It's been up and running since 2018, and it's headed up by a multidisciplinary team. And it's also reviewed by experts, has been reviewed by experts. I'm just going to try and get the right button here. Just to give you a bit of context, the WHO report on the aging process talked about healthy aging as the process of fostering and maintaining functional capacity, which will enable well-being during old age. Now, if we talk to elderly people, what they are most concerned about is how to maintain their functional capacity. But in order to maintain functional capacity, the WHO also said it's not enough to just do the same as we have been doing in the past. We need a systemic change. In relation to the aim of increasing functional capacity during old age and to prevent disability at a national level, in 2014, a consensus document on the prevention of fragility and falls among elderly people was approved, again in 2014. In the Basque Country, we have our health plan, includes an intervention about how we have to set up a care program for the elderly. And this is also referred to in the challenges and strategic projects of OSAKIDETZA, the Basque Health Service, and it also is referred to in the strategic priorities for the Basque Health and Social Services. So, to follow on from what I was saying about this change of paradigm, we have to move from a model which is basically based on diseases and curing them to a model which is based on integrated care focused around the elderly people themselves. This is what we're aiming to do through the PAM plan, the care plan for the elderly. Now, throughout the course of my talk, I will be talking about the PAM plan. She calls it the PAM plan, the care plan for the elderly. The aim of this plan is to increase functional capacity in people over the age of 70. In order to do that, we need a structured program. It's important to work between health professionals and social professionals, to have a joint effort by both of them. The idea is to identify functional capacity at the beginning and to divide elderly people into different groups with regard to their functional capacity, then to carry out a multidimensional assessment according to the different groups in order to come up with a customized care plan, and then to establish interventions which will contribute to the maintenance of the functionality and quality of life of elderly people. Now, this plan can be expressed in this diagram that you can see on the screen. As I said before, at the beginning, there is an identification of the functionality level. There's a series of scales. I'm not going to go into detail with regard to the different scales, but if at the end of my talk somebody wants me to talk about them, you can always ask me a question. So there's a series of scales that we have identified. And these scales will define the category. There are 5 different types. There is somebody in robust health with comorbidities but no functional deterioration, fragile, dependent, or at end of life. And depending on these 5 categories, we will carry out a functional assessment in accordance with the category, of course. And then through this evaluation, we can determine a series of interventions to be carried out, which would, the working group at least, has set out or identified as priorities. So, for example, one series of interventions, which are in orange on the screen, and that is we have tried to integrate them with the interventions or programs which have already been carried out in OSAKIDETZA, the Basque Health Service. In OSAKIDETZA, there's a series of programs and projects that are already underway, and it's important to integrate what we do into these programs, because we wanted professionals, practitioners to see elderly patients as elderly patients, to focus on them as people. And this is why we have made this effort to try to integrate everything that we do. Now, this is our flowchart for the interventions, for the multi-dimensional approach. We've taken different aspects of the geriatric evaluation, but we've tried to make it compatible at the same time with the care that is provided in primary care. So there's a functional evaluation, a mental health evaluation, evaluation of the carer, etc. And then in the preventive evaluation, we have the general evaluation as well. Which is an evaluation which has to do with weight and size, etc. There are some which are specifically related to geriatric syndromes, another with polymedication, and then looking at the comorbidity of these elderly people. In relation to all of this, we come up with therapeutic care and customized care plan as well. Now, to set it up, we carried out a pilot project which lasted for 6 months, carried out between the end of 2016 and the beginning of 2017. The aim was to assess the program in a controlled way in order to establish the different adjustments that we needed to make in order to guarantee its applicability and its subsequent deployment in primary care points. Now, this evaluation, this pilot project, was a research project, a study. It was carried out as a research study, and we assessed 1,200 people with a mean age of 79, and 85%. We were able to actually determine the category in 85% of cases. It was carried out in 7 health centres throughout the entire OSAKIDETZA network. Now, we had a specific structure for evaluating. I'm not going to explain it, but I would like to highlight the importance of measuring the impact pre and post intervention. And I identified the functional situation of each participant, which resulted in this pyramid, which is significant, especially in relation with the sample that we used. Now, this is the pyramid. It's like a population pyramid, really. We have those in robust health at the bottom, and then we go up until you get the ones at the end of life, in the end of life stage. Now, one thing that we can say is that systematizing the intervention has had a very positive impact with regard to assessing the points that you can see below. But even though many of the variables were twice as high as we thought they were, according to official registers, there are some, such as the level of physical activity and falls, which are marked with an asterisk there, which should they need to be improved. The care and the registering of them needs to be, the reporting of them needs to be improved. Now, what to do with this assessment as well? This is another question. Now, in the centres involved in the pilot project, they said that we had to evaluate fewer people in order to improve the screening criteria as well. They also told us that we needed to have different specific forms to be filled in. And we have incorporated all of these suggestions into the new version of the programme. And then another important aspect was that we needed to coordinate with other groups and programmes. Now, this is something that I mentioned when we were looking at the flow chart. This is something that we try to do. We try to coordinate our efforts with other programmes. For the deployment and for the training as well, for the pilot project, we did have a training plan. And in the deployment of it throughout the entire service, we have aimed to improve on what we did in the pilot project. And we have developed a series of professional support tools. We have developed some care plans within the PAM. Now, we have 2 information systems, it's important to mention. We have the clinical histories, and we have them in the global service, and we also have them in the place where we called Los Anaya, which is where we have the central services of all the different information, and it's where the care plans are developed. So what we've tried to do is to set up tools and develop tools to try to standardize these tools in the different areas in which practitioners need to carry out the assessments. We've also, with the aim of training practitioners in relation to this plan for the elderly, we've set up an online training scheme as well. Computer formats have been adapted as well to all the different requirements of the plan. We have developed different forms for functional capacity evaluation as another form that we have developed for evaluating the functional evaluation and alert systems for fragile patients. And we have provided different help sections so that it's easier for people to report incidents. We've also developed some educational material. And this material can be used by all practitioners in primary care points, and then also different documents, different resources which are available on the website, the intranet and the extranet. So we have, there's the guidebook as well, and then there are different resources that all practitioners can use on the website. Now, we've only been up and running since April. It's not been April last year until now, and not for very long then. but we wanted to bring you today some data, some outcomes with regard to deployment, with regard to the training, evaluation, the categories, etc. With regard to training, the online PAM training, now you can see that despite the fact that the target group were in the primary care sector, we have also provided training to professionals working in other areas, in hospitals, in the emergency room, mental health, for example, who are interested in this particular, in the training provided by the plan. Now, the analysis was carried out in the primary care sector, and there were 732 people who were registered. Only 60-odd% were actually deemed apt. Now we are going to evaluate what sort of resources we're going to be using in the future, how we can make things easier so that we can improve the course itself. So I'm being told I've been taking up too much time. Because in the reviews, they've been told that there's too many videos. It's quite a burden. So 23% of participants were nursing staff, and the rest were physicians. If we have a look at the categories, you can see that it's not very even results. So we can say that the deployment is not an even deployment. We've also identified the categories in accordance with the organisation of services, and this is really going to help us when we're deploying it more. If we compare this with the population pyramid that we saw at the beginning, we can see that, as expected, if we compare it with what was expected and what was actually observed, we can see that the patients that are being included in the deployment are more complex patients. They're more dependent, more towards the end of life. And we have a hypothesis which says that there will be chronic patients receiving home care, and we need to start with them. With regard to the different drugs that are being taken, you can see that a very high percentage of polymedication, taking more than 10 different drugs. I don't know if I have time to look at this. Well, if you look here, you can see that all the different categories and all the patients if we compare these with the over 60s population, general population, you can see that polymedicated patients there's a much higher percentage of them among our participants. Now, we have to carry out a scoreboard, for example. We haven't been able to fill it with data yet, the scorecard, sorry, but we will do that in the future. And for future challenges, well, we have a group which is focusing on physical activity among the elderly. It's a multi-professional, multi-area, multi-departmental group, a working team from the University of the Basque Country, from the different provincial councils. We also have people from OSAKIDETZA, the Public Health Service. And these are the actions that we will be prioritizing in the future to have sort of training pills, basic short training courses for people. Now, I'm just going to read this very, very quickly, although we can't really see it up here on the screen. But it seems that the project helps us to improve the health and social support. The aim is to maintain their functional level. We are better able to identify situations of fragility, to monitor health problems and their complications, and it makes coordination easier, and it helps us to integrate the program with other programs that are currently up and running, provided by the Basque government. The deployment is not very even, and we need to adapt the training to each particular field and to look at the dropout rate as well. We believe that the scorecard in the future will enable us to understand people's functional situation better and how suitable the interventions are. And this will enable us to adapt the program accordingly. But this is everybody's responsibility. It's our responsibility to build a better aging for all of us, and we think that the PAM plan will help us do just that. And I'm sorry if I have talked for too long. Thank you very much.
Muchísimas gracias, Mariluz. Lamentablemente.
Thank you very much, Mariluz. Unfortunately, we don't have time for questions, but if anyone does have a question that they haven't had a chance to ask them here, perhaps you can find them during the coffee break or the lunch. And I'm sure any of our speakers will be happy to answer them. Now we have one more presentation, Marisa Marino, who's going to be talking about management competency development for integrated care. Good morning, everyone. I'll try to be very brief because, unfortunately, Mariluz talked for a little bit longer than she should have done. I work at the Spanish Association for Primary Care. We work as a multidisciplinary association, and we've been working for many years now in the primary care area. And we have been focusing on integrated care, most particularly over recent years. We all know the current scenario, greater degree of chronic diseases, different models, and as the WHO says, we need to have people-centered care. People-centered care. Now, this change needs to be led by the health managers and other people working in integrated care. But to do that, we need tools, and we don't always have those tools. So in this context, our association that's set ourselves the following challenges: to identify the skills required by health managers for advancing integrated health care. What did we need to do in that case? What were the skills that we needed? Secondly, we needed to validate and prioritize these skills. And thirdly, if possible, to try to design a skill development training program. So bring it all together and to come up with a specific outcome. What we did in order to identify the skills, we brought together a group of experts from different autonomous communities, and we came up with the Sirocco plan. It's a maturity model. There are 12 different dimensions. We went through these different dimensions one by one. Each of us, what the situation was in our autonomous communities with regard to our actions in the 12 dimensions, and what tools and knowledge and skills that we needed in order to move forward towards integrated care. Later on, we validated what we had designed in this team in the rest of the different departments and partners in the different autonomous communities, and we defined a framework with 11 skills that we believe are the ones that all of us need to have, those of us who are managing or leading integrated care. They are as follows: a systemic view, people-centered care, participation, communication, leadership, talent management, relationship management, innovation management, change management, resource management, and digitization. Later on, with the draft that we came up with, thanks to these skills, we shared that with the different autonomous communities, and many people were involved in validating this framework. In this phase, we also prioritized the skills, these And there were three: people-centered care, leadership and communication, change management, and digital transformation. These were the three priority skills. And based on that, we came up with a training scheme which had three areas: people-centered care on its own, leadership and communication, and then the third one would be change management and digital transformation. So the three areas coincided with the three skills that were prioritized. Now, we did all of this about a year ago. Last Thursday, we presented it to society in Leon, and we had quite a lot of media echo. And lots of other things were going on at the same time, because we have the framework and we have been focusing on these specific skills that we want people to acquire. In many of the autonomous communities of Spain, we have set up innovative experiences, fostering these competences, these skills. We have organized specific conferences and workshops on integrated care. We're running different courses and workshops on Twitter, visual thinking, creativity, communication, etc. Also, alliances are very important, alliances with other institutions, organizations, societies, etc. So, for example, we also have forged an alliance with the Spanish Association of General Practitioners to try to work together. We've also developed different training actions, for example, with visual thinking and the Visual Health Conference that's going to be held this September in San Sebastian, with the Digital Health Foundation as well. Always trying to develop these skills that we have identified as priorities. And based on that, we've also developed a new project, in this case in collaboration with OSAKIDETZA and the Basque government, about digital competences. The EU has identified the fact that digital competences are very important for citizens, did that back in 2013. And so in the Basque government, its digital program, it has a program called Decanos, and it defines different digital professional profiles within the Industry 4.0 drive. And we've done the same thing, but not with regard to Industry 4.0, but with regard to health. In OSAKIDETZA, we are now developing our own digital profiles of the different primary care professionals as a first step. Now, the Decanos program has developed or set up a website in which each individual can evaluate themselves as a citizen, so that they can know what skills they need to acquire. And they also provide you with links to enable you to actually acquire that knowledge and that competence. And in our website, we are developing our own section which has to do with the health profile, the health digital profile. At the moment, we're focusing on primary care, and we're working on that at the moment. Well, I don't have time to go into too much detail here. But as you can see, we are based on the European framework of reference. We have the diagnosis tool, so that and we define what the profile each professional post should have, and then each citizen can actually carry out a self-evaluation on the website, so that they can get an idea of how they're doing and where to go in order to achieve the required level. And the different training can then be accessed in a very personalized and customized way. And just to conclude this project, I would say to you that the managers and leaders of integrated care must acquire new skills which are related to people, people-centered care, leadership, communication, talent management, and digital transformation, among others. And that we have created a framework of reference for integrated care management competences. And this is important because it enables each person to know how they're doing within this framework and where they should be focusing their efforts. And as a third conclusion is that alliances with other associations and health services are essential for the deployment of all of this throughout all the Spanish autonomous communities and at all levels. And that's all. Thank you very much indeed.
Muchísimas gracias, Marisa, por...
Thank you very much, Marisa, for that fantastic presentation, also for being so short and concise and brief. So we have a couple of minutes now for questions, for comments. There's one there, I think. Can you say your name, please, and the organisation in which you work? My name is José Luis Olosua. I am the chairman of a volunteer group of elderly people. And my question is for all our speakers, because I want to talk about loneliness. What do you think about loneliness? Now, we have been working for many years to accompany people who live alone. Now, we work at care homes, day centres, and homes as well, those who live at homes. There are a lot of problems we have. Now, this year, we want to focus mainly on people who live in their own homes, particularly this year. Now, there are two ways of doing this. One is to have a personal presence of the volunteer with the person who's by themselves. And secondly, there's a tool that I think is very, very important, and that is the telephone. So we can ring up people and talk to them on the telephone when they're by themselves. What's the problem? Well, the difficulty is that it's difficult to actually find people who are actually happy for us to go and visit them, and then people who are actually happy to listen to them over the telephone, which is why I wanted to talk to you. Because through OSAKIDETZA, the Basque Health Service, perhaps we can reach out to these people. Now, why am I saying this? Why is OSAKIDETZA important here? Well, it is important because based on our experience, we can say that loneliness in and of itself is not just a case of being alone. It's the result of new diseases. And it's true that physicians have to see many more people. There's a greater cost on drugs, but not so much on people. So please work with us. Please work with us so together we can reach out to these people who are by themselves. Now, the GPs can do wonderful work here. But if we can see that this type of loneliness is actually generating new diseases, different diseases, perhaps the GP can actually prescribe some kind of tool for these people who are lonely, who live by themselves, so that they can be accompanied part of the time as a way of preventing the emergence of new diseases and problems. This would be my request to OSAKIDETZA, the Basque Health Service. Thank you very much. I'm going to give each speaker a few moments so that they can respond to that. But first of all, I think there were some questions here for Marisa's presentation, because Marisa is still up here with us now. No? No questions, comments? Marisa, I would just like to ask you one question. What are your plans for the future? You have presented a very ambitious plan. What's the next steps? Well, we have representatives of all the different autonomous communities in a community. So representatives in each autonomous community, and all of them have different plans for the future. They have a different starting point, of course, as well. And what we're doing in our society is to provide different innovative experiences, or providing specific courses, or forging alliances with other associations, for example, the Association of General Practitioners, so that we can develop materials not just for leaders and managers, but for all different levels, so that we can all move forward together, because everybody is a motor or a driver for change. Thank you very much. Marisa unfortunately has to leave us. I don't know if any of the other speakers wanted to respond to the question that was posed about loneliness. Just some brief reflections, some brief thoughts, please, because we do need to close the session. Well, just to answer, it's true that we set up a lot of projects, very well-intentioned projects, but we often lose our way when we're not listening to the people that we're trying to serve. So I understand what you're saying. It's important to listen to the elderly person, what sort of conditions they want to be cared for, and what conditions. This is going to be very enriching, and it really needs to be the guiding force for all our interventions. Any other comments, or else with this we'll close the session. It's evident that I don't work in OSAKIDETZA, so I can't speak on behalf of that organisation, but I agree with what you say. I work from the social side of things more, and we've tried to join social and health together. Now, we have access to the municipal census, so there's privileged information about the situation in which people live. And all local councils are now coming up with a register using the census information, a register of people who live by themselves. And it's a very important tool because it enables you to map different areas, different neighborhoods in which people are alone. So you can help build a community. Because one of the phenomena of loneliness has to do with reduction of family units and the loss of the primary, what used to be the primary care network, which were the neighbours and people who lived in your local area. So I think that, yes, we have primary care, we have the nursing staff, we have the social services as well. I think if we all get together, we can do a lot in this area. Now, I'd also like to say that loneliness has an objective aspect as well, but it also has a subjective aspect. This is what Maribel said. You have to talk, you have to listen. So the subjective dimension of loneliness is important and needs to be incorporated as well. We have to encourage people to participate in their local environment, to work, to have a greater network. And I think the intergenerational work is very important and is important. It's important the work that you're doing, of course, but intergenerational networks can help mitigate loneliness, and this is something that we have to recover. Thank you very much. And with that, we will conclude this session. I would like to thank our magnificent speakers, all 6 of them. And thank you to the interpreters as well. And a warm round of applause for all of them, please. All the presentations will be made available on the website, the conference website, once the sessions have concluded. I think probably from Wednesday onwards, all of the presentations will be available on the website. So now, if you have another session to go to, you should go. Otherwise, it's lunchtime. Thank you very much, and a warm round of applause, please.
everybody. My name is Moody Kadu, and I'm president of the Emerging Researchers in Integrated Care, and I'm also a junior associate with EFIC. So the Emerging Researchers in Integrated Care Network, it's a unique platform founded to connect early career researchers and professionals. We also do a lot of mentorship activities and different skill-based work for emerging researchers. So for this session today, we put together a forum in which editors of 3 leading journals, international journals on integrated care, will talk about their editorial experiences, and then we'll take on questions on how to get published. So in this way, we're hoping this session will support emerging researchers in the key skill set of how to writing successful papers and how to get them published. So we know there's a lot of advantages to publishing. When we publish, we grow the existing knowledge base in our field. In applied problem-solving fields such as integrated care, the key impacts of publishing, they're not trivial. So our work may have relevance to people facing similar problems across the country and even around the world. Publication is also a critical component of how academic and non-academic scientists are evaluated. I'm sure you know that as an emerging researcher, a lot of the times your publication record may be evaluated when you apply for scholarships or other awards. For junior and senior investigators, your ability to obtain a faculty position, for example, a grant, tenure-track position, is largely contingent on your publication record. In other words, your ability to publish can be an indicator of your competence, your commitment, and your potential as a researcher. And finally, publishing helps us grow as researchers. Every publishing is an opportunity to learn and provide us with a chance to receive an outside opinion on the relevance, rigor, and impact of our work. Even the occasional rejection can ultimately lead to us doing better research in the future. And to say the least, it's actually kind of fun. So it can be exciting to see the fruits of our labor appear in print or on the internet. So with that said, I think it's time to introduce our panelists. So we have Dr. Axel Keen, who is appointed reader in Health Service Research in 2016 and is currently editor-in-chief of the Journal of Integrated Care. We have Dr. Victoria Stein, who is editor-in-chief of the International Journal of Integrated Care. And we have Dr. Bert Verhoef, who is the editor at the International Journal of Care Coordination and principal investigator at the Department of Patient and Care at Maastricht University. So in terms of the structure of the session, the 3 editors will first introduce their respective journals. Followed by that, we'll have a brief presentation by Victoria Stein on how to get published. She's going to offer a few tips and suggestions on how to do this. Then we're going to open up the floor. So we're going to open up the session with a facilitated discussion led by myself. If at any point you have questions or if you want to jump in, please raise your hand. We want to keep it as interactive as possible. So with that said, I will turn over the mic to Dr. Axel, who will tell us a little bit about the Journal of Integrated Care.
Thank you. Is this going to carry or do we... You can't hear me. All right, okay. Right. So we tried apparently to get the stadium here, but it was taken, so we had to actually settle for this room today. So apologies. Fantastic, thanks. So this is about the, oh, it doesn't show. Can we make it happen on the screen as well? Is that okay? Hello? Oh, yes, no, okay, great. Okay, so this is about the Journal of Integrated Care, which is clearly the flagship amongst the integrated care literature. It is traditionally a journal that's very much for practitioners. And I was very, very privileged to have fantastic predecessors in the editorial role. One of them is actually here today, Robin Miller and John Glaspie at Birmingham. And we've done a lot of work with the journal to make it very international now. And I will just give a brief sketch of what we're trying to do. So the Journal of Integrated Care facilitates evidence-based integration of health and social care and other community services, vital reading for managers and practitioners. And you can see already the practical kind of like focus for the journal. The journal is actually quite well placed now. We are looking at some really good citation index scores at the moment, and we've also been really ramping up the downloads. So if you're looking for an outlet for your publication that really achieves some impact with practitioners and managers and those who are about to implement research or implement integrated care findings, we would really be your first port of call. In particular, the things that really work are special editions or special issues. And we had one recent, so check it out. It's on primary care and integration. And that racked up about like 1,200 hits, 1,200 downloads, in fact, not hits. In fact, 1,200 full downloads within 2 months. And needless to say, it was my very esteemed colleague, Robin Miller, who actually edited that, guest edited that. So it's a really fantastic way of reaching a practitioner audience, and that's very important, I think, in our field. Okay, we've got a fantastic editorial board, very international now, with editorial board members from Netherlands, Australia, Canada, and others. I'm not going to go through that list. Many of you know the names anyway. These are the sort of things we publish. So we publish research papers, we publish also discussion papers and technical papers and conceptual things, but we also quite want to encourage discussion amongst researchers, as well as discussion amongst researchers and practitioners. So we're really happy also to see submissions of viewpoint papers where somebody's saying, well, look, this is something that's really urgent. We haven't got the research in this yet. We not necessarily didn't do a systematic review or something like that, but we really want to get this out. We want to encourage and kick off some debate around, let's say, mental health and integration or things like that. And we definitely encourage these sort of submissions as well. We're a subscription journal at present with Emerald, that's the publisher. That means there is no fee and it will go through the normal peer review processes. Articles should be between 3,000 and 5,000 words long, but we're, as I said, you know, if it comes to a discussion paper, we're probably looking at a smaller word count anyway. Okay, this is our unique selling point, the USP. We welcome new writers and provide advice and support. We, and Robin and I and John, always felt that it's quite easy for academics to write. Now it's quite difficult for practitioners to write, people who are actually in the front line very often, and implementers and also evaluators from time to time who do in-house evaluations for some of these integrated care programs that they do. And what we do is we actually work with potential authors. So if people come to us and say, look, we want to get this paper out, it's reporting the findings of our study, of our program, but we don't quite know how to do this. So we are really your guys. Come to us, we'll look at that, we'll work with you, work maybe with an outline or with an abstract, and then, you know, try to get this all the way through the processes of the writing process and all the way through the peer review. And we also, of course, very much welcome ideas for guest editing special editions or special issues. Okay, that's it for me. I've put some contact cards, business cards here on the front desk, so on the front table. So later on, please help yourself with it and do get in touch. Okay.
Oops. Hello. Thanks for having me here. Yep. What is? The first one. First. A few words about the International Journal of Care Coordination. If you have very detailed or very specific questions, I always tell, please reach out to Jenny. Jenny has much more experience within SAGE than I have. So Jenny is the senior editor manager. She does not just has the International Journal of Care Coordination but also I think she has about 10 or 15 journals to deal with. So she has a lot of experience in terms of, you know, very practical things when it comes to tables or figures and so on. Obviously, we have just like the other journals, I suppose we have a very international editorial board, people from Europe, South America, US, Japan, but as you can see, most people from Europe. I think that is because how it all started. The International Journal of Care Coordination has been around for a little while, but using different titles. So it was launched as the Journal of Managed Care, moved on being the Journal of Integrated Care. I don't know for what reason, but they left that title. Then took the Journal of Integrated Care Pathways title, and since 2014, having me on board, they actually asked me if I wanted to carry on that title, and I chose for this title, the International Journal of Care Coordination. So I think that situates us a bit differently from the two other journals. I think as we are primarily interested in the interaction between people with a health condition, or patients and their caregivers, as well as healthcare professionals. So the micro level is probably the area where we pick up most of our manuscripts or articles. So you can see the title of the definition of care coordination as provided here. I always tell people, to check this paper by Ellen and Catherine, which was in the inaugural issue, at least when I started working as an editor for the International Journal of Care Coordination. Because if it doesn't fit within this title, which is a pretty broad definition though, I usually tell people that they have to look for another journal, because this is what the scope of the journal is all about. So there's one advice already for you: always check the aim and the scope of the journal. If it doesn't fit, then it's very hard to get it in. We publish 4 times a year, so every quarter. We are a member of the Committee on Publication Ethics, COPE, and recommend authors to follow the recommendations formulated by the International Committee of Medical Journal Editors, which I think is very useful for you to check if you are not just writing the paper by yourself, but if you're working with a team, you need to make sure that you set the right set of arrangements among the authors. Both the Committee on Publication Ethics as well as the Committee of Medical Journal Editors, I think, provide you with a lot of guidelines in that sense. There are no fees payable to submit or publish. We only, as all other journals, I suppose, we only accept original work that is not being considered for publication elsewhere. We accept different types of papers, original articles, systematic reviews, meta-analysis, study designs, leaders, tailpieces. What we do is, since we are focusing on this micro level, we request authors of original articles and systematic reviews to insert, well, at least, I was going to say, a separate paragraph about the relevance of study findings from a patient perspective. These are just a few stats. So the acceptance rate is about 1/3. The average time to publication is around 75 days. And the full text downloads, well, 2016 was an exceptional year because then SAGE offered people free access. So there are some arrangements between different countries and universities and SAGE. I believe, for example, the Dutch universities, they have free access to upload full papers, but that doesn't account for all countries or all universities. So 2017, 2018, we had around 8,000 full text downloads. Making an impact, yes, we are enlisted in different databases, ranging from the British Nursing Index database all the way down to Scopus. I think these days, if you want to make an impact, not just focus too much on the traditional databases, but also take into account Altmetric. So since you're all tweeting, maybe not, Altmetric, I mean, it's not just that your work gets picked up when it's published in a journal. It's also because you make use of social media and people find your article actually because it's referred in social media. And that is what the Altmetrics actually measures. We also work with Kudos. Kudos is actually, it's a free service which helps you also to make that impact, making use of Twitter, LinkedIn, and other social media platforms. And actually, I think these days, you know, if you don't want to limit yourself to the scientific audience, but also want to reach out to healthcare professionals, patients, community, etc., really think about how to sell your work by yourself, and Kudos actually provides you a very nice platform for this. There's an upcoming joint call for papers. So together with the Healthcare Management Forum, we are jointly producing a one-of-a-kind themed edition on transforming healthcare. So you're very much invited to submit your work. We're looking at the final quarter of this year. There will be a more information soon on websites of both journals. That's it. So please, once again, if you have very specific questions, you can send them to me, but usually I ask Jenny, so then maybe ask Jenny right away. Thank you so much.
Yeah. Hi, everyone. My name is Victoria Stein. I'm co-editor-in-chief of the International Journal for Integrated Care, together with Robin Miller here from the University of Birmingham and Nick Goodwin, CEO of the International Foundation for Integrated Care. And one big difference to the other journals is that we're a peer-reviewed open access journal. So you can download our articles for free, but you have to pay for it as an author. And we have an impact factor last year of 1.837, which is actually quite good for such a niche topic as integrated care still is. You can see that we've published about 50 articles, original articles per year, and 109 were submitted last year. So it's a similar acceptance rate actually as Bert's journal. We publish original research, policy, and integrated care cases, but also book reviews, PhD summaries, etc. So it's quite a wide variety of anything that deals with integrated care. And we try to be quite quick in publishing as well. We publish in real time, but we have 4 editorials and a quarterly edition basically per year. We also are really quick actually in rejecting, and part of that is because as co-editors we have a first look at all of the submissions, and at least 2 of us look at that, and then we make quite a quick decision, is that actually within our scope or not? And as Bert said, the first thing you should do when you submit or want to submit an article, read through the aims and the scope of the journal. And you wouldn't think how many and how often authors actually submit something where, in our case, integrated care doesn't even feature once in the whole text. So you do question whether authors actually have thought about where to submit. So make sure that it's actually the right journal that you're addressing. And you can see everything online. We have some special issues, and as you know, if you've been to our conferences before, we also, all of the abstracts that are accepted are published as conference supplements. We have some special editions around projects. So one of them is Project Sustain, an EU Horizon 2020 project, which just concluded. We have Project Integrate, which was another EU project, and we're still publishing some of the outcomes that came out of this project. And we have iCoach, which is an international project between Canada, New Zealand, and Europe, which looks much more around integrated care for older people. So there's a lot of possibilities of getting engaged also, and we do, as the International Journal, we do try to reach the whole world. But obviously, if you look at the submissions actually of where authors come from, it's really interesting. We've had, the majority comes from the UK, the Netherlands, Australia, and Canada, but there's also, we had a submission last year and a publication actually from Kenya, we had one from India, we have a couple from China, so it is actually, you can see also with the publications and the submissions how integrated care is spreading virtually around the world. This is all to the International Journal for Integrated Care, and before we go into the questions, I was asked to just give a few ideas of how the reviewing process works and how you actually can get published, how you can enhance your chances of getting published and getting through this screening process. As I said, in any journal, the editors-in-chief or the editorial board will make the first decision, is this within our scope, is it good quality, is it innovative? And this is also a possibility, at least we do that, to actually go back to the authors and say, well, we cannot accept it at the moment, but please, we are really interested in your work, so please, if you tweak here or if you add some information there, then we'll consider it for submission. And it gives you, as the author, a possibility of really getting good feedback even before the official review process starts. Once you are accepted, then it goes to the blind review, to peer reviews, and then, as you know, you get it back, you can resubmit, you can tweak it. It's very, very rare in our case that once you actually are sent to review, that we then get back from the reviewers, this is unacceptable, and we reject it. So last year it was only with 2 articles actually that we initially had accepted, and after peer review we said, okay, actually, we're sorry, we can't do that. The first question, of course, and Bert said that as well, is this within our scope? Is it integrated care? Is it care coordination? Does that have any relevance for the audience? And then apart from the question around, is this the right methodology? Was it innovative? It's really also about, could you provide some follow-up? Did you choose the right population? In our case also, we are looking much more to, have you included patients? Have you included families and caregivers? Did you actually reach out to other professionals? It's not enough anymore to make do some focus groups with nurses and ask them, what do you think of integrated care? That was okay 10 years ago, but now we really need to look much more towards interprofessional education, involving patients and communities. And we see that also in our journal and in the articles that are published, that we are keeping up with the developments, but also we're trying to set the pace and to set some examples and really highlight where are we going towards and what is it that we still don't know, and where should research also head. Very often when we go back to office and say you need to change something, it's about the transferability. Is this actually relevant for someone else? Whether it's in your own country, but also in other countries. What is it that we can actually learn from your research or from your case example? And that's with any journal. Really, you need to make a point of, well, what's the point of everything? Maybe you found out something for your locality, but what can we learn on an international scale, or maybe in a similar setting somewhere else, from the experiences and the research that you provided us with? So it's very much around that question. And in integrated care as well, this devious question around scalability. Can this move from a pilot to a program? Can this move from one locality to a regional program or to a national program? And that's a question that is becoming ever more relevant. And it's something that you also need to think about. Is that something we can prove? Is it something where we can shed more light on it? How can we scale? How can we transfer the findings that, that we've seen in our research or in our study? And then, of course, it's the audience. So you've heard 3 different journals, and you've heard how ACSLS is much more focused on getting out to practitioners and involving practitioners. We've heard from Bert that it's focusing on care coordination and not on the broader perspective of integrated care. So really asking yourself, who is it that I want to reach with my article and with my study? Who is it that I want to impact and influence? And sometimes that may be the world. Usually it's got to be much more specific, and that's a way of also defining what are the appropriate journals that I should address. Also, how international is my research? So there are some journals that are much more regional, for example, or European, or even national, while others, like ours, are really international and global. And which research methods did I use? We have, for example, at IGIG, we have a topic editor, Apostolos Theokristos, on health economics. But the health economics in integrated care is a very nascent field, and sometimes we send it back and say, look, this is an interesting health economics paper, but it's not really an integrated care paper. You should send it to a health economics one. So also thinking through, even though you may have addressed integrated care, but it's really the research or the methodology that is your key message, then you should maybe look into a different field and a different journal. And very simple, but do I actually comply with the journal requirements? I personally get really frustrated when I see articles and you see it's in the wrong format, it doesn't comply with the references, etc. This is really simple, and it's something that you don't really need to make that error, because it says on every website how the article should be structured and how the referencing should be done. So not doing that is just really also disrespectful towards the reviewers and the editors, because everybody does this for free. We're not getting paid for that. Also, actually, something that is interesting is, do I know people in the editorial board or authors that have been cited before in the journal, and can I reference them, or can I maybe also relate to their work, and so make a connection between work that has already been published within that journal? And that's something that you do look at when you're an editor, because of course, if you want to raise your impact factor, citations are really important about that. And once again, really look at the author guidelines, and usually it depends also on the kind of article that you're submitting, whether it's research, whether it's policy, whether it's a case example. There's different kinds of author guidelines, there's different kinds of structures. So really make sure that you know how to actually format and how to phrase your article when you submit something. Some of the underlying motivations of an editor and also a reviewer is, of course, for an editor, we do want to raise our impact factor, because whether we like it or not, whether we think it's okay or not, it's something that gets measured and that gets also gets acknowledged. And you look, of course, at who are the leading authors, who are the leading researchers, or the emergent researchers and the emergent topics that we want to get into our journal. So something that I usually also tell to my students is really go through the last year of publications in the journal and look at what's been published to get an idea what are the key topics that are currently discussed. Am I adding something there, or maybe am I adding a new perspective, or is it something completely different, a new viewpoint that I can add to this discussion? And as a reviewer, I have to say we've been really lucky in getting much better also in the quality of the reviews. These people do it because, first of all, of course, they're interested in the field. They're interested in keeping up to date. And I know it from personal experience that when you review an article, very often it's about something like, oh, I can actually use that, or that's interesting, I've never heard about that before. But of course, it's also about giving some of your experience, some of your also articles or publications as a guide to the authors. And it's a way also of staying up to date in what are the discussions that are currently going on. So keeping that in mind also, when you write your article, you need to tell a story. It's not really about your research methodology in the first place or the specific context. It's really telling the story of why was this relevant, why was this important, and what is it that you can learn from me. Because all of us, when we read it, this is what we're looking at. Is it actually something that is accessible and something that will be interesting for our audience as well? So to conclude, some of the common mistakes, as I said already, it doesn't fit into the journal, or very often the title and the abstract don't really fulfill the expectations and the promises that you've set out. There's a lack of background information, and we don't need 10 pages of your health system, but you need to provide the context of what kind of service providers, what kind of reform, what kind of system are you dealing or talking about. The methods are not well explained. That is very often a problem because, as you should know, you should be possible from reading the article to replicate the study. So if you don't explain your methods well enough, then that won't be possible. But it's also just an information. We are such a mixed methods approach in integrated care. It's also about being very clear of how did we mix qualitative, quantitative data, and how did we actually get the data that we used. As I said, this storyline very often is lacking because you only focus in maybe on one point, but are not telling the overall story. And very often there's a missing discussion around what are the strengths and what are limitations, and where can we go from there. Sometimes conclusions are missing completely, but if they are there, it's interesting to read that all of a sudden you introduce new ideas and you tell us about things that haven't been discussed or haven't come out of your article at all. So again, really reading through the whole thing as one story that is to be sold and is to be distributed to an audience is really the main message to get a good article and also to get published and get through the reviewing process. So with that, I hand over to Moody and we'll open some questions.
Thanks, Victoria. Apologies for that. I was just opening up the facilitated discussion questions. So if at any point people want to ask specific questions to the editors, feel free to raise your hand. But I've just prepared a few questions here. So I'm sure you've seen that there's quite a few different types of papers that come out, sometimes with multiple authors, sometimes with single authors. So would you say that the order of the authorship matters? And as a first author, what types of responsibilities come with that? Yeah, it's open to everybody.
Yeah, thanks for the question. Yes, it matters. To put it quite frankly, the first author usually does the hard work. The second and the last author usually are the ones who are closely supervising not just the writing of the manuscript, but the entire research process. And anyone else who contributes, but who really contributes, qualifies him or herself for a position in between the third place and the last place. Yeah, and also in terms of not just for submitting the manuscript, because also the communication over the manuscript, usually I think the first author usually deals with all the communications, but also for your own interest, if you are into research, because why would you otherwise submit your manuscript to a scientific journal? Also the positions of on a manuscript do count big time.
If I just add one thing, I think what needs to be clear, we might not sort of like ask you for evidence of this, but it needs to be clear for your own writing, is that everyone who is actually on the paper needs to have made a significant contribution to the project that you are sort of like reporting. That's very, very important. And contribution in this sense means not just reading the final paper, but actually either a contribution in terms of design, if this was a study, design, data collection, analysis, and write-up. So if none of these things have actually happened with that particular person, then the person probably shouldn't be on the paper. Now, that's a thumb rule, of course. You know, there are some other things people can do still to get on the paper. You know, statistical support, etc. But it's important that you make that clear before you start writing the paper, who's going to be on it and what sort of their contribution will be. Now, in medical literature, usually, apart from what Bert said, the first author is usually the one who's writing. Usually, in the medical literature, the project lead, the principal investigator, goes last, unless that person is actually writing the paper itself as well. But that's not really commonplace in our journal. I'm not quite sure what it is in your journal, but you can still adhere to that rule if you wanted to. That's not a problem for us, so that it's recognizable that the PI is in the last position of the sequence of authors. Okay.
So for emerging researchers, a lot of the times we do end up doing the brunt of the work. And what ends up happening when you haven't quite found your voice yet is that when it comes to authorship, it's a little bit hard to maybe push a little bit and say, hey, I actually did write the whole manuscript, how come I'm not first? So I guess I'm wondering, is it common to see disputes over authorship, and if you could offer any mitigation strategies?
Well, I think it's a very true and it's a very good question. I personally was always very lucky that my professors, when I wrote my PhD, always acknowledged that I'd be the first author. Mm-hmm. But that's not common practice, and I know that. I think it's very much on the professors actually to recognize that you need to also support your emerging researchers and your young researchers in being published, as long as you ensure that it's the right quality. I'm sure that there's a lot of, or there might be discussions, and there are professors who just expect to be, but usually they expect to be last authors and not first authors, is my experience as well. And I also think that it's slowly changing, I have to say, in that, first of all, your generation is so much more demanding than previous generations were, which is good, absolutely. But also, I think it's also a fair question for you to pose and to say, look, I've put in a lot of work. You've helped me develop it, you've guided me, but actually it should be me as the first author and you as the last or the second author. I don't know.
Yeah, I think there's a bit of sort of like entitlement, kind of like tussle going on sometimes, but actually I think we all just have, as senior researchers, we have to be generous, I think, with early career researchers, especially nothing is perfect at that stage, and we really need to give them, you know, the help they need and the support they need to get through this. And that's also what the journal editors, Victoria, would do as well. You know, if you have a question or if you have a problem, you know, how to actually formulate it, how do I get beyond that outline? Do get in touch with us. You know, that's a really important source, hopefully, of information and help as well.
So you've also talked a little bit about impact factors and how the different journals have different scores. How important is that when you're actually selecting a journal? So say you have a journal that is maybe 1.5, but then it's an open access journal, and then you have another one that is a closed access journal, or like say something like Nature, which is really high. And congrats to you if you've ever published in Nature. But I guess, how do you go about selecting a journal based on impact factor, and should it even matter?
Well, it does matter, because usually that's how you get funded, or that's partly of how universities also evaluate you as a researcher, and whether you get funding or not, or whether you are promoted or not. It's so yes, I think the question here is, it's back to you as an author. What is it that what do you need, really? Is this an article that you do because you're convinced of it and you want to publish it no matter what, and you want to select then maybe a journal that has not such a high impact, but you get it to the relevant audience? Or is it an article that you really need to look at the impact factor because it's maybe also part of a bigger project? It's part of a university funded project, and so you need to prove to the university that you use the funds wisely as well. So I think it's a very difficult line. I know at many of the big universities it is still one of the biggest defining factors of where do I submit first, really.
I probably see it as slightly more sort of like subtle. What I would say is the various publishers moving to various different approaches to the impact factor. Now, there's one impact factor that's obviously, you know, the one that IGIC has, and that's simply number of citations divided by, you know, sort of I think it's the count of articles over 2 years. Now, that's a technical one. I recently published a Cochrane review. The impact factor is 6 point something. Does it matter? Actually, in my field, for the ref next year, that's a sort of like research assessment framework. Next year for my university, actually it doesn't, because I'm in nursing. You know, the impact factor doesn't really matter. Is it a great publication? Probably it's okay, you know, but I'm more proud of some of the things that I publish in my own journal or other journals that are more text-based than this sort of very highly structured Cochrane review. So it's really about what you want to do, who you want to reach, and how can you reach that particular audience, that readership. That's very, very important. And I think you can, again, have that discussion with Victoria, Bert, and myself. You know, where do you want to be with that paper? And I think that's important, a conversation to have.
Let me put it very bold. The impact factor is really old school thinking. So I do know that a lot of universities and that maybe a lot of your fellow researchers, they do regard the impact factor as an important quality indicator. Please let them look at the Declaration of Research Assessment signed in San Francisco a few years ago. I think it's gradually changing, so that's DORA in short. I can't recognize that there's still a lot of emphasis on the impact factor. But really, Altmetrics, Kudos, and so on. So there are so many other platforms. Look a bit around you and start looking at some other indicators as well.
Thank you so much. I guess I'd like to maybe open it up to the floor if you have specific questions to the editors.
Is it important how many years after doing the research itself I'm trying to publish it? Because I did my master's degree like 6 years ago. I tried to publish it a year after it. It didn't get accepted, so I dropped it out. And my professor is always asking me, what about it? And I'm like, it was 6 years ago. Of course, it is still important to publish it, but is it? They would say it's like from 6 years ago, the data collection, so.
That's a very relevant question as well. Thank you for that. Yes, we definitely look at that. And I would say it depends a bit on what kind of research you did. So for most of the studies, we would say that it's too long ago. But if it's more conceptual, for example, or if it's more something that that has impact, that is still relevant, then yes, we would still say, even though it's maybe 6 years ago, but it's still relevant, it's still answering questions that we're asking ourselves, we would still publish it. So it depends also a bit on if it's a very data-driven set, then it's probably too old. But if it's more of the conceptual or a case study, for example, then often what we do is we actually go back to the authors and say, this is 6 years ago, could you please just add some text or explain why did it take so long? And is there some kind of at least follow-up in the discussion to say, this is what happened since?
Any other questions?
Can I just say thank you very much to IFIC, actually, for inviting us and giving us an opportunity to share this with you. And, of course, do get in touch.
Absolutely, and I think with that, it's time to close because we do have another session opening up here. So thank you, everybody.
Thank you.
Jerusalem bells ringing, Eusko Jaurlaritzako osasun sailburu Andre Agurgarria. Gipuzkoa Aldundiaren gizarte politika diputatu Andre Agurgarria. Donostiako alkate Jaun Agurgarria. Jaun Andreok. Arratsaldeon. Ifikanen izenean atsegin handiz egiten dizuit ongi etorria arreta integratoru buruzko nazioarteko biltzarraen edizio berri honetara. Atsegin hori are handiago eta arrazoi bategatik. Biltzarra aurten Euskal Herrian egingo da. Bere bertazu aparteko agatik, hizkuntzu agatik eta kultura agatik hainbeste miresten dugun herri honetan. Eta ez dugu haut behar gainera, berrikuntzaren eta arreta integratuaren eredu berrien edapenari dagokienez. Gure herri honi lidergoa, aitortu eta errespetua aieratzaren zaiola nazio artean. In welcoming you all to this new edition of our AFIC conference, I cannot avoid recalling and paying tribute to the small group of people back in 2000 that created our journal. In their minds was the need of advancing the science and knowledge about integrated care, and perhaps more importantly, to promote adoption. 19 years later, the Foundation still lives up to these principles, but we have been able to incorporate new perspectives that widen our understanding of what matters to patients and allowed us to better serve people and communities. Esta es la realidad de IFIC hoy en día, y el programa de esta conferencia recoge en variedad y densidad esta riqueza. Espero que todos ustedes puedan disfrutar de estos días. Y sin más, me gustaría pasar a la abertura oficial de esta conferencia. Tiene la palabra el señor alcalde Eneko Goya.
Sailburua, diputatua, agintariak, lagunak, arratsaldeon eta ongietorri Donostiara. Dear participants in the Congress of the International Foundation for Integrated Care, on behalf of the city of San Sebastian, welcome to our city. I hope you will enjoy those days. San Sebastian receives you with our best hospitality.
I truly hope this conference that will channel health or look into integrated care will be a milestone for all the experts that will participate in it. Some of you probably have already seen that the icon for, or the logo for this conference is a symbol that shows our territory, which is a kind of a boat used for whaling back in the day, with a crew led by a patron, by a master. With this boat, we wanted to symbolize the essence of the word that integrated care means, which is very much needed in a joint way, having several stakeholders all on the same boat, rowing on the same direction and under the command of a good master, and without forgetting what's the ultimate goal of integrated care. Nothing but to improve quality of life and the health of the people. I truly hope these few days will be a source of inspiration, and that all of you that are part of this conference will go back home with the idea and the feeling that this has been very useful 2 days or 3 days to help other people's lives. Thank you very much.
Thank you very much.
Tendría ahora la palabra Nick Goodwin.
We now give the floor to Nick Goodwin, who is the General Manager at IFIC.
Oh, goodness, how many people. Welcome. It's a great pleasure. Thank you, Mr. Chair. Thank you to the Mayor and all of our distinguished guests for being here today. Thank you to you, ladies and gentlemen, for coming all this way to San Sebastian. Some 1,400 people registered today from 60 different countries. It's very humbling. As Albert mentioned, we had very small beginnings in that original meeting, which I remember some nearly 20 years ago. Maybe there were 14 or 15 us in a very cold Dutch polder when the wind was blowing. And we kind of had this idea related to how do we solve today's public health problems through practical solutions. And we thought through some of the ideas around that. And integrated care was the name that we came upon. And I think all of those founding fathers who are not here today, seeing this group of people here, politicians, academics, researchers, practitioners, people working in industry, coming together into one place to have a conversation, to share knowledge, to share experiences in what is a very appreciative and still quite an early field. Today is our 19th conference. That means we're still teenagers. We're still in the growing pains of working through what integrated care really means. And once we've kind of gone through school and kind of now have an understanding of integrated care as a concept, I think we're still trying to find our way in terms of how we can further the implementation and meet the challenges of transformational change that all our healthcare systems need if we're going to grow to meet tomorrow's challenges in a sustainable, equitable way. So our foundation has kind of begun to change its mission from just bringing people together to share knowledge and experiences and to drive forward the science and the knowledge of integrated care, to really beginning to focus on all of the different challenges that exist in terms of implementation and in terms of finding solutions to today's problems. Very much going back, as Albert said, to those original meetings. And I'm really looking forward. Being here in the Basque Country is one of the leading countries, leading parts of the world that has really taken integrated care forward at a policy level. And we salute all of the efforts that have been going on here. And this is my fifth journey. So it's just for me to welcome you all here. We're very humbled that so many people are now joining this movement for change. And I look forward to meeting you all over the next 3 days. And I hope you have a very enjoyable experience. Thank you very much.
Thank you, Nick. Gracias, Nick.
Thank you, Nick. I'd like to call Mrs. Maite Peña so that she can address a few words for the opening of this conference.
Bai, Sailburu Andrea, Alkate Jaunoa, agintariok, lagunok, eguerdi on guztioi. Segurazki gaur egun esku artean daukagun erronka nagusiena da nire ikuspuntutik behintzat gizartearen zahartzaroari aurre egitea.
Dear participants, we'd like to give you a warm welcome. We are so happy to have you here. We will have more than half of the population that will be more than 65 years of age in a few years, and a lot of people, more than 80 years of age. We will live longer, but we will live better, and that's what we want to achieve. For this purpose, we have to gather our forces, our strengths, and work in collaboration. For this reason, there's a great challenge in front of us. Innovation should be at the center, and we should use it. We in the provincial government of Gipuzkoa, we in the administration, we know that older people want to stay at home. They want to be at home. And the secret is coordination. Coordination between primary and secondary care, both in health services, in social services, and in both systems altogether. In Gipuzkoa region, we have an integrated strategy to face up the challenge of aging. It's called Adunberri, That's the name of the strategy. We're going to reinforce our innovative potential in Gipuzkoa. But there's no other way than using coordination between the various systems. That's why this Congress has so much importance. It's a great opportunity to put the focus on the health and social care system and integrated care, and to know the best practices, the best for us, the best projects, best evidence at world level for integrated care. We are sure that just through the test and error methodology, which is the secret to innovate, through that we can improve our health and social care coordination. I mentioned dependence as the priority challenge for us, but we shouldn't forget other domains that require this health and social care, especially for minors with special needs, the challenge of social inclusion. They all need us, and the path is already there in front of us. We need to cooperate, collaborate. Thank you very much. And to end this opening ceremony, I would like to ask Nekane Murga. She's the Minister for Health in the Basque government.
Eguerdion guztioi. Good afternoon. Ongi etorri. Welcome to Euskadi. Ohore bat da niretzat, jardunaldiaren hasiera ekitaldian parte.
I'd like to welcome you to San Sebastian and to open this ISIC Congress. This is a great opportunity to share our knowledge on integrated care. It's one of the main strategic axes of our government.
Basque Country. We are very pleased that the International Conference on Integrated Care takes place in the heart of Basque Country, Donostia, beautiful and full of kind people city. Integrated care is one of the main strategic issues of the Department of Health of the Basque government. This meeting will allow us to generate and share knowledge about integrated care. Tengo el gusto de inaugurar.
I have the great pleasure to open this 19th Congress on ISIC 19 San Sebastian Basque Country. For all the people who participated in the organization, this has been a great challenge for the very high level of previous congresses. This meeting, under the title of A Shared Culture for Change, assessing and implementing people-centered models, has been possible thanks to the collaboration and joint work of the Provincial Government of Gipuzkoa, the City Council of San Sebastian, and the International Foundation of Integrated Care and the Health Ministry of the Basque Government, but thanks also to the personal effort of many of you. I have to underline the great effort that the Scientific Committee has made. They have been working for more than 1 year now so that this Congress could happen. I'd like to mention the speakers, the facilitators of a very high scientific quality. They found a place in their agenda so that they could be here and share their knowledge and expertise. Other protagonists of this conference, you all participants, all professionals that have fantastic projects, things that you are already doing in your daily practice. You are going to participate in workshops, in presentations, posters, debates, discussions, plenaries. Your experience is very useful, especially if we can share it. You are the soul of this meeting. You people who came here because you want to improve in your work, because you're curious, because you want to know other ways of working, because you're ready to introduce changes in your organizations, adding value to your organizations, and what's more important, helping families, patients, and carers. Thank you to all of you, because you have course to do after this meeting. You have chores to do after this meeting, and because you will have many people to implement changes in the future. Looking in perspective, in the last few years, the most important element in the transformation that happened in our health system was the integration of care. It has gone beyond of mere management. We are in the middle of an organizational change, but what's more important here, a transformation in the way of doing things, the way of caring for people. We have less fragmented caring models. We are centered on needs. We want to give well-being to people around us. We want to obtain performance and results in health, and sharing all this with the population. Out of evidence, we know that the organizations that carry out integrated care obtain better results. They give more quality and efficiency. This is what is pushing us to facilitating coordination, communication, and teamwork in primary care, hospital care, and in social services. Today's challenge is to transfer integration in a coherent way to all domains, in financing, in the organizational structure, micro and micro, in service provision, and to all processes. One of our main challenges is to deal with chronicity, aging, dependence, many other challenges that we are facing. Our Ministry of Health and the rest of institutions that are here today, provincial government, city council and others, all of us, administrations, we have major access for action, especially health and social care coordination. This is the proof. Basque institutions, we are responsible for gathering all this knowledge and expertise and transform it into policies that can give answers to what society is asking. We should do that together. We should be rowing in the same direction. This is the symbol of this trainera, the whaling boat that has welcomed us in Kursaal Palace. I am really convinced that all contributions coming out of this forum will help us to improve integrated care and our health services in the last few years in the Basque Country. Finally, I would like to end by referring to the image of this Congress, the trainera, the whaling boat. It shows us that rowing together, all the professionals in teams, we will advance and we will give a better quality of life to our population. Together, all together, rowing together in the same direction, we'll do it, we'll succeed. And without further ado, I would like to officially open this conference.
Thank you very much.
Muchas gracias.
Thank you very much. I'd like to thank the Health Minister of the Basque government, the mayor and the person responsible of social services in the provincial government. Thank you very much for this opening ceremony. And now we'll have the first plenary session in a couple of minutes. Thank you.
Si acaso les decimos dónde se tiene que sentar. Cuánto móvil que tengo yo aquí. Me sobran móviles. Puedes empezar.
Bueno, arratsaldeon eta ongi etorri arreta integratuari buruzko nazioarteko.
Good afternoon and welcome to this international conference. It's a great honor for us to host this congress in the Basque country and in San Sebastian. We're so happy to have you here today. For me and for my colleague Tony, it's a great honor to be here. Our main goal today is that in the next 3 days you will enjoy not only the city but also debates, reflections, meetings, workshops, and I hope we will learn a lot of lessons here. Welcome to this 19th International Conference on Integrated Care. We are so pleased to have you here in San Sebastian. This is a pearl in the world, the small city of San Sebastian. For me and for Tony too, my facilitated colleague, it's a great honor to be here together with all of you, so many people. And we invite you to have 3 days, fruitful days with debate and discussions.
And I would like to say, arratsaldeon, buenas tardes, good afternoon to everybody. And this is the start of 3 exciting days, and it's a privilege for us to have 2 stunning and brilliant speakers. We will listen to 2 angles of integrated care in this plenary session. The WHO conceptual framework on integrated people-centered health services and transformational change needed for its implementation. And we are going to listen as well to the adoption and implementation of integrated care in the Basque Country. So, as you can see, international and local evidence shows us that there is a movement for change. And the movement for change, we are the movement for change. You are the movement for change. But I would like now to engage all of you to the discussions and to the engaging to all the questions that you have through the means we are going to use. And the means we are going to have, as you've seen, we've got an app that I invite you to use the app as much as possible. Secondly, you can follow all the Twitters that we launch, but I would like you to participate and be engaged as well to disseminate all what's happening here through Twitter. But what we've got today is a surprise for you. So we are going to use something called a Slido to connect with the chairpersons, and then as well for the people who are more shy to be able to participate using a Slido in the workshops, in the sessions, in the plenary sessions as well. So I would like to encourage you to look at Slido. And what's a Slido? The Slido is spelled SLIDO.com, and then I would invite you to start using this thing. How can we do it? This is very easy. This will be a warm-up session for breaking the ice for you to be engaged during all the conference using a Slido as much as you can. So it's very easy. I'm going to, some people know it. So what we are going to do, you go to your mobile telephones, your iPads, or even in your laptops. You can look at the website to slido.com, 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 y entonces ponéis
I see 19 without the slash, without the hashtag.
I see that 8 people have already joined, so we are going to encourage you to download a Slido. And as you can see on the top left of the screen, there is a number. So I guess there are more than 13 people in this room. So let's see if you engage and you participate. So now we can see what conference track are the most excited about. So this is the question we ask you today. And on Wednesday, we are going to repeat the same questions. And we would like to know what can you bring back home and if your opinion, the opinion of the most of you, has changed. So I think it's going pretty well. More than 57 people, 61 people. So 67 aurrera for the...
Come on, more people, more Basque people, more people joining.
To at least 200. This is our goal, 200, so we are 110. You can see now that the whole system transformation interests to many of you, followed by digital health. Then it's quite static. We've got 138 people, 144, well done. So let's see if tools and methods for supporting integrated care was doing pretty well. Digital health now is the third position. So we are almost at 200. I encourage you to join. I think it's easy. Most of you can do it. 200, this is pretty good. Well done. Sorry?
The password for the Wi-Fi. No idea.
It's ESIC. Which one?
ICIC, and then the password is 2019.
2019, yeah.
ICIC y la contraseña 2019.
Yeah, so we are 254, 257, 260. So as you can see, the whole system transformation is in the lead, tools and methods for supporting integrated care. So what happens with policy development? Aren't there policy makers here? So palliative and end of life care, education and training is the last. So 292, 295, 297, almost 300, you are doing pretty well.
Great benchmark, international benchmark in integrated care. It's a real pleasure for me to be here today in Donosti, accompanied by so many experts who have made great advances in the area of integrated care. And when I speak of experts, I am not only talking about the academic world, I'm also referring to all those managers, decision makers, health and social professionals who contribute on a day-to-day basis to the fact that integrated, person-centered, integrated care is gradually becoming a reality. And of course, it's a great honor to be surrounded by many colleagues and friends from the Basque health system, with whom I learned that there are no shortcuts on the road to integration, that perseverance and optimism are two great allies in the transformation of systems, and that, in fact, I understood that we can only reach the goal if we know how to play as a team together. Without further ado, I'm going to focus on my presentation. A presentation that I'm going to do in Spanish because it's one of the 6 official languages of the World Health Organization, the organization that I represent here. This is the title of my presentation, How we Transform Health Service Delivery so that care is integrated and person-centered or people-centered. Probably the how is the most complicated question when we try to answer the questions regarding transformation and provision models. Obviously, it's not the only question we've asked ourselves over the years. Why do we need to transform provision models? What do we need to do? When? How? This has been the object of research and discussion over the last few decades, and I'd like to make a short review of all of them, of all these questions, before going into the subject and into the discussion about the hows. First, the first question that we ask ourselves, why do we need to transform service provision? We know that the global health context is full of challenges that we all know, such as aging, the rise of chronic diseases, not only in rich countries, but also not only in rich countries, what we normally know, but also and more in developing countries. Urbanization, globalization, rising costs, all these are challenges that are transformed into a series of demands. All these demands are very well known by us. And what I'm talking about here, I'm talking about unhealthy lifestyles, the double burden of disease, transmissible and non-transmissible, growing need for self-care, mobility. All these demands, all these needs cannot be responded by today's health system. Why? Because basically these systems are fragmented. They are centered on hospitals. They don't take care of individuals, communities. They have few staff. They are poorly distributed and without adequate skills. Fragmented systems. That's a reality that we are facing. A reality in which up to 40% of health spending can be wasted. A reality in which 1 in 10 hospitalized people suffer from harm during their hospital stay, and a reality that implies that half the people in Africa consider that their level of participation in health services decisions is very low and very low. All these are powerful reasons that force us to rethink not just the configuration, but the functioning, the operation of current health systems. The second question is the what. What do we need to transform? In this sense, there's a wide global consensus regarding two critical aspects. On the one hand, the need to place the individual, the family, the community at the center of health service provision. And on the other hand, the need to consider the transformation of service provision as part of a broader reform of the health system as a whole. In 2016, 194 countries adopted the WHO's People-Centered Integrated Care Framework. This is the framework that proposes 5 big transformation areas. First, it's about involving and empowering individuals and communities so that they can have an active role in all aspects related to their health and health services. On the other hand, strengthening governance and accountability. Thirdly, to reorient, to refocus the model of care, basing it on strong primary care, so that it is on the optimal place in order to maximize results and health results, but also efficiency. A care model that has to be based on very strong primary care. A primary care that, according to a Lancet article, can reduce preventable mortality in mothers and newborns by up to 77%, preventing the death of more than 3 million people each year. So a primary care system that should be coordinated with the rest of the levels of care, within and outside the health system, highlighting, of course, its relationship with the social sphere, but without forgetting the necessary collaboration with other key sectors, such as housing, education, employment, so that we can tackle the structural determinants of health in an effective manner. And finally, we need to guarantee an environment of favorable policies where these transformations can be developed. The third question, when and where do we need to reform service delivery in a sustainable manner? The answer is clear. We need to reform service delivery in all regions of the world, from Norway to Papua New Guinea, from Benin to Afghanistan. Fragmentation and other constraints in health systems prevent people from receiving care designed around their needs. The good news, the good piece of news is that in all regions of the world, there are initiatives that seek the transformation of care models, people-centered care models. These initiatives have obtained successful results. However, these experiences have not always succeeded in maintaining long-term results and to develop them on a scale. This is the crux of the matter. We cannot only put the focus on transforming service provision and care models. We need to do it in a sustainable manner and beyond successful experiences at the local level. And now, the how. How can we transform service delivery in a sustainable way and with a scale? The answer is very simple and very complex at the same time. It's called transformational change. There are many definitions of transformational change, but I would underline this definition proposed by Lee and Weiner and colleagues. They define it as an intentional, multidimensional change that radically moves away from the past in search of adjustments that have to be made to scale. There is a key element that I would like to highlight in this definition, the concept of radicality. We speak of radical change, and that in our language would mean moving from white to black or from black to white. In our health system, what does it mean? Going from fragmentation to integration, from ignoring individuals and communities to fostering their participation and empowerment, from models where the hospital is the reference to models where primary care is the pillar of care. But beware of the word. This word, radical, is sometimes misunderstood. Radical change does not mean change overnight. Radical change does not mean changes that occur all at once. It's not a big bang. But rather, as evidence suggests, in practice, transformations consist on a series of experiments that are implemented, adjusted and scaled over time. And there are very few cases, I dare say none, in which the redesign of care models comes out 100% right at first. We know that countries like Brazil or Thailand, among others, have been able to increase access to quality and integrated services for their populations through transformational change. It's a complex concept. We need to put the focus on technical content of reform, but also we need to consider other variables. Brazil and Thailand are success players. They considered, apart from theoretical content, the creation of a favorable context. They considered the participation of key actors and the development of processes that facilitate the implementation at scale. Let's analyze these four variables. What can we learn from these success examples? Successful transformers. Let's start with context. This is going to depend on the ability of politicians and the health systems to abandon an old paradigm, the paradigm of we're going to do as usual and we're going to use another slogan. Let's think outside the box. We know that reforms have to have a privileged place in a political agenda. They have to have great commitment on decision makers. This is very important. Reforms shouldn't be done in an independent way. They should be part of a broader social agenda, because people can contribute a lot to society at large. Reform needs leaders, transformational leaders. Leaders that are able to exercise a distributed leadership between the various organizations. Leaders that are able to promote collective commitment, good communication, transparency, and basically the work in teams, and we need leaders that are able to manage change in a proactive way. It's improbable that people-centered integrated care will emerge in a natural way as a solution to problems and limitations that we have all in our health systems today. Transformation has to be guided by a narrative, by a vision that is attractive, an attractive vision and a shared vision, as Peter Senge said in the 90s. This goes beyond the world of ideas. It's more material. You can touch it. It's the strength in the heart of people. Power is focused towards action, not just individual action, but towards collective action, basically. In countries that are really transforming countries, the minister, the finance minister, has always asked the same question: how much is this going to cost, this transformation? Transformations is not free, so they will need initial funding in order to make investments in primary care, especially, yes, but not exclusively. In low-income countries where structures are scarce, investing in new human resources, new skills, sometimes outlays to promote the positive result. We have good news here. What we expect is that efficiency improvements, thanks to integrated care, will compensate the initial outlays at medium and long term. Who are the actors that we should involve in the process? Well, all the key actors, and here I'm talking about users, health managers, social professionals, health professionals, universities, civil society, the communities at large. In each and every phases of change, these people should be involved. There's a key element that we normally tend to forget. It's the members of parliament. The politicians, they need to understand the content of the proposed reform and make it their own. In general, social services and health services transformation shouldn't be associated with specific ideology. Integrated care should consider as a transversal axis of action beyond specific political tendencies or trends, regardless of the political party in power. There's possibly nothing as important to successful integration as the support, the trust and the commitment of health and social professionals, who are often said to tend to resist change. However, as early as the 60s, Everett Rogers showed that not all humans respond equally to change. And he showed us that, in fact, there are two groups, innovators and early adopters, who, to varying degrees, promote and are enthusiastic about the idea of change. Today, it is virtually impossible to imagine an organization or a health system that is exclusively composed of laggards or a very late majority of people. Honestly, I don't know any. All organizations are moving forward. What would be the challenge here? To identify those who are at the beginning of the curve and to involve them more actively, to involve change leaders, to involve clinical leaders, so that the rest of the groups will follow once they listen to very positive reactions to change. What have we learned about success stories? Before agreeing on the content of the reform as such, they carry out a participatory assessment of their health system with a view to identifying existing opportunities and barriers, achievements, but also good practices, with the general aim of establishing priorities, which will depend to a large extent on society's preferences and acceptability.
WHO, we have developed LEAP, Local Engagement, Assessment and Planning. This is the tool that will allow us to carry out this preliminary assessment. We have other tools, the Sirocco tool, developed by European partners, that will be very useful to us in order to carry out this prior assessment. In terms about the what to reform, it's necessary to focus on multiple tools and interventions that affect the three levels of the system, macro, meso and micro. So we will need to invest in macro policies. We need to implement leverages. Leverages change affecting regulation, funding, payment systems, information systems. And that will make it possible to lay the foundations, the pillars of new provision models. With respect to the type of interventions that we can implement at organizational level, at clinical level, there is abundant evidence on the key elements that must be included in the models of integrated care, and on those that we have learned throughout the different editions of this Congress. Thus, we speak about protocols, case management, sharing opportunities, and sharing everything that has helped us to improve efficiency. Well, so we have an assessment and identification of the strengths and weaknesses. We've defined priorities. We've defined the content of the reform. What's left there? We need to define an implementation plan that is sound, that is accompanied with measurable goals that enables us to measure efficiency. What does evidence tell us? The evidence tells us that the existence of a plan is not going to assure us success, but without a plan, failure is more than assured. Three adjectives will define the transformation process: complex, difficult, and long. The path to integrated person-centered care will be different in different contexts. Each starting point is unique, and each system will have to deal with its
y que pueden inspirar nuestra agenda de transformación. Sin embargo, hay que ser más atrevido y no fijarse solamente en las historias de éxito, sino también aprender de las historias que han fracasado o aquellas que no han conseguido los resultados esperados. Pues podemos extraer lecciones sobre lo que no deberíamos hacer, y esas lecciones son igualmente importantes. Pero el aprendizaje no solo debe ser externo, sino que además y sobre todo debemos aprender continuamente de nosotros mismos, tratando de extraer la inteligencia colectiva de nuestras organizaciones, de nuestros profesionales que están en la batalla del día a día, con un conocimiento profundo de lo que funciona y de lo que no funciona, de por qué no funciona lo que no funciona y cómo hacer que las cosas mejoren. Así, el enfoque de abajo a arriba no solo debe complementar, sino además debe guiar los enfoques que se planteen de arriba a abajo. Y no deberíamos acabar esa sección sin hablar de culturas organizativas y de cómo los valores que las subyacen pueden realmente influir en la transformación deseada. Sabemos que los transformadores exitosos invierten en crear un conjunto de valores compartidos, valores que van a permitir orientar la toma de decisiones por parte de los diferentes actores involucrados. ¿Y cuáles son los valores asociados a la atención integrada y centrada en la persona? Un trabajo de Nick Zonneville y Mireia Mickman, basado en el marco de atención integrada de la OMS, sugiere un listado de 18 valores, valores que deberían fomentarse a nivel de sistema y a nivel de organizaciones. Valores fundamentales como transparencia, confianza y respeto están en esta lista, pero no deberíamos obviar otros valores fundamentales, tales como la innovación, la flexibilidad, la sostenibilidad, que sin duda van a ser clave para poder implementar la atención integrada y centrada en la persona en la práctica. Y acabo con nuestro logo, Dare to Transform. Atrévete a transformar los sistemas
Dare to
sanitarios
transform
en
health
sistemas donde
systems
la atención primaria
so
sea
that
el eje
primary
central de
care
la provisión de
will be
servicios,
the
donde las
main
personas
axis
y las
of
comunidades
service provision, where
estén realmente
people
en
and
el
communities
centro.
are really at the
Sabemos que no será
center. We
fácil,
know that
pero sin
this is
duda
not going to be
merecerá
easy,
la
but
pena
it will be
intentarlo.
worth.
Eskerrik asko.
Thank you very much.
Gracias.
Bueno, gracias, Nuria. Estupendo, como siempre.
Thank you, Nuria. Wonderful,
Nuestro
as
siguiente
usual.
speaker es Iñaki Berraondo. Para muchos de vosotros quizá conocido, pero para muchos otros seguramente no. Iñaki es médico de familia de formación y actualmente es nuestro viceconsejero, uno de nuestros dos viceconsejeros en el Departamento de Salud. Inicialmente formado como médico de familia, luego fue director de atención primaria en la Dirección General del Servicio Vasco de Salud, OSAKIDETZA, y desde allí pasó a ser gerente de un hospital y, como él mismo dice, tuvo la suerte de liderar el proceso de integración o de creación de la primera OSI en el País Vasco, la OSI Bidasoa. De allí, de OSAKIDETZA, pasó al departamento donde está ahora y donde ha trabajado en proyectos que, bueno, seguramente a muchos de nosotros nos suenan y que han sido bastante importantes, como el plan de paliativos o el contrato programa. Así que cuando quieras, Iñaki, por favor.
Eguardion denori. Good afternoon, ladies and gentlemen. Bueno, yo voy a hacer mi exposición en castellano.
Good afternoon, everyone.
Más que nada porque quiero que me entiendan y mi inglés todavía es
Since I
un
don't
poco
speak
básico.
English, I think I rather
Bueno, en primer
speak
lugar quisiera
Spanish.
agradecer
First of
a
all,
IFIC la
I'd like
oportunidad
to
que nos
thank
da el departamento y a OSAKIDETZA
IC for the
de
opportunity given
presentar
to my
aquí esta
unit
tarde
to be here.
el trabajo que venimos realizando en los últimos años, casi 10 años, en atención integrada. Agradecer también a Maya y a Tony su presentación y, cómo no, decir que estoy encantado de compartir con Nuria esta mesa hoy, o este plenario, porque juntos también trabajamos en el primer proceso de integración que se dio aquí en Euskadi, en concreto en la OSI Bidasoa. Mi exposición va a bajar un poco al terreno operativo. Nuria ha hablado de grandes conceptos muy globales, y yo voy a intentar dar respuesta a algunos de los interrogantes que ha puesto o sobre los que ha basado su exposición, dar la respuesta que hemos intentado dar humildemente en el País Vasco, porque, como verán, es un proceso muy complejo, muy largo.
Time-consuming, as it's been said, and naturally still uncompleted. A long way ahead of us, even though we feel we've achieved significant results. So, again, as I said, I will go down towards a specific in a European region, that's the Basque Country, with over 2 million inhabitants, with a high level of financial devolution. So, part of the budget has been used to move towards public health and social care, which is public, universal and high quality. And that way, we've reoriented our system towards integrated care here in the Basque Country. My lecture will be broken down into two. First, I'll try to explain how we've changed this healthcare system, the delivery system in the Basque Country, and then I will focus on complex patients, as it is the topic for integrated care. Well, there's no news here, but that's as good a starting point as any other. And this is the challenge we all have, adjacent countries as well, the demographic challenge, sustainability challenge as well, because of the aging, which is known as a pandemic now, and something very common, which we used to have and still have, especially I'm referring to the first decade of the century, 2000 to 2010. It was a fragmented care. We would have primary care, secondary care, and then mental health. I think it's twice as fragmented as I describe it, because social services report to other organizations. For us, we have the regional government in the territory and the city councils. So the municipalities, they all report to this both too. So twice as fragmented and a bit more complex when trying to move it forward, forward towards integrated care and health and social care. And there is this other challenge, which is sustainable
Well, what I mean here is we want new technologies, ICTs, and have them embedded into the delivery system. Because I feel this is the huge challenge that we will have, the largest, to be honest. And sometimes the demographic challenge somehow covers or hides these other problems that we, public services, will have to face undoubtedly in upcoming years. This fragmented system, or a system broken down into 3 levels, meant that as part of the chronicity strategy, that we try to move forward, trying to solve fragmentation through integration of different institutions. Specifically, we made quite an effort to try and develop an integrated healthcare organization, which is Birasoa, and that would be combining together a hospital and the outpatient clinics. So instead of having 2 different organizations, they would be just one. With this initiative, we were first focused on smaller regions, first Birasoa and then 3 more OSAs. But I would say that what's most important from a strategic point of view would be the decision by John Dagon, the regional minister, to move forward, to push forward this change for all of us, for OSAKIDETZA. The idea was to change it all as a whole, to have this integrated delivery of care, and not just limited to smaller regions or small outpatient clinics or hospitals. I felt this is quite a change that was adopted at the highest level for the Basque government. And then in 2013, some processes for vertical integration of organizations started as part of a slow but continuous process that lasted till some 2 years ago, where the healthcare system here in the Basque country was being transformed, starting from primary care and hospital organizations into 13 healthcare integrated organizations, as well as mental health, which also has some integrated elements, but it's not yet been fully integrated. At least we have not taken that step and have it integrated into OSAs. Probably that's the idea, keeping mental health services as a priority for our Basque government strategies. So this is a vertical integration model. This is a transformation model which purpose, ultimate goal, was to facilitate. This structural facilitation or integration was never the goal of the health department. The idea was rather to identify other elements, to avoid fragmentation in outpatient care and hospital care, avoiding or ditching classical problems such as resistance from organizations that actually need to converse and understand each other, so that they would adjust to the new healthcare system and the demographic challenges posed by aging and comorbidity. The how we did it, how we moved forward to facilitate integrated care, well, there were 3 pillars, so to say. First, we define integrated care as a concept, so it's a field definition, then a reference framework for its development, and then a roadmap to help organizations, integrated organizations, to move forward with integrated care. As a field definition, this is the one we chose. It could have been any, because there are so many, as you probably know. Well, we decided we were very much interested in this one, because the message was based on 2 elements we found were key. First, it is a collective project of collaboration amongst professionals who work on a care process and whose decisions are dependent. So whatever someone does has an influence on the results of the next professional, and especially the results of patients. And then finally, the next key word would be coordination amongst professionals. And this is a call for cooperation as part of the public healthcare system, but also with social services. So these are 3 key words that help us convey a message that Nuria referred to earlier on throughout all integrated healthcare organizations in the Basque Country. So as a reference framework, we decided to use this one here, which somehow highlights the three main elements or changes sought after by this model, delivery model. First, change in culture and values or mindset. So this is what's typical of a fragmented system, and now it should be a cooperation amongst professionals. Secondly, changes in the governance model in order to make sure that we have integrated care, and then focusing on population instead, so that we move forward towards the true essence of integrated care, which is productive interactions amongst proactive professionals, and proactive is the key word here, and patients that are more and more empowered and informed. And with all of this, patient would stay down at the lowest complexity level and with the best results possible. So it's a people-centered, patient-centered care. Third basic element here in the transformation model was a roadmap that would set out the changes that were needed as part of those components that came hand in hand with the program contract or contract program as a regulatory tool for planning in the healthcare department and the delivery system. So this is a tool devised for the deployment of integrated care to sign or point out the changes needed for clinical management, organizational structure, and so many other things that we've been working on in recent years. So, vertical integration in the Basque Country has had a purpose, a goal, that is facilitating integrated care. It's just been a methodology. Working methodology might not have been a radical change, as the one that Nuria mentioned, but it is significant enough in the way we structure services and delivery. And there are two driving ideas here for healthcare and healthcare model. First and foremost, this is a patient-centered care, but they are empowered. And this is also based on the cooperation amongst professionals to achieve the best result. And as part of this change, we have used several levers, and I guess throughout the conference there will be several interventions that will discuss them, but I like to highlight it now because then later on, well, I will show you a few more change levers. First, the political and strategic decision itself. I feel it was a decisive element for this bet on integrated care, and then message through that program in order to move the management towards several organizations and monitor and keep track of the change as well. Then the e-records, medical records, that way we could have that exchange of information amongst professionals, and that is also helping us use collaboration as a lever, so that we have that collaboration with social services as well as specific actions for patient empowerment. I guess this has been significant change in levers. And as part of this process, this idea of monitoring and assessment as another lever, another driver. It is so complicated as the development of integrated care itself. It is an assessment which nowadays I feel is not yet complete. We've not made enough progress in the way we assess integration, and yet there are three items I'd like to highlight. First and foremost, assessment of integration as an evolution of the healthcare system, a maturity of the system, and so within it we can have integrated care developed, and then performance assessment, an assessment on the results and the outcome of that integrated care system. I would say we in the Basque Country, we try to see whether we have a more mature system for the development of integrated care, and in that regard we can use those indicators that refer to performance and the healthcare system. But there are some other methods to approach assessments, such as maturity assessment for the healthcare system, to see to what extent it is mature enough in order to develop several integrated care actions, and as well as focus groups where we ask professionals how we are doing on progress. All right. As indicators, we have so many. Here we have some results that we are considering in the Basque Country. Well, in themselves mean nothing, but yet I've included here the most important indicator when seeing the result of integrated care, and that is how the rate of admissions has evolved when it has to do with outpatient care. So these are potentially avoidable. And in the Basque Country, there is a downward trend. And so since 2003 till current times, obviously, there's much to argue here to see whether integrated care has managed to achieve this result. As you can see here, on the graph, the trend stayed stable, but then without integrated care, the graph might have had same trend, maybe not, who knows. This is our problem with assessment, because we've changed the whole healthcare system as a whole, so we find it very difficult to have this comparison. Maybe in the near future, some other regions in the state might be used as a comparison, but it is true, though, that in other regions they're developing integration strategies. We could also discuss other kinds of indicators, such as the rate of readmissions to hospital, which indicate whether the patient, when they leave hospital, they are actually cared for in primary care. And as you can see, the evolution has been stable in recent years, which is not good nor bad in itself, because it is thought that, well, we have more complex and aged patients every time, so keeping it stable is not such bad news. Haven't found any changes in the reference center, or rather the rate of referrals from primary care to tertiary care, but it is true, though, that they've developed so many more contacts between well, rather online contacts for professionals, mainly because of these technological evolution. We've seen quite a change in the access to the health range of portfolio. That would mean an empowerment of patients in the Basque Country. Somehow, around 25% they are interacting with the system through the healthcare folder, and they can have information on care processes. We could keep on discussing indicators and performance, and that would give us the clues to see whether integrated care is getting the results to improve this kind of indicators. But I don't think that's the most important part. Probably what's most important is moving on to other kinds of responses and see how it's evolved in its maturity, and after a vertical integration process and working around integrated healthcare organizations. So it's been a long 8-year long process, and we need to know whether we have a more mature healthcare system now, which would evidence that we've moved forward in integrated care. Well, this maturity model can be a good tool. As you see, I've referred to the hard work of key people coming from 12 different countries, looking into the maturity of a system. That would be 12 key components. In itself is a good roadmap. I would compare it with the work we've done with the program, because it actually focuses on the key elements in order to make progress towards integrated care. And as Nuria said, we've been part of the Shiraka project with Gune, which is our research institute for healthcare services. We're actually moving forward in so many elements, and it could become another driving force in order to transform the healthcare system and keep on moving on towards research. And this is just the picture, so to say, that we got from the Shiraka project about the maturity of the healthcare system in the Basque Country. This is self-assessment by key players in the Basque Country, giving us an idea of the prep degree or the maturity in the Basque Country for the practicing or implementation of integrated care actions. So you can see it full, half or half empty. Well, I see it half full. We have a mature system well, sufficiently mature, that is, to move forward with integrated care. Naturally, this is just a recent picture. This is not where we started in 2010. I'm sure that this very same exercise back in 2010, the picture would have been closer to these beginning from scratch or back to this is square one, rather. So this is reason for hope, and I say that we are down the right path in integrated care. As for focus groups, let me highlight just 3 items, and I think it has to do with the very same thing, and this is just has to do with what we've been doing, and professionals say we've been doing. These were focus groups with physicians and nurses in both care levels. And they say that the electronic systems have been paramount for integrated care facilitation, and they also refer that the referral internist role that we've developed for the system, well, it's been 4 years now, and I would say that this is well recognized for its potential for integrated care, and they bring us down to earth as well, because the development of what I'm saying has not been equally done in every organization, and there are several approaches in primary care, which is a problem, because as said by Nuria before, this is basic for the development of integrated care, or one of the basic elements. Insofar, it should be driving the integrated care systems. Oops. All right. And, well, at this point, I will focus on complex patients, and I do it the other way around this time. We'll start with assessment and indicators, and then we move on to some ideas on how we've deployed it, what are the most important elements in the deployment of complex chronic patient care in the Basque Country. Indicators, just one, because I think it shows perfectly well the spirit of what we want for complex patients. We want those patients that at some point will have to be admitted. That's why they are complex. We want them most of the time to be nicely managed at the outpatient clinic, so primary care that is, and whenever they are admitted, they do so in a planned way, meaning that if you have a patient admitted in a planned way, making sure that there is no visit to the emergency department, because it's always complicated. For those patients, we have the professionals keeping an eye. They see whether there is any impairment, any changes, and they talk to the hospital so that the patient goes into hospital in a planned way for stabilization processes. This is what we've seen as an evolution, as a trend. I find it is important because it points out that we're doing things right with complex patients. Same way as before, I refer to the maturity of a system, and for longer now, it's been from the beginning of the first OSIS, we've looked into the maturity of different organizations when deploying these Wagner model, because we find this is a reference in order to work all 6 elements highlighted by the model. As you can see on the screen, with several assessments, we've enlarged this web or network as part of the organization. This is one single organization. This one is OSAKIDETZA, and how they move forward in the management of chronic patients and how much they've learned along the way as the years gone by. And as far as people-centered care is concerned, and so focus groups I refer to, how important medical records are, and internist as well, there's 2 elements, maturity of the system and indicators as the one I've shared. And we see that it has to do with the deployment of strategies for chronic patients. Well, all those approaches cannot highlight the wealth and variety of experiences developed in all 13 healthcare integrated organizations in the Basque Country. I dare say there are 13 organizations, and we had 13 different integrated care programs for the management of complex patients. And this is another pulley for change. With this framework and the program, but top down, we have this idea of changes and structural changes and what was expected. But then bottom up, the other way around, we got local initiatives, very interesting ones, helped us understand as a group. How am I doing on time? Well, I brought 2 experiences here, highlighting common elements. Not all experiences, not all 13 integrated plans include those elements. Well, they do in some cases with a greater or lower deal of intensity, but I would identify them as common. First, stratification of population in order to identify complex patients, which is based in the case mix of the outpatient care rules. And we've been working with that since 2018, and it simplifies those patients or identify those patients that are most complex in the system based on looking into their experiences, previous experiences in the healthcare system. Then we have clinical stratification, and so clinicians let us know as well. Well, rather that's a computer that has not been able to identify. And the other way around, they would say that some patients identified by the stratification system are not as complex as we could think a priori. Stratification on the one hand, and then new roles, professional roles. And here, let me highlight the referral internist physician, and then the case nurses and the liaison nurses. This could be further discussed. But these are new roles, helping us understand, do things differently as well. By building those assistential pathways, collaborative and sharing-based, and especially patient-centered, with first-level and second-level professionals. Then there's these shared elements, and is the fact that we have customized care plans and a single medical record registry, including prescriptions, which is very much appreciated by professionals because it makes transformation of the care process easier. I had 2 experiences. I bring 2 experiences, well known. The first one, Care World Project. There were 6 organizations, one of which was Control. And this highlighted how important systematized approach of complex chronic patients is. With all those common elements developed systematically, we realized we could reduce the rate of admissions in a statistically significant percentage, and we could bring down the number of admissions in those that had to be admitted. Oh, it won't go? Well, this is p-value. And so it somehow highlighted that there was a larger burden or payload for GPs, contrary to all other professionals. But with the other experience, I will explain why. So, this is about experiences for complex chronic patient care, showing it is important as long as we reduce the number of admissions. And let me say that the control group was not doing as we were doing back in the 2000s. And it had customized, rather integrated care, which was modified as part of the OSA, but with a different approach, not the systematized approach that we were following. Then there's this other experience that I wanted to share, and it's been explained here. Vidasoa experience, another way of getting organized and having this complex chronic patient treatment with this unit for continuum of care, working with family doctors, nurses, managing nurses, and also social workers. Every internist at the hospital, well, they work with just one outpatient clinic, and every day with patients that had been admitted. and patients that are complex patients, again, outpatient clinics, and they are in touch with GPs on the phone, over the phone, and also face-to-face once a month. So another way of approaching complex chronic patient management, well, this is a different one, but very interesting as well. This is the assessment model that is a bit different from the previous one. The previous one was a control group and an intervention group, and here what we have is an experience before being included into this organizational model. Patients, if complex, well, here they had 334 complex patients, 456 admissions, and ones admitted to the continuum of care unit. And once we had all the resources to focus on their needs, the number of admissions went down to 336. So you see there is a favorable variation or a positive trend when it comes to these patients. Once, as it's been said some other times, once the patient is under our radar and we can meet their needs in a simpler way, in a basic way for primary care, that's where we need to work with patients insofar as possible. And this very same comparison gives us a different picture, a different snapshot of the payload for these primary care services. It is obvious that before and after working with the customized management plans, well, that's when the nursing services take up a significant role. The GP role goes up just slightly, but what really increases is the nursing activity for home visits and phone calls as well. This is an analysis. This is a before and after. Well, probably this effect was not noticed because the organization as control was already having a proactive activity on complex patients. This is another interesting result. So these are complex patients. Laura. So this is where we work together with the Basque Country, and this is another idea for change. So we move on from common element. So we're moving now to a common or shared roadmap for the whole healthcare system in the Basque Country. And so this would be a care pathway for patients with several diseases shared by all 13 integrated organizations. So best practices that we've seen in 2 organizations are now being scaled up to other organizations with these features. And so we define positions and roles for every stage along the way, and with these other kind of elements that are part of the intervention. Probably you cannot see with such a small print, but these are the different stages of the itinerary that we will now be scaling up to all integrated care facilities and somehow highlight the role of every professional along the care process. Just 2 more words on the main items here. First, we are at a turning point in the Basque Country because we see this change of generation. So we are very much interested in reinforcing primary care because that's the way to move forward, as I said before. And the next step would be having a care itinerary for all the institutions in the Basque Country. So next what we have to do is to develop individualized care plans that are part of the itinerary and scaling it up to all organizations. And we're talking with Clinicians as well. And I hope that as part of a conference in the future, we will be able to share the results. Thank you to you all.
Eskerrik asko. Thank you very much.
Muchas gracias.
Muchas gracias.
Iñaki, Nuria.
Amaya, didn't we discuss before that we said that there was a surprise, I think, no, today?
Sí,
yeah?
Es verdad, es verdad.
So,
venga, le pedimos.
It's true. Let's ask Roberto to come up here.
Oh, please. So thank you very much. Yeah.
Todo tuyo,
Roberto, welcome. Yeah, the floor is yours.
Buenas tardes.
Good afternoon. Good afternoon, everybody. It's a pleasure to be here. For someone like me who knows nothing about your subject, Bioef, the agency that is promoting innovation in the Basque Health Service, wanted to open an exploratory way, an innovation way with improbable connections that I represent here today. It's about the integrated care for oncological patients through a special pill. This conference, international conference, wants to go from an old health system that puts the illness at the center to a different model that puts the focus on the patient and the integrated care of that patient. But what else in the challenge that we try to solve today, the oncological patient? Is it possible to go from a patient-centered system to a person with cancer to the person-centered system with the whole life of the person living with a cancer? It's not a person with cancer, but a person living with cancer. In improbable connections, our motto is to hybridize, to innovate. We use arts, culture, and creativity. It's the engine of innovation in other sectors too. For transformation, for instance, in the health system too. Why not? This piece, this play that we're going to see now, is just a part of a whole process that takes various months. A group of people, or people who lived with cancer, from different positions, and health people, health personnel from various specialties. They have worked with patients and with a team of improbable connections in trying to identifying milestones. Both patients and professionals identify these milestones when living with illnesses and conditions. This hybridization can help us to improve the health system. They've done it with Tantaka. Tantaka is a very famous theatrical company in the Basque Country with under the direction of Eger Martin. He is the mediator with improbable connections. The procedure is necessarily heterodox. It's been an intense experience for all the participants in this experiment. I would like to thank them from the bottom of my heart. Thank you for your engagement. Nacho, Begoña, Carlos, Maite, Julia, Estíbaliz, Josefa, Anne, Mariasun, Elena. Correspondences is the name of this play that is directed by Mireia Gabilondo, and the protagonists are the people who lived with cancer or around cancer. And it's also played by Ainara Ortega, Quique Ruiz de Rada, Iñaki Salvador, artists and people from the professional world and health professionals. They dealt with cancer at some point in their lives or with their families. All the examples here are real. This is the fruit of the joint work. It's about drama. This is told by the protagonists of the stories. We all know that integrated care requires many commitments within our health systems, but it requires an active listening and not a hierarchical listening of people who are living through that disease or condition. Okay, relax, forget about your scientific criteria, and just, I hope that you will be surprised by arts in this case. Thank you.
memories that never die.
Hello? I remember when I got the news. I was listening to In My Solitude in my car radio. I was told, okay, we'll have to start with the treatment as soon as possible. The result of your tests has been positive. You've got cancer. The world just stopped. There was a deep silence. I couldn't speak, I couldn't think, I couldn't drive, I couldn't breathe. I remember I thought, maybe it's a misunderstanding. It's not true. Couldn't be true. Yes? Yeah. No, I can't on Wednesday at 8 in the morning. Yes, okay, I'll be there. Okay, at 8 in the morning, I'll be there. Thank you. Goodbye. I remember that at this precise moment in that car, I remembered that the favorite word of my father was bicho, thing. Everything that interested him was qualified as thing. What is this thing for when he saw the Thermomix? Oh, these big things, what they do now when he saw me going up the street with my electric bike. When I had to give him the news that he had cancer, I told him they discovered a thing in him. What thing? He asked suddenly. He was alarmed. Oh, my dad, it seems that it seems it's cancer. Oh, that's not a thing, he said. That's the thing. I remember so many things. I remember it was a fantastic day, beautiful day. It was on the 1st of April, and we had appointment with the oncologist. Lander was my boyfriend. He was 26 and he had cancer. On the 1st of April, we knew Josefa. I remember that Lander and Josefa had the same kind of T-shirt, striped T-shirt. Josefa told me that we had to start now with the treatment as soon as possible. Josefa had a very sad smile. I remember when we got out of hospital, in the corridor we heard doctors talking. They were talking about Josefa. It seems that the day before it had a very hard day for her. 8. Yesterday, 8 patients died in her service. I remember that Lander and myself, we looked into our eyes and we got out of hospital holding our hands. And I remember that the day was still beautiful. I remember when I got to work, I wrote this letter to my daughters. Hi, girls. You wonder what happens to me, why I'm writing you this letter. I'll explain it to you. As well, we speak on the phone every day. We listen to each other, but now I would prefer you to read what I want to tell you. I never told you until now, but I was going through several tests and I had the confirmation that I have the thing. Well, let's kill it. Next week, I'll start with therapy. I hope you will come to see me and we will laugh before anything. After the first therapy, I will explain about chemotherapy. But I'd like you to know that you give me so much strength. We'll have to go through difficult days, difficult moments, but we'll have very good days and very good moments too. And I want you to know that I'm going to take advantage of this cancer as much as I can. I remember that after the first chemotherapy sessions, Lander and myself, we went for a weekend to Galicia. And Lander, without saying anything, he wrote this postcard to Josefa. Dear Josefa, I send you this postcard to tell you about my mood. Explosive, as you can see on the postcard. I feel strong, I feel calm, and everything is thanks to you. I know you will say no, but I can tell you it's true. Thank you for everything. And also remember the day I met Nacho, my chemotherapy colleague, and he said to me that morning he had written to me a text message, but he never sent it.
Querido compañero de quimio.
Dear chemo pal, I know that you're sad and you're afraid. You just got a terrible piece of news that we normally associate with death. Some moments you'll be very irritated. You'll feel so sad. At other moments, you think that all that you've been told is in fact a lie. At the beginning, all these tests will be so strange to you. You don't know anything about medical treatments, cycles, red tape, terms. Maybe you think that the consent I just signed is much worse than the cancer itself. Just take advantage, enjoy and readjust your mind to the new situation. I know it's complicated, but I still try to do that. I remember that very often I was called that I was courageous, that I was winning the war, that I was a champion. But the only thing I felt was that, in fact, I was following a treatment that was working okay for me. It wasn't my merit. I had no strength. I couldn't even walk. I didn't understand why people could say that I was winning a war. I remember I thought, if things are not going okay, I will collapse, but because it's my fault. Lander refused to use war words. He told me, against what I have to battle, what fight, what war. The only thing I do is to live, to enjoy every day. Days are so short for me now. A month ago, I read in a newspaper an interview to a boy that had a cancer. He said, I don't want to live with fear, but sometimes I say bullshit and I'm really afraid. I was in hell. I became aggressive. I was so bold. I was irritated. I only could watch Chuck Norris's films. Shots and more shots. And my wife asked me, Carlos, are you okay? Oh, yes, of course. I wasn't shot. I'm still alive. I'm still here. Oh, I said so many things, stupid things. I remember it was a very hard autumn. And I said, shit, I can't do that. I can't stand that. I'm fed up with that. And I remember an embrace. I wanted to cry, but I couldn't do that with my family around. One day, I went to see my GP, and I just collapsed. With no announcement, suddenly I was sitting there, and I was crying like mad.
La doctora entendió.
The doctor understood. She came up to me, she took out the stethoscope and she embraced me in silence. She hugged me and I was crying in her arms. And she told me, look, if you feel sad, if you're irritated, if you're in anguish, please tell me, I can help you. We have a team of psycho-oncologists. If you feel unbalanced by cancer, we need to balance you back again so that curing your cancer is easier later on. You will do that? Will you tell us about your sadness? I remember at this moment, I was able to timidly smile. It wasn't mixing shame, crying, tears, and everything.
Fresco y curado, claro y feliz, y te digo voy al bosque para aliviarme de ti. Sabes que dentro tengo un tesoro que me llega a la raíz. Pero si un día me demoro, no te impacientes, yo volveré más tarde. Será que la más profunda alegría me habrá seguido la rabia ese día. Asesino de niños, la rabia se me ha podrido el cariño, la rabia madre, por Dios tengo frío, la rabia es mío, eso es mío, solo mío, la rabia bebo pero no me mojo, la rabia miedo a perder el manojo, la rabia hijo tierra, la rabia dame o te hago la guerra, la rabia todo tiene su momento, la rabia el grito se lo lleva el viento, la rabia el oro sobre la conciencia, la rabia coño paciencia, paciencia. La rabia es mi vocación.
Pero también recuerdo.
I remember also this routine test in my health center. I was reading a magazine and they said that in 2050 science will or would cheat death. Well, why not? I remember I thought it's a pity I'm not younger because I would like to be there in 2050. It was my turn. Oh, hi Kike. How are you? Yes, well, okay. I feel tingling on my hands and feet. It's a strange sensation. Can you describe it? I don't know. I'll explain to you. I feel like it was a champagne bottle and that somebody has agitated before opening it. Don't worry, it's normal reaction of chemotherapy. It will go away. Okay, let's do the test. Listen, you think I'll be alive in 2050? 2050? Maybe I won't be there in 2050. Why? Well, just read a scientific article saying that in 2050 we'll be immortal, that will cheat death. Immortal? Oh, that's boring. But don't read that. Don't believe it, because they're just total bullshit. What you should do is not to forget to take care of your mind and your body, and you'll be alive. Thank you. I remember that one night we were having dinner and Lander asked me, when people ask me in the street, what do I have to say to them? Okay, this game, the Rubik's Cube, has accompanied our son Nacho and myself in many difficult moments. When I was alone waiting for the test results, for the CT scan, I couldn't read anything. I couldn't understand what I read. I just could listen to music. A valse, please.
Por las noches.
At night, many nights, I go to my balcony. I go out. If I look towards the south, at 30 degrees west, I see a woman. She writes on a table. I see her from the side. And some nights there's another woman with a strange kimono. And she brings her a tea. And the two of them, they laugh, they talk. We protected ourselves against bold questions or awkward situations. Time goes by and both ways are still open. Hope and the end as a great fright for us. The hospital is our second home. It's a long time since I can't see the woman with the kimono, but the writer, that lady, is still there writing on her table. Sometimes she walks and she puts on the kimono of the other woman. I remember when future started to dilute, and Lander told me, the future doesn't exist, Ainara. Everything happens now. I thank from the bottom of my heart what life tells us about the cancer. We speak about our plans, our dreams, and death was there. It was another character in our lives. Does it exist? Are we souls inhabiting bodies? And we speak about our last desires, our last wishes for the future. Maybe I could have an accident myself. I could be dead tonight. And Lander told me, oh, I don't want to be alone. And I remember Josefa's words. Dear Lander, I would have liked to live with you longer. I don't know how much time is left for you. I don't have a ball to read the future. What we try to do is to have you in the better situation possible, without pain, without anguish, without anxiety, close to your people so that you can say goodbye if you want, that everything is left closed for you at the end. It was a pleasure to accompany you. You've been a very good person and a very good patient. You'll be in my memory, and I'll have affection for you until the end of days. See you soon. I kiss you. Lander died on the 11th of August. I remember it was a beautiful day, and I put a lot of flowers in my hair to say goodbye. Seeing the beloved dying is a mixture of cruelty and beauty, so difficult to express. I put makeup on my eyes because I knew that he was going to see me from where he was, I don't know where. And I remember I sang this song.
Que me ha dado tanto. Distingo de quebranto, los dos materiales que forman mi canto y el canto de ustedes, que es mi propio canto.
Un 11 de agosto.
It was August the 11th, and I remember it was a beautiful day. I was walking along the city, and all of a sudden, I found something unexpected. Different people dancing around. They were dancing tango. They were tangoing. And then I thought, cancer is to be sung as a tango. It's desperate and tragic, with some effect, shocks, tension, stress, and so much sadness in the voice.
Pero conviene bailarlo con alguien.
And yet you need to dance it with someone. English people say, so it takes two to tango. Yet I would say more people should dance together. Cancer is a fucking tango. You need to dance it as if it were a folklore dance. The more, the merrier. And I yet recall thinking, best partner to dance to cancer was my doctor. My doctor was such a wonderful dancer. No fear of physical contact, looked me in the eye, guiding my steps. I just had to be taken away, carried away. She had everything she needed in psychology to adjust to any partner, clumsy as they could be, because I was one of them. I was so clumsy. And yet I danced. And what's better, I'm still dancing.
Lizardi, rimbo etorri duk, itaz galdezka eta gu ere ire zain geundela esan zioagu, ezin zela aspaldi azaldu etxetik eta belatzean eseri gaitu denok, erlojuak janez, baina mezularia bidaliagu alosko torrera, eskilara luzetan, beleak usatzen, oteintzen ikustezan, gero kanpaiak entzun dizkiagu. Zakorrak zaunkaka, orduan sortu aiz bidetik balantzaka, eta irekin aurrez aurre. Jarri garenean, zerraldo erori aiz gure oinetan, eta gorpu gogorintzen. Udazkenaren tronoan, ertsi dizkiagu begiak adiosik ez, eta goizaldean, musika zur batetan sarturik, opetipoet pirotekniarik gabe, lurperatu bagu baratzan Lizardi. Rimbo etorri duk, itaz galdezka eta gu ere ire zain geundela esan zioagu, ezin zela aspaldi azaldu etxetik Lizardi. Rimbo etorri duk, itaz galdezka eta gu ere ire zain geundela esan zioagu, ezin zela aspaldi azaldu etxetik.
Vámonos, salir. Y aquellos hay que sacarlos. Quietos aquí.
Welcome, everybody. Thank you for joining us for this session on co-designing care for integrated care. We're going to hear from multiple perspectives from different countries around the world and different perspectives. My name is Jodine Goldhar, and I'm chairing this session. I come to you from Ontario, Canada, and I come from the Change Foundation in Ontario, Canada. And our focus is on co-designing the answers to integrated care with patients, users, and their families. So I am especially honored to chair this session today. I also come to you from the International Foundation for Integrated Care, where I'm the Senior Associate for Canada, and it is a privilege and an honor to be here. A couple of items before we start our presentations. The first is that we are being live streamed. So those in the audience, we are being joined virtually by many different people around the world. So I would like to welcome those in the room and those that are joining us virtually. Welcome to our session. The second is that we are very active on Twitter. Please join us on Twitter, both those who are joining us by live stream and those in the room, and use the hashtag ICIC19. Our approach today is each presenter who has joined us will speak for 15 to 20 minutes, and then we will open it up for questions after each presentation, and then we will close with a common discussion together. So again, I welcome you, and I'd like to ask our first presenter to join us, Lucia from Italy.
Thank you very much. My name is Lucia Ferrara, and I'm a researcher at the Cergas Bocconi University in Italy, in Milan. And I'm very glad to be here with you. And I will present some of the first findings of a research project we are working on that is engaging the patient with HCV and NAFLD-NASH disease. And this is a case study of 10 healthcare organizations in Italy. First of all, I want to put some quick information regarding the backgrounds. Over the last decades, we all know that increased attention has been placed on measuring and improving the health care and the experience of patients. And patient experience is considered as one of the 3 pillars of quality in health care, alongside clinical effectiveness and patient safety. But if we look at the literature, we can see that there are several definitions of patient experience. In this context, when I mention patient experience, I refer to the patient experience is in a healthcare context, is formed during the moments when the operations, that means the health service and the consumer, meet. But first of all, I want to talk about different definitions, because I will mention them during my presentation. We refer to patient experience, as I've already said, when we talk about the interaction that patients have with the healthcare system and the experience of patient that is created when they meet with doctors, what is the experience of patients relating to their healthcare plan and their and the relationships also with other facilities. But we also talk about the patient journey a lot, that is the series of encounters and consecutive events or steps, that means activities, interventions, staff interactions, as perceived by the patient. So it is the integrated care pathway, but from the perspective of the patient. We also talk a lot about patient engagement. In this case, we refer to the process of building the capacity of patients, of families and caregivers to self-care, so to take an active role in the management of their own care. But all this putting together, we want to talk more about what we call as patient involvement. That means to go a little bit further and to consider the active participation of patients in the healthcare decision-making process. So, regarding this, when we talk about chronic patients, we know that chronic patients are people who have multiple encounters with the healthcare system. They see a lot of healthcare professionals, they see a lot of healthcare settings, and they move around all these settings. And so their experience is central to gain the real patient experience of the patient. So when we're gaining a clear and a real patient experience of the patient in all their journey around the different healthcare settings, it is important to go from the symptom onset, so when there is the diagnosis of patient, till the end of life. So to consider what is the real patient experience of the journey, of the patient journey. So what is patient journey mapping? What we are trying to do with this project is to map the journey of patients in regard of the healthcare organizations. And this is beneficial both for providers and for patients. For providers, because it makes the care continuum continuous. Because we all know that breakdown in communication between providers due to geographical, technological, or network problems can cause gaps in the overall outcomes of patients. Mapping the patient journey is also beneficial because it means to close the loop. We always talked about the communication breakdowns, but also we need to talk about unmet expectation. Many times we don't know what are the expectations of patients, and we don't clearly clarify what are the expectations regarding also the complete healthcare process. And also, this means to continually improve this system, because it means to collect data about the real patient journey, but it's not only important to collect data, it is also important to understand what the data means and to review the data periodically to improve to go from best to better and better in care for patients. But patient journey mapping is also important from the patient itself, because it allows the patient to stop the care silos, because we always talk about fragmentation in care, and so it is important to let visible to the patient what are the blind spots, and to see that silos have a negative impact on patient experience. It means also to guide the patient expectation. Many times we learn that patients often don't know what is supposed to happen next. So the great fear for the unknown, the confused instruction always bring to lack of adherence. But it is also important to understand what are the pain points. That means to are the problems along the way, and these are also opportunities for the organization to improve the care process. And finally, it is important to emotionally connect with patients, to empathize with them, with their journey, to shine light on how they feel regarding the patient journey. And so, putting this as a background for our project, the main aim of our project is to gather information on the real patient journey of patients with two diseases that are HCV and NAFLD-NASH. I will explain in 1 second because we decided to focus on these two diseases. And also, at the same time, to identify what are the strategies to engage patients in the decision regarding their health. So to have a patient involvement strategies, to involve always the patient in the definition of the healthcare system. As I said, we decided to focus our attention on two disorders. On one side, the hepatitis C virus, that is a very known disorder that affects from 1% to 3% of the world population. It's an acute disease, but most of all is a chronic disease that can lead to major problems like liver disease and liver cancer. On the other side, we decided to focus to a not really known disorder, that is the non-alcoholic fatty liver disease. In this case, we are talking about a disease that is really unknown from the patient, and we estimate that from 30 to 40% of the USA population are affected by NAFLD or NASH. And the risk factors are the obesity. In this case, we estimate that from 30 to 90% of patients with obesity may also have NAFLD-NASH, but they are not aware of this problem. And also is a major complication for type 2 diabetes. If for hepatitis C virus, we have a therapy that completely changed the patient journey. We do not have a therapy at the moment for NAFLD-NASH, and the only things that we have in our hand is only the behavioral therapy. So we are studying what is the real patient journey of patients in 10 healthcare organizations in Italy that were selected in order to cover the national territory and also to cover several institutional settings. So we have local health authorities, but also hospital trusts and also university hospitals. Just to see what is the difference in the process in the real patient journey, depending on the institutional setting. We're using a mixed methodology, and we're employing a customer experience mapping in order to understand the journey of these patients. When I talk about mixed methods, I mean that we are using working groups with professionals, but also workshops. We are analyzing the local documents. We are doing focus groups and interviews both with professionals on the one side and with patients on the other side. And we are going to distribute a survey to patients and caregivers to understand what is also their feeling regarding their patient journey. So what about the working groups? We decided to create two kinds of working groups that put together several professionals. I mean all the professionals involved in the integrated care pathways. So we have clinicians, but also we have GPs, we have also the patients, just to understand what is the different point of views from the different shareholders and stakeholders involved in the process. This is a broader project that will last for 2 years, and we are just at the beginning of the process. And what I'm going to share with you is the organizational analysis and the integrated care pathways that we are mapping with the professionals and with the patient. This is a project that will last till almost the end of 2020, and this is part of an observatory on chronic disease and primary care that Cergas da Bocconi were running in Italy. So what are we doing in our process mapping? We are mapping the patient journey that is a visual representation, and we are using the flow chart to understand what are the processes, what are the interaction with the organization, what are the activities, the entrance and the exit points. And we divide the process of care in 3 major episodes of care that we call diagnosis, treatment, and follow-up. For every single episode of care, we try to understand the 5 W. That means who are the professionals involved, what are the activities and the decision, the organizational routine, when, in which moment of the journey people are involved, where, that means in which setting, why. That is what is the main aim to reach for each procedure that we do. I will show some examples that are our results in this moment. I will focus on 2 models of care that we are discovering. If we look at this slide, we have a first kind of model of care where there is a consultancy role from gerontologists. So if we look at the screen, we can see that there are several the patient has several comorbidity, and we have several professionals involved that they are taking charge of the patient. But the process is really fragmented, is in silos. And then we have the gastroenterologist, that is a specialist, that acts mainly as a consultancy role. But in this model of care, we don't see any correlation, any coordination between the professionals involved. I will show you another model that we are discovering with the focus group with professional and patient. That is what we call the referral model to specialist professionals. In this case, we have the involvement of GPs, outpatient setting for first contacts and also for diagnostics tests. And so many professionals are involved at the local level. But then we have a specific referral with specific protocol between first level and secondary level specialistic center. And in this case, there is a clear owner of the process, a care manager that is the gastroenterologist, who take charge of the patient and follow the patient during the journey. What are the results of this analysis? First of all, we can say that in every context that we are analyzing, there is not an integrated care pathway available at the local level. There are some form of collaboration and cooperation among several actors, but not a formal integrated care pathway. This is a simple method that can be used to map the patient journey, both from patient and professional perspective. It is useful to identify the professionals involved, the results involved, but also the gap in the integrated care pathway. We call this a smart model that is simple, that is measurable, achievable, result-bounded, and time-bounded. That means that it's a model that is simple and replicable by any organization and hospital trust who wants to know more about the organization and the patient journey of the patients involved in their process of care. But there are other questions. What is the role of different professionals involved in the process? We can see that more fragmentation is linked to poorer communication and coordination among providers. And so as I presented you 1 second ago, I was talking about two different models. And we can see that there is a clear correlation between the models of care, how professionals interact, and how patients are feeling about their own care. There are several breakdowns in communication from primary level to specialistic level, and this causes absence of reference contact, and this causes absence of continuity of care and lack of care plan adherence. But the major questions, and that is important also in this session, is where is the patient? Because we cannot find explicit strategies of patient engagement and patient involvement in all the hospitals and all the local health authority that we are mapping. But we know that the engagement of patients has a central role in the change process within healthcare organization, especially in defining the integrated care pathways. So what are the next steps, and what I want to point out as a discussion also for you? Another point before going to the discussion, because we know that there is an innovation for ACV patients. We know that 80% of patients are known, and among those who are known, 90% have been already treated. But there is the 20% of patients who is completely unknown. What can we do with this kind of patient? How can we involve them just to follow up the process? And on the other side, we have the NAFLD-NASH patient. I'm using the image of an obesity person because they are happy, they feel okay, but they don't know to have a problem with their liver that is suffering. So what are the discussion points to conclude? Healthcare organization, we are considering how to consider and taking into account the patient perception, patient preferences, and expectation. On the other side, the experience of patient could be a driver to implement operational and strategic model to redesign also the integrated care pathways. And finally, there is a growing need also to develop some strategies to involve the patient in the decision-making process. Thank you very much.
Yep. Thank you, Lucia. Wonderful, excellent. Lucia really spoke about her findings, here, come join me over here, of not yet seeing it in local communities and integration where patients' voice is engaged as part of the process. Let me start with the first question. That was my timer, I apologize. What is your best advice to all of us around how to move forward?
Mm-hmm. Yep. My suggestion is it's also what we are trying to do with the focus group is to involve the association of patients as the voice of patients. But what we discovered is mainly for this kind of patient, for example, I will use the example of HCV patient. Those who are unknown in this moment are people who have, we can consider them drug users or sex workers. So it's also difficult to involve them. But we can use the association, we can use these GPs, we can use the territorial level just to involve them also in redesigning the process of care and see what's wrong, what's the process, what are the pain points, what can we do best to integrate them and to consider their point of view in the comprehensive strategy with them, I would say.
Thank you, Lucia. An opportunity to hear from groups that have already engaged patients and their families to help inform. What about for anyone in the audience? Do you have any questions for Lucia? Thoughts, reactions, anything you'd like to add to what she said? Okay, wonderful. Well, a warm and big thank you on behalf of everyone in the room and everyone who's joining us virtually. Thank you. Before I move on to our next presenter, I also want to share with you that our translators are supporting us today, and you'll see that the presenters are speaking in different languages and all supported by translation, so a special thank you to our translators. For those that are joining us live stream, I'm not sure there's translation, but we're super happy that you're here, and I saw on Twitter that people on the live stream are already commenting that they're enjoying the session and that they're engaged, so thank you to those who are joining us online. That's wonderful. Next, I'd like to welcome Estibalis. I hope I pronounced it relatively well. And I'll turn it on for you. Wonderful. It's okay. Welcome.
Okay, thank you. Okay, thank you very much. Bueno, yo voy a hablar en castellano.
I will be speaking Spanish. I hope it's not a problem for anybody. I hope that you all have headsets. My name is Estibaliz Gamboa, and I'm in charge of the Active Patient Program at OSAKIDETZA, the public healthcare system here in this region, in the Basque Country. And I would like to tell you a little bit about the self-management program among equals, the online program that we have set in motion here. Self-care is basic for chronic patients, which is why in 2010, to face the challenge of chronicity, this program was launched, the active patient, in the Basque language, Paciente Bizia. We decided to work with a program designed by Stanford University, and we started with a pilot in 4 different healthcare organizations. After that first stage, one of the conclusions was that the methodology had to be adapted and customized to our own culture, our own communities, and ever since then we have our own methodology. What is the Active Patient Program? Well, it's a program for self-care so that patients with chronic pathologies and their caregivers can benefit from it. This is a program where the leaders of the workshops and are chronic patients or their caregivers. It's a program led by peers or equals. It's a peer-to-peer program. And apart from helping them with basic facts and information about their pathology, we also help them be proactive. We give them facts and information, but we also train them to do something with that information. And why did we decide to run an online program? Well, when we started working with the program back in 2010, we found that a good number of patients couldn't attend the meetings for the workshops, because of their duties, we tried organizing workshops both in the morning and in the afternoon, but even so. Also, our region has some remote rural areas with sparse population, so organizing workshops there was logistically harder. There are certain pathologies as well where there's a huge social stigma, so some patients don't like attending workshops and being known to suffer from that particular pathology. That's why we decided a remote online program might be suitable. The main challenge was making sure that this program, which is based on practice makes perfect, a practical program with peers as leaders, as role models for other people to follow through persuasion, how could that be made successful in an online format with participants all in different places? Because we wanted a workshop that made people feel satisfied, that was practical and useful, and also making sure that the final outcomes were as good as we'd had in the face-to-face workshops. We decided to work with a company, Vively, that had been working with Stanford University for their online program. So a number of us at the Basque Healthcare Service, Public Healthcare Service, OSAKIDETZA, had meetings with this technological company, and we started with some pilots in 2018. Originally, we had a target figure of 200 patients. In the end, it was 223 patients who originally enrolled for the online workshops. But that figure came down to 193 before the workshop was finally organized. Then 88% of the 193 patients who were sent their username and password. As I was saying, 88% of those 193 patients accessed the workshop at least once. So those would be patients or caregivers who had participated even at least partly. A total of 69% of them attended 4 or more sessions that we organized and covered all the tasks and activities they were asked to do. That graph shows that some 24% of patients were lost on the way. They dropped out, and we had been warned by the technological company that that was quite normal. That was to be expected. Vively knew and warned us. So I'm just telling you this, some 20-25% of the people who originally enroll or say they're interested will not fully follow the program. Just look at those figures. We've managed to bring down the average age of participants by 9 years. Why is that good news? Well, because we want to recruit those patients, chronic patients who are younger and who have not deteriorated over the years, because in the face-to-face workshops, the average age 62, whereas the online course would have an average age of 53 years of age. and there's a gender difference as well. More women doing the online workshops than the face-to-face workshops. And the bar chart at the bottom of the screen shows how most of the people who enrolled in the online workshop are people with higher level of education. This probably means that people who socially are more disadvantaged will probably not access the online workshops either. That's probably a very difficult barrier for us to overcome. At the end of the workshop, participants were sent a satisfaction survey, and some 45% of respondents said they were chronic patients. Over 40% were caregivers, and some 5% of respondents were both caregivers and patients, chronic patients. And then some 77% of the people who took the workshop were not chronic patients or caregivers, were just people who were interested in that particular pathology. 14%, sorry, of the total. We have there people with cardiovascular disease, muscular, skeletal problems, cancer, respiratory pathologies, well, a bit of a mixture there. In the satisfaction survey, 86% of respondents told us that at the end of the program they felt much better prepared to face and cope with their pathology. 83% of the patients really valued the fact that it could be anonymous. You could have an alias. You didn't necessarily have to enroll with your real name. You can imagine that when they posted comments, whether it was fears or doubts or facts, that's probably quite useful for somebody to just speak honestly without the fear of being judged. That's why we have that very high percentage. 83% of them valued it very highly. Some 4.15% out of 5 is the score for usability of the platform. Why? Because it's very intuitive. You don't need to know very much about IT to use it properly. And then we've also identified a number of areas for improvement, which we will do. But it's a very simple platform, really, for users. In our process, we wanted co-creation to be present. So together with Vively, the OSAKIDETZA, the public health care service here in the Basque Country, has been working not just with Vively but also with participants.
So we asked them to help us, and we talked to them to see what they had improved. We talked to participants to see what they wanted us to improve, and we've also carried out some focus groups in order to see what improvements participants would implement. Now, one of the things where we can improve is the action plan. Action plan to make it slightly longer, to extend its duration. The different forums where participants were able to share experiences, they wanted it to be more chat-like forums. They also said that there should be more interactions in the forums and more deeper interactions, being able to talk about feelings, for example, emotions, more information about food and diet, and that they should be professional as well, participating in the group, someone who you could ask questions to if you didn't know something, if you wanted more information. Now, what were the achievements? Well, they talked very positively about responsibility, co-responsibility, assuming the co-responsibility for their own health. They had increased their awareness of their disease, their knowledge of their disease. They said they felt healthier, they had more positive thoughts, they had improved their habits. They said that they were able to manage stress better, and they were more consistent with regard to their everyday habits and routines. And if we look at the sort of spiritual side of things, they also said that they felt much better in themselves. So, as key points of the co-creation process, we've identified the following ones. The anonymity was very important, because that meant that participants felt that they were able to express themselves more freely. The training can be used for people with any type of pathology. So we can actually reach out to many patients using different structures and without actually having to make them travel. So in fact, and the workshops can be done simultaneously as well, because you can actually do more than one workshop at the same time, because you can do it from the comfort of your own home. It is scalable. You can reach out to many different patients. With regard to the platform, now we've seen throughout the entire process, both with our work with the technology company and then our work online, that we can improve different tools and different technologies in order to become more efficient. So that's important to do that, to maintain the platform. We've also seen that it is both sustainable and transferable. We were a little bit concerned about whether the online format was going to be the same as a face-to-face one, because when you're meeting face-to-face, there's some kind of climate, a feeling as complicity is generated between the participants, which really helps the process along, and it helps the exchange of information and knowledge. And we were worried that that wasn't going to happen in the online program. But in fact it did. The mean age has been lowered, and in fact the scope is broader. So that's the good news for everybody. Thank you very much indeed.
Sorry.
Thank you so much. It was excellent. I'd like to start by asking the first question. The way we engage people is changing online. What is your best advice to us, to the audience in the room and those that are joining us through live stream, around how to start to engage with people through virtual online?
Bueno, a ver.
Now, a priori it is more difficult. It is more difficult to get participants to connect up to us, to connect with us. So here, the work carried out by the facilitators is very important. The work carried out by the people who are actually running the workshops. The fact that participants need to feel listened to, not judged, the fact that they are free to express their opinions without anybody judging them for it. If they do that, and also mutual support from their peers. All of this really helps participants to become involved and engaged in the process and to maintain their work in the workshop. Thank you very much.
In the room, do you have any questions? Any thoughts and reactions? Wonderful. A special thank you.
Thank you.
I'm okay. You're going to do? And now I'd like to welcome Joe from Edinburgh in Scotland to join us. Welcome, Joe. It was already here. It's okay.
Good afternoon. My name is Jo Thompson. I am a critical care research nurse, and I would like to talk to you today about the SCARF project. I have worked clinically as a nurse for 8 years, 5 of which were in intensive care, critical care, and for the last 5 years I have worked in research. So we have been running SCARF, the project, for the last 15 months. It is part of the Edinburgh Critical Care Research Group and the University of Edinburgh. I'm going to share some key outcomes, how SCARF, the project, started, and what the project is and what our plans are going forward. So some key outcomes before we start about the project. Provisional reports from the project, which we have ran for almost 1 year, show that we have reduced readmission rates from intensive care back into the hospital by 10%. We have found that our assessment tool is finding the patients who are most at risk for readmission back into hospital. And we have established really good communication lines with the integrated joint board hubs within Edinburgh to improve communication outcomes for our patients. The SCARF project is putting into practice some research which was found by the profile study, Preventing Early Unplanned Hospital Admissions Following Critical Illness. And the research team was by Dr. Naz Lone. And what we found, some of the findings from this were that there was 140,000 patients admitted into UK intensive care units each year. And in Scotland, that meant that there were 30,000 patients admitted to intensive cares within Scotland. And out of that 30,000, 70% survived, creating a cost of nearly £50,000 per patient per year. And as part of this research study, they found that within 90 days, 25% of these patients were readmitted back into hospital, not intensive care, but back into hospital. And within 6 months, 40% of patients were readmitted. Another part of the findings of the profile study was PICS, which is post-intensive care syndrome. And this is a gathering of symptoms that a patient who survives intensive care might experience. And they categorized them into 4 main groups of symptoms. Psychological symptoms, which was anxiety, depression, and PTSD. Some physical symptoms were muscle wasting, fatigue, weight loss, joint pain, stiffness, and impaired mobility. There was cognitive symptoms of amnesia, delirium, cognitive impairment, and social symptoms. Many people returned to work late. There was money concerns, reduced social participation, health and well-being of carers was an issue, as well as relationship strain. Surviving intensive care is no small accomplishment. It has massive consequences for patients and for family members. And actually in America, they have PICS-F, which is post-intensive care syndrome family, because a lot of carers and family members experience social disruption and depression as a result of their loved one having been in intensive care. So we see that there are massive factors that are associated to unplanned readmissions, and part of the profile research discovered that there was 10 main factors that contributed to a readmission of a complex intensive care patient, and there were patient-level issues and system-level issues. And so we have on patient-level issues, we had multimorbidity and polypharmacy, psychological problems and drug dependency, fragile social support, problems with specialist equipment at home, user-friendliness related to that, and poor mobility. And then the system-level issues was preparation for hospital discharge, communication or lack of between acute and community care, psychological support, medication support, and goal setting. So these were 10 main risk factors that they found from survivors of intensive care who were readmitted. And what they discovered was the more of these issues that each patient had, the higher the risk of the patient being readmitted back into hospital. Some readmissions are avoidable and some are unavoidable. And our goal was to try and find the avoidable readmissions and prevent them. So some examples from the profile research of potentially avoidable readmissions were drug-related. medication errors happening in polypharmacy patients. And what we discovered was that patients who were discharged into hospital who had polypharmacy issues, maybe had medications changed, but their pharmacist wasn't updated of these. And so old discharge scripts were given, and the patient was then given the wrong medication and was readmitted back into hospital with more complex health issues. We found mobility was an issue with falls at home, and mobility aids weren't always delivered in time for the patient being discharged, and they maybe had to wait a week or 2 weeks, but within that time they maybe fell or suffered injury which was preventable. Carer support was another area. Sometimes a carer may have been absent due to work or holiday or unforeseen circumstances, and this precipitated general collapse, possibly not eating properly, not medicating properly, whereas a simple package of care could have prevented another readmission. And medical support, not enough support being given for medical care. We had issues of nephrostomy bags being blocked or Hickman lines being infected because proper support wasn't given. So all of this research led to the development of SCARF. And what we wanted to do was we wanted to learn from research that was done and then put into practice and try to integrate a new pathway to support survivors and reduce readmission rates by improving communication and support, and thereby improving quality of life for patients and carers. Our goals starting the project were to have quicker and better feedback to healthcare providers from the acute setting into the community setting, and to improve community recovery of intensive care survivors. We also had a goal of reducing early unplanned readmissions by 20%. So this is our general pathway that happens for the patient whenever they're admitted into intensive care. My job is to assess all the patients who come into intensive care through an assessment tool, which I will shortly show you. And whenever a patient goes on to our assessment, between myself and our administrator, we will email their GP, we'll find who their pharmacy is. We have made contact with the integrated joint boards within Edinburgh. They are a collection of multidisciplinary team members based in the community, and we will speak to the family. And we will alert the health professionals that this high-risk, complex patient has been admitted into intensive care, and there is a high chance that their care outcomes will have changed upon discharge. Whenever the patient is then discharged to the ward, I go and visit the patient, introduce myself, as well as giving some basic information about things they might experience post-discharge from intensive care. And that is learning from the PICS syndrome that patients might experience different systems, as well as giving support, but also trying to find what their social engagement is like. What support do they have in place, and what extra support might they need whenever they go home. Then, whenever the patient is discharged, we email the GP, the pharmacist and the hub a shortened summary of the patient's stay in hospital and intensive care. And on top of that, to the hub, we will give a breakdown of any additional needs we think that this patient might require going forward, and if they're able to meet that. Aside from that, on discharge, we also try to support the family member going home. We offer third sector support and try to signpost to maybe counselling or other areas of support that the family member might find. In 2 and 8 weeks post-discharge, we do a follow-up with the patient where we call them to see how they're getting on at home and if they require any extra support. And it has been known that on the back of that, I've contacted the hubs again requesting extra support for the patient to try and keep them at home so that they're not readmitted back into hospital. So this is the assessment tool that we're using at the moment. And what we're trying to do is learn from the 10 key areas that we saw with patients earlier. And so we want to see if they had multiple admissions within the last 12 months. We wanted to see if they had more than 4 comorbidities, creating a complex patient. We wanted to see if they had polypharmacy issues, if they had a history of mental health, substance misuse, were concurrently on antidepressants or psychiatric medication, if they required additional significant help for activities of daily living pre-admission, if they live alone, and what their general demographic is. And all this information we want to know prior to admission to hospital, not what happened in intensive care, which creates a different pathway. What we generally found actually was that our patient group met two different kinds of cohorts. We had our complex medical patients who were comorbid and polypharmacy, and then we also had our mental health patients who generally had history of mental health, substance misuse, and were on complex antidepressants. So the impact that we have found as a result of this has been multifold. We've had patient has felt more supported, they felt heard and understood as a result of conversations. Often having that simple conversation with a patient post-ICU helps them to realise that the symptoms that they're experiencing are normal, and that is also through the use of the discharge sheet that we've provided. And part of my job has been to signpost to counselling or to our intensive care support group that we have running for patients, which is called ICU Steps. For family, they feel seen and heard. We had a situation where a brother was really concerned about his brother and was able to give us information, which meant that the patient was retained in hospital for longer because it exposed a really extreme social circumstance which would have led to a readmission. As well as system impact. As a result of this study, we've realised the incredible need for counselling for not just patients but for family, and we have begun to integrate a counselling service for the entire intensive care department for patients, relatives and staff to try and support people better through the intensive care experience. So progress to date has been that we are 10 months into the project. We have had 235 patients. Our PDSA cycle has revealed that we have a very high percentage of substance misuse and serious mental health patients that accumulate approximately 30% of our cohort. And these patients are incredibly hard to follow up. And an interesting finding was that changed the pathway of our project. So we had to create a separate pathway for these patients as they were proving incredibly complex. Our assessment tool is identifying the patients who are readmitting back into hospital, which is a really encouraging sign. We have made contact with 14 hubs, 7 integrated healthcare hubs and 7 mental health and substance misuse hubs. Our provisional reports have shown that through this project we have reduced readmissions by 10%. And our next step going forward is that we will be looking for an NIHR grant for a larger scale intervention within the southeast of Scotland. I'd like to say a special thanks to Health Improvement Scotland for funding this project. Eddie Donachie was our project manager, Dr. James Marple was our clinical lead, and Julie Fenton was our administrator. Many thanks for listening.
Thank you so much, Joe, on behalf of everyone in the room and those that are joining us through the live stream. I have a question for you, and then I'd like to open it up to the audience to see if anybody else would like to ask anything of Joe. Given that you have such a unique role, from clinical practice to research, and now meeting individually with the patients and their families, what are you most proud of?
I think I'm most proud of being able to impact the patient as an individual on their journey and realising for the patient that they're more than a system, that they have complex needs within them, and being able to meet those needs for the individual so that they feel seen and heard, and hopefully the plan for keeping them home and reducing readmissions, I think, is something that has impacted me the most.
Isn't that amazing? When we talk about integrated care, we talk about it ultimately from the perspective and experience of people and their families, so that people and their families experience multiple part of our health systems and the people in it paying attention to what's most important to them and helping link our different parts of our health system from the ICU to the community to primary care together. And it sounds like that's what you're doing, and you get to do it directly with people and their families. So congratulations. I think that's great. What about for anyone in the audience? Do you have any questions, thoughts, or reactions for Joe? And she'll also be available, I'm sure, after. Okay, thank you so much, Joe. Come join us. Yeah, you are very slow. Sorry. Phone's off, I believe. Okay. I'd like to welcome you. We're going to do a 5-minute poster presentation, and then we'll open it up to any final comments. Welcome.
My name is Ingela Job, and I'm a PhD student at Luleå University of Technology in Sweden. And I will, sorry.
It's okay.
No,
it's not
so,
right?
Oh, it should be the beginning. I don't know. It moves by itself.
It moved by itself?
Yeah. Sorry. I will present a study from the northern part of
Voy a presentar entonces un
explore active older persons' perceptions of healthcare services and preferences of factors related to care planning among active older persons. And this is the coordinated individual care planning that take place in the primary healthcare setting or when a person is discharged from the hospital. 40 participants between 70 to 88 years of age from 6 different patient and seniors associations participated in 5 focus groups discussions, and the data was analyzed using a qualitative interpretive framework. The analysis resulted in 4 themes: collaboration and continuity, participation and involvement in decision-making, individual need for support, and access to information and services. The participants questioned the way healthcare services were organized and expressed lack of continuity. They wanted to be active participants in decision-making and wanted more flexibility regarding decisions and the possibility to change the decisions. A majority were not aware of this coordinated individual planning, but they thought it could be beneficial for them if they would need help and support from the primary healthcare and social services. A majority of the participants did not have access to internet, but they did not resist the new technology and stressed the importance of not excluding anyone. So these are some quotes. We need an organization that really works so that people do not fall between the shares. It has gotten worse. There are no permanent general practitioners at the health center anymore, only temporary staff. And you never know who you will meet. And you have to narrate the whole story each time, even if they have the medical journal. They have no knowledge about you. I want to participate in the decisions. I do not want them to make decisions above my head. When we need planning, we will not be this confident, and we will not be able to express what we need and want. You want to be respected as a person and listened to. Today, people are not respected, and all the time you have to beg for what you are entitled to. More and more information is on the internet. For me, it's okay, I'm just old. But when you are ill, it's more difficult. But for relatives, it could be useful. So our conclusion is that older persons want to be active partners in healthcare and social services, and they value a personal relation with a practitioner, and easy access and well-coordinated and more personalized and flexible services. Thank you.
That's great. Thank you. What did you learn most about speaking directly with people and their families?
I think I learned most that there is a gap, because as many, I am working myself in the health sector, and we feel that we give a lot of information to people, but somehow they don't get all the information we are providing. Yeah.
Amazing. Thank you.
And, yeah.
Thank you. I want to thank all of our presenters today, and I'd like to summarize some of what I heard for all of us to take away, those of us in the room and those that are joining us by live stream. I had mentioned to you that I come from Ontario, Canada, and I work for an organization that believes the answer to integrated care is through the lens of patients, users, and their families. And one of the reasons we believe this, and I believe this, is because you heard from each presenter today, when you actually talk to somebody who's experiencing the care, the perspective is very different. Just like, why is it if we give information, users, patients, and their families don't always hear it? Or why is it that people are coming back to hospital after an ICU admission? Or why is it that so many people are participating online to build their ability to self-manage? We have so many questions. And the answer is with patients, users, and their families, because they experience multiple parts of our health system. They don't just experience their hospitalization. They don't just experience primary care or home and community care. They experience all of us in the health system, and they're very much impacted by our policies, our research, and our practice. And so the lens, understanding what's most important to people and their families, can really design a path for all of us. We heard from perspectives from Italy, Sweden, Scotland, multiple places around the world, which is so wonderful. What I find so amazing is that no matter where we're coming from, including the Basque Country, we have a common element, that what makes us most proud is when we affect real change in a person's life. Most people I asked, and you could hear, what makes you most proud is when you're able to help support somebody to improve their own life, patients and their families. I also heard that a lot of this work starts with engaging patients or users, but there is an invisible voice, that of caregiver or carer, family and friends that support patients and users, and that to get the full picture, you need the experience of both. So I want to send a very warm thank you to our panelists who did an outstanding job today, and to everybody in the audience. I want to thank our translators for helping us have this session in multiple languages. And I would like to thank those who participated through live stream. It is wonderful to be able to connect with people all over the world while we're physically in this room. That is a rarity, and we are grateful. So enjoy the rest of the conference, and thank you to everybody, and thank you to our speakers.
Yes,